Hello, check, check. Hello, 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 check. Hello, hello, check. Hello, hello, check. Hello,
কি ল্যাপটপ লাগবে নাকি?
hello, hello, check, check. Hello, hello, check, check. Hello, hello, check, check. Hello, hello, check. Hello,
বিভাজন আমাকে দিয়েছে, আমি দিয়ে দিয়েছি। আজকে আমার আনন্দ দাস
hello, check, check. Hello, hello, check, check. Hello, hello, check. Hello, hello, check, check. Hello, hello, check, check. Hello, hello, check, check. Hello, hello, check. Hello, hello, check, check. Hello, hello, check, check. Hello. Hello. हेलो
तो और रात में लगाया गया था सीवर वाला भी अच्छा
जगह कौन दोनों चालू हो
उधर वाला 35 है देखिए ऑन कीजिए बुझले ना आया नहीं है हाँ 32 है ये वाला है का
नीचे वाला दोनों वहाँ दे दे देखिए अभी आया
आ गया दोनों
हेलो हेलो चेक
Okay, Subro, now.
हेलो हेलो
হ্যালো হ্যালো হ্যালো
हेलो हेलो चेक हेलो हेलो हेलो
नाम बोलबो আপনি দেখিয়ে দেন
ये वाला को देखिए ऑन कीजिए दोनों ने हेलो हेलो चेक हेलो 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 चेक हेलो हेलो
Good morning, delegates. So today we are starting our scientific session with a very interesting topics or whatever session that we call it free paper session. All the papers will be delivered by our DNB PGTs of BR Singh Hospital. One and also we have one from Southeastern Railway and one for our orthopedics also, I think. So our judges are Dr. Shukubar Barik, an eminent gynecologist, Dr. Anandudas Chaudhary, our ex-HOD surgery of BR Singh Hospital, and Dr. Bhaskar Ghosh, another eminent neurologist of Kolkata. So the candidates will be given 4 minutes to deliver their talk, and after that the judges will ask them questions related to their topic for 2 minutes. They will be given marks 25 for presentation, 50 for the content, and 25 for the question and answer. If they exceed their time of 4 minutes, it will be deducted from their presentation. So I'll request all the participants to stick to their time. And we have three prizes: first prize, second prize, and third prize. So without wasting any more time, I would like to call Dr. Annesha Das Ghosh to deliver his talk.
Good morning, I'm Dr. Anvesha Dashghosh, presenting my paper, a comparative study on oxytocin versus carbitocin in prevention of primary postpartum hemorrhage after childbirth. Introduction. Postpartum hemorrhage is nightmare even to the present obstetricians. Primary PPH is defined as loss of more than 500 ml of blood in case of vaginal delivery and more than 1000 ml of blood in case of cesarean delivery within 24 hours. The most important cause of PPH is uterine atony due to poor contraction of uterus after delivery. WHO currently recommends active management of third stage of labor by uterotonic agents to prevent PPH. Oxytocin, which is a nonopeptide with short half-life, mean 3 minutes, and short duration of action, is the current standard of drug which is used in management of third stage of labor. It is susceptible to heat. Its efficiency cannot be assured in many developing countries where access to cold chain transport and storage is unavailable. Oxytocin 10 unit is charged in 1 bottle of fluid after the delivery of the baby, and another 10 unit will be given in next bottle of fluid as a maintenance dose to keep the uterus in contracted state. In contrast, carbitocin, which is a long-acting synthetic oxytocin analog, has been widely used in preventing PPH, and heat-stable carbitocin has been shown to maintain in active state for more than 36 months at 30 degrees centigrade. It has a half-life of approximately 40 minutes, 10 times longer than oxytocin. It does not require maintenance dose. Injection carbitocin 100 microgram is dissolved in 10 ml of normal saline and will be given as slow IV route. Here we will study the safety and efficiency of oxytocin versus carbitocin in prevention of primary PPH after vaginal and cesarean delivery. Objectives: to compare the amount of blood loss within 24-hour post-delivery, blood pressure 5 minutes after the drug administration, urine output 24-hour post-delivery, atonicity of the uterus and need of other uterotonic agents, and side effects of the drug. It's an institution-based randomized control study in B.R. Singh Hospital. Study technique: 154 people were screened, out of which 120 were enrolled, including the exclusion criteria. Oxytocin, out of which 60 people received oxytocin, out of which 27 underwent vaginal delivery and 33 underwent cesarean delivery. 60 people received carbitocin, out of which 28 underwent vaginal delivery and 32 underwent cesarean delivery. These are the steps one by one. Consent of the patient taken, age, parity, period of gestation, hemoglobin and BP before delivery noted. Either oxytocin or carbitocin is administered after the delivery. SBP and DBP is measured 5 minutes after the drug administration. Blood loss is measured. In vaginal delivery, blood is collected in calibrated drip under the buttock till 1 hour delivery. C-section blood collected in suction container and soaked mops wet. Step 5, after delivery, mothers are given sanitary napkin 25 milligrams soaked. Napkins used for 24 hours are wet. Atonicity of the uterus is detected. Urine output is measured, and data will be entered in Excel and analyzed with statistical test. P-value less than 0.05 is considered significant. Results and observations. Bar diagram showing age distribution and mean age of participation in both the groups are comparable. Bar diagram showing parity and mean age of gestation in both the age group are comparable. These are the bar diagrams showing SBP and DBP before and after the drug administration. It was found that decline in SBP and DBP values at 5 minutes after oxytocin administration was statistically significant as compared to the initial value, while the difference was not significant in case of carbitocin group. Mean blood loss within 24-hour post-LSCS was significantly higher in oxytocin group 688 ml compared to the carbitocin group, which was 498 ml. And mean blood loss within 24-hour post-vaginal delivery was significantly higher in oxytocin group 408 ml compared to the carbitocin group, which was 261 ml. And incidence of PPH in both the groups were comparable, and the proportion of patients with uterine atony was significantly higher in the oxytocin group, 43.3%, as compared to the carbitocin group, 23.3%. Mean drop in hemoglobin was also significantly higher among those receiving oxytocin and compared to those receiving carbitocin, 2.1 versus 1.2 in LSCS and 1.8 versus 1.1 in vaginal delivery. The mean 24-hour urine output was higher in carbitocin group as compared to oxytocin group, but the maternal side effects in both the groups were comparable. Conclusion: carbitocin is hemodynamically better since oxytocin after administration causes more hypotension and drop in hemoglobin concentration after delivery. The total blood loss 24-hour post-delivery is less in carbitocin than oxytocin, both after C-section and vaginal delivery. The uterine atonicity is maintained well, and need of other uterotonic agent is less in carbitocin group than oxytocin group. So carbitocin is better in preventing primary PPH than oxytocin. The side effects of carbitocin are comparable. Therefore, here heat-stable carbetocin is better to use than oxytocin in terms of hemodynamical stability, uterine tonicity, decreased blood loss, and more half-life of the drug. Thank you.
Thank you, Anisha.
Thank you, sir.
I can't see you. If you just thank you very much for your nice presentation.
Thank you, sir.
Um,
Thank you, sir.
how you randomize these two groups? You told that this is a randomized control trial.
Sir, actually, total 154 people were taken for this study.
How you calculated the sample size?
Uh,
It's a RCT. How you calculated the sample size?
Sir, by the 4PQ by n square formula.
No, but have you just had to
No,
tell that sample size? Otherwise, you will not be able to distinguish because it is difficult. So, how is the sample size calculated? How the randomization is done?
sir, randomization is done including the exclusion and inclusion criteria.
No. After that,
Acha.
this is the patient.
Huh.
You have excluded the exclusion criteria,
Sorry.
inclusion criteria. After that, what is the process of randomization?
Sir, 120 people were taken out of.
How you randomized? It's
Which
a
patient you will keep in which group? How do you decide?
Yeah.
Sir, it was an. So 60 people were taken for oxytocin group and 60.
How
people.
you decide which 60?
It is as per your choice, or there is some sir is wanting to know, is there any other?
Sir, as per my choice, I took.
Then
That
it
is
is
not,
not
yeah.
randomized.
Because
is
two
not
patients may differ. That's why you cannot choose. That's the thing. You can choose good patient in one group, bad patient in another group. So it does not depend totally on your performance.
And the last question is that from my side.
Yes, sir. Yes, sir.
And have you got any international study on this one?
Yes, sir.
Which
Yes,
study?
sir.
Which study?
Sir, various articles I have.
No, not various article. Any particular article, because once you're going for a study, I'm sure before that you have gone through the literature that what has been done. I want at least one good study which is done comparing the carbetocin and oxytocin. Anything? Because I'm expecting that, isn't it, sir? I'm expecting that before you do a study, you have gone through the literature so that
Yes,
you
sir,
know.
I've gone to various.
Your study should be compared with some previous studies, and you have to show the difference, why this difference is there, or what are the similarities are there. That you should at least one slide you should protect.
Okay, sir.
Okay.
Okay, sir.
Okay. Thank you very much.
Thank you.
Thank you. Thank you very much.
So our next speaker will be Dr. Sandeep Shiv Puja.
Good morning, everyone. My name is Dr. Sandeep, Pediatrics PGT, BR Singh Hospital. And now I'm presenting a paper on maternal profile, outcome, morbidity and screening of extremely low birth weight, very low birth weight babies born in level 3 NICU in BR Singh Hospital. Objectives of the study are to evaluate the proportions of babies born via vaginal delivery and LFCS at different gestational age, to evaluate the incidence of different complications like apnea of prematurity, sepsis, necrotizing enterocolitis, etc. To evaluate the indications of emergency LFCS and maternal risk factors. To evaluate the proportion of babies that received resuscitation at birth, different modes of ventilative support, and different procedures. And materials and methods. It is a cross-sectional type of study in BR Singh Hospital over 1 year. 13 inborn units with birth weight less than 1.5 kg were taken into the study. In maternal risk factors, 3 mothers had preeclampsia, 1 has chronic hypertension, 4 mothers had hypothyroidism, 1 mother had gestational diabetes mellitus, and twin pregnancy, 7 mothers had twin pregnancy as maternal risk factors. And indications for LFCS are preterm premature rupture of membrane with severe oligohydramnios in 8 mothers, and severe preeclampsia in 3, antepartum hemorrhage in 3, and abnormal Doppler in 4. And period of gestation was less than 20, one neonate was born less than 28 weeks, and 6 neonates were born between 28 to 32 weeks, and 6 neonates were born more than 32 weeks. The birth weight, three neonates had birth weight of less than 1 kg, and 10 neonates had birth weight of more than 1 kg. And mode of delivery were 4 neonates were delivered by vaginal delivery, and 9 neonates were born by LSCS. And resuscitation, in resuscitation, 38.5% units cried spontaneously, and 38.5% units required initial steps of resuscitation, and PPV was positive pressure ventilation was required for 23.1%. And mode of oxygen support, 53.3% units were on HFNO, means humidified heated humidified high flow nasal oxygen, and 26.57% was units were on CPAP, 20% were on mechanical ventilation. And procedures performed were UVC was done for 9 units, PICC line was done for 2 units, and surfactant was administered for 2 units. In associated disorders, while they are in NICU during their stay, they have been evaluated for G6PD deficiency was found in 1 unit, and congenital hypothyroidism was seen in 1 unit, and inguinal hernia was in 1 unit. In complications during NICU stay, apnea of prematurity was the most common complication in 8 neonates, followed by NNJ in 6 neonates, and sepsis in 4 neonates, meningitis, neonatal cholestasis, ROP, AKI, septic shock, death, and necrotizing enterocolitis grade 1 was seen in 1 unit, and 2 neonates were presented with BPD. And hearing abnormality, all neonates were screened for BERA for hearing abnormality, and there was normal. Neuroimaging, USG cranium was done for all neonates, which was normal. And the conclusion of the study is, most common indication of emergency LSCS was PPROM with severe oligohydramnion seen in 61%. Most common complication was apnea of prematurity, followed by NNJ and neonatal sepsis. 80% of them received non-invasive mode of ventilation, that is HFNC and CPAP. Just 20% were on invasive ventilation. UVC was performed, most common procedure seen in 59.23% units, PAC followed by PICC, and surfactant in 15.38%. The associated disorders were G6PD deficiency, congenital hypothyroidism, and inguinal hernia. And mean stay in NICU was 38.4 days, and outcome discharged in stable condition where 12 neonates were discharged in stable condition. Death was death less than 750 gram 1 unit, and more than 750 grams 0 neonate. The survival rate of extreme low birth weight was 66.66% as compared to 34% in a recent systematic review evaluating the outcome of extreme low birth weight units in low and middle income countries, included a study of 192 studies. Survival rate of a very low birth weight was 100% as compared to 80% in a descriptive study from a tertiary care teaching institute in South India. Drawback of the study was small duration of the study, small sample size, and single hospital study. My references are, I have provided my references, 2 references. Thank you, sir.
Thank you very much, Sandeep.
Yes.
2-3 things. One is why you have clubbed the extremely low birth rate with very low birth rate, because the outcome is from the beginning should have been separated. That's one. And
result we have published separately only. Means in conclusion we have.
Yeah,
We have taken less than 1.5 kgs as
so
cutoff,
you have
sir.
already in the result you have separated it.
In result we have.
Okay, that's fine.
Yes.
Second, how many of these has received antenatal corticosteroids, and how many of them has received magnesium sulfate?
All of the only one neonate who came in labor didn't receive antenatal corticosteroids, sir. Means more than all the 12 were admitted before they were received antenatal corticosteroids.
And what about the magnesium sulfate?
Magnesium sulfate didn't receive magnesium sulfate.
None of them.
None of them.
Are you sure? Because at the current moment, if you have got time, as you know, why the magnesium sulfate is given?
To prevent pulmonary hemorrhage and intracranial hemorrhage in neonates.
Magnesium sulfate.
Yes.
Not corticosteroid. I'm talking about magnesium sulfate.
Magnesium sulfate. So is it too pre?
Okay, sir. Up to you.
So, what type of study you have done?
Cross-sectional studies, sir. Cross-sectional studies, sir.
Oh, 6 hours.
Yes, sir.
Okay. Okay.
Okay, sir. Thank you, sir.
I would like to have more resounding clapping after each speakers, they get encouraged. So the third speaker will be Dr. Sagar Pushp, DNB PGD Surgery.
Good morning, judges and all the delegates present here and all my colleagues. So today, myself, Dr. Sagar Bush, PGT of the Department of Surgery, and today I'm going to present a case on Mickel's diverticulitis presenting as an intracutaneous umbilical fistula, and it's a very rare presentation. So Professor Mickel described the diverticulum in 1809, and it's defined as a congenital proximal part of unobliterated vito-intestinal duct, which is single through arising from the anti-mesenteric ileum, having an independent blood supply from the superior mesenteric artery. If you look at the embryologically, at the end of the 8th week of gestation, incomplete obliteration of the vito-intestinal duct causes the Mickel's diverticulum. Mickel's diverticulitis is the inflammation of the Mickel's diverticulum, which is the most common congenital structural abnormality of the GI tract. So in our case, 55-year-old man presented with a purulent discharge from the umbilicus for the 3 days, which preceded by the sudden onset of dull aching periumbilical pain. Our patient didn't give any history of similar complaint in the past. So if you look at this image, the swelling was present in umbilical region with the erythematous skin. And in the next image, you can look, there's small fistulas opening over the umbilicus and oozing pus with fecal matter. So we did various investigation, and what positive findings we got? We got neutrophilic leukocytosis with the raised CRP. We did the USG, which shows a well-defined fluid collection below the umbilicus in subcutaneous plane, approximately 2 centimeter in the 2 centimeter. We also did the CECT abdomen with the oral contrast, shows an intracutaneous fistula between the umbilicus and small intestine. So firstly, for the first 2 weeks, we did the conservative management like regular dressing, care of the skin, and broad spectrum IV antibiotics. However, after the 2 weeks, it failed to relieve symptoms and inflammatory changes around the fistula. So finally, we did the exploratory laparotomy. So you can look at these images. We found this Mickel's diverticulum having the opening, and we did standard Mickel's diverticulectomy and excision of the tract with closure of umbilical tent from inside. The patient was discharged on the 7th post-operative day in stable condition. So after post-op in biopsy, we confirmed the Mickel's diverticulum containing all 3 layers of the intestine, having no ectopic gastric or pancreatic tissue. So we'll see this case. It mainly becomes symptomatic only when it's get complicated. Case is reported as rare at this stage because mainly it's happening less than 2 years of age. Incomplete obliteration of the VI duct results in intracutaneous fistula at the umbilicus. If we look at the complications, the most common complication is the lower GI bleed, and other complications include the band obstruction, intussusception, and the diverticulitis. In our case, the tract infection explains the local sepsis, and a USG CECT were useful diagnostic tools. And if any case presenting with the lower GI bleed, the investigation of choice should be the technetium 99 per technet scan, that is the Meckel scan, and CT angiography are also helpful. So diverticulectomy and excision of tract produce a satisfactory results. Thank you.
Definitely, it is a very rare case. But what should be ideal treatment of this infection and associated small intestinal lesion? Only diverticulectomy.
So in adults, they mainly present with the pain abdomen.
It is a very infected case.
Yeah. In infective case, if it's diverticulitis, then we'll check it. We'll do the operation, and if there will be the wide base or wide mouth of the Mickel's diverticulum, we'll leave it. And if there is any narrow base or narrow mouth and unhealthy epithelium, so we'll go for standard diverticulectomy.
Only.
Yes, sir. And repair of that defect.
So is it a rare case or a rare surgery you have done? What is your opinion?
It's a rare case only, sir.
So
Because
what's the incidence, or do you have an idea that how many patient presents with this enterocutaneous?
sir, less than
fistula?
2%.
Less than 2% of mecal diverticulum.
Yes, sir.
Sir.
Which incision you used for this? For exploratory laparotomy?
So we did the midline incision below the sternum to the tail umbilicus.
Mhm. Okay, this infected urachal cyst also mimics like this.
Yes, sir.
How you could differentiate? Anyhow, the CT scan what you have done and the technetium 99 scan, that was the one which clinches the diagnosis of
If there will be, sir,
metastatic
if there will be any ectopic tissue in the mecal diverticulum, then we'll go for if there will be upper GI bleed, ectopic gastric tissue, then we'll go for mecal scan. Otherwise, CCT with the oral contrast will be the good investigation.
Because when the symptoms are related to gastrointestinal systems, it is more of Meckel's diverticulitis rather than urachal cyst.
Yes, sir.
Okay.
Thank you, sir.
Yes, that sounds better. So we have our fourth speaker, Jhilam Basu, Dr. Jhilam Basu, DNB PGT surgery.
Good morning, judges, my seniors and my colleagues. I am Dr. Jhilam Basu and I'm here to present a case of subacute intestinal obstruction in a case of primary idiopathic sclerosing peritonitis, which is also known as abdominal cocoon. We know that intestinal obstruction can be of acute or subacute types, of which subacute intestinal obstruction, it implies that there is an incomplete, intermittent, or a recurrent intestinal obstruction, which usually presents to us with features of abdominal pain, distension, vomiting, and absolute constipation, which means there is passing of no flatus or feces per rectum. Intestinal obstruction can be categorized as dynamic or adynamic, depending on its causes. Dynamic intestinal obstruction, the causes of which are fecal impaction, bezoars, strictures, malignancy, intussusception, volvulus, band adhesions, and hernia. Adynamic causes are paralytic ileus and pseudo-obstruction. Abdominal cocoon, however, is a very rare cause of intestinal obstruction. In this picture, we see the cocoon belonging to a monarch butterfly. A very similar structure occurs inside of the abdomen due to chronic intra-abdominal inflammatory process that leads to a fibrous tissue formation, as we will be seeing very shortly. So what is an abdominal cocoon? An abdominal cocoon is described as a total or a partial encapsulation of the small bowel by a thick, white, fibrocollagenous cocoon-like membrane that forms a second abdominal cavity. Sclerosing encapsulating peritonitis can be classified according to its etiology and pathology as primary or secondary, whereas we do not yet know the cause of primary SEP. Secondary SEP is most commonly associated with tuberculosis, mostly in developing and underdeveloping nations. Next, we come on to the radiological features. Computer enhanced tomography or contrast enhanced computer tomography or CECT scan is the most important radiological tool that we have in our hands for preoperative diagnosis of this condition, which shows clumping of small bowel enclosed by a soft tissue covering located at the midpoint of the abdominal cavity. Barium study, which has become obsolete now owing to evolution of CECT, it used to show cauliflower sign, which was concertina or serpentine-like arrangement of the bowel covered by in a U-shaped fixed structure. An abdominal ultrasound will show us the classical sandwich appearance, which is dilated bowel loops encircled by a membrane, hypoechoic membrane. Treatment. Treatment is basically adhesiolysis and surgical release of the entrapped bowel loops. Fibrous capsule is resected out completely or to the greatest extent available or possible without causing any extra damage to the gut. In SEP, Due to long-term peritoneal dialysis, management is by stopping of dialysis, nutritional support, and surgery. In tubercular SAP, preoperative ATT may negate the need for surgery altogether. We present a case of a 42-year-old gentleman with no prior history of abdominal surgery or other significant comorbidities who presented to us with sudden onset colicky epigastric pain, which gradually progressed to diffuse intense abdominal pain over 2 days and multiple episodes of vomiting. He had past history of progressive loss of appetite and early satiety and incomplete bowel clearance for last 1.5 months. There was no history of significant weight loss, fever, prior similar abdominal pain, or contact with any other TB patient. On clinical examination, the abdomen appeared distended. There was mild tenderness in the right upper quadrant and a vague, palpable, soft intra-abdominal lump in the supra and the right para-umbilical region. This is the slide showing the CT scans, axial and coronal views. After initial resuscitation, exploratory laparotomy was planned and proceeded. Intraoperatively, we found a fibrous sheath encapsulating the small bowel in a cocoon-like manner. The entrapped bowel loops were released surgically and partial resection of the fibrous tissue was done. There was a mass found in the jejunum with 5 centimeters margin. We resected the mass. Post-operative was uneventful and tuberculosis workup yielded negative results. In conclusion, we know that abdominal cocoon or primary idiopathic sclerosing encapsulating peritonitis is a rare occurrence presenting as an acute or a subacute intestinal obstruction. Etiology of primary is unknown. Secondary is associated with tuberculosis, also with other intra-abdominal inflammatory conditions. Diagnosis is usually intraoperative. However, we can diagnose preoperatively with the help of CECT. Treatment is usually with surgical release of the entrapped bowel loops and removal of fibrous capsule. Thank you.
You give the diagnosis of tuberculosis.
No, sir. Our tuberculosis workup came back as negative. It
What
was
are the
not
other
tuberculosis.
causes?
Sir, other causes are like sarcoidosis. It can be cirrhosis of liver, continuous long-term peritoneal dialysis. Then, sir, cirrhosis of liver, asbestos exposure.
What was the cause in your case?
Sir, it is, we are diagnosing it as primary idiopathic. We do not know the cause. Yes,
So
sir.
idiopathic sclerosing peritonitis.
Yes, sir.
So is it associated with other systemic features like involvement of the other organs?
Sir, in our case, there was no other involvement.
So can you name one disease which is associated with this sort of presentation like pancreatitis
No, sir.
and also some pituitary involvement?
Sir, Men's syndrome.
Have you heard the name of IgG4 disease?
No, sir.
No. So I think IgG4 should be excluded in this case.
Okay,
You
sir.
please go and study. Huh?
Yes, sir.
I've got a small suggestion. If you're presenting a case,
Yes, sir.
introduction should not be that big.
Okay, sir.
You came to the case much later.
Yes, sir.
Present the small introduction,
Okay.
larger part of the case, and little bits conclusion. So
Yes.
that will be a good thing to do.
Yes.
Please.
When this case was done,
Sir, it was around December.
are you following it up?
Yes, sir. The patient has gone back home. Yes, sir. We are following him.
The cause you told is idiopathic sclerosing peritonitis. So that is, it is known to cause recurrent fibrosis. And these are the patients who go for recurrent intestinal obstruction.
Okay.
So you require to follow it up.
Okay, sir.
So just because in one attack you have done with and be done with it, so probably it may not suffice. So you require to advise the patient accordingly.
Yes, sir. Okay, sir.
Thank you.
Thank you, sir.
Our next speaker is Dr. Kiran Vaidya, DNB PGT Eye, Ophthalmology.
Good morning. So I'll be presenting a comparative study on a comparative study on efficacy of intravitreal injection brolucizumab and aflibercept as management in diabetic macular edema. So diabetic macular edema is the most common cause of loss of vision in diabetic patients all over the world. And brolucizumab and aflibercept are both anti-VEGF drugs that penetrate the dense cellular network of the retina to prevent the growth of new blood vessels. We can see here that the molecular weight of aflibercept is about 115 kilodaltons and that of brolucizumab is 26 kilodaltons. So with brolucizumab, we get a smaller molecular weight and a higher molar dose, leading to higher drug concentration in the retina. The aim here was to study and compare the effects of aflibercept versus brolucizumab in patients of DME and to compare the visual outcomes and the changes in the central macular thickness in both groups. It was a single-centered randomized prospective comparative case study carried out in our department for 15 months in 60 eyes. All patients above 18 years with diabetic retinopathy and macular edema having central macular thickness more than 300 microns were included in this study. Any patient who had active infections, patients with glaucoma, or having received previous intravitreal injections, or having any other retinal disorder or cataract were excluded from the study. These were the baseline ophthalmological investigations that were carried out. Once the investigations were done, the patients were grouped into two groups. Group A received 3 doses of intravitreal injection aflibercept at 6 weekly intervals, and Group B received 3 doses of intravitreal brolucizumab at 6 weekly intervals. Follow-up was done on 1st, 3rd, and 6th month with assessment of the ocular parameters. OCT was repeated on 1st, 3rd, and 6th month. These are some OCT images of before and after injection. So this patient had before injection visual acuity of 6/36 and a central macular thickness of 467 microns. After completing 3 doses of injection, he had 6/12 vision and 246 microns central macular thickness. The patients in my study group mostly belong to the 60 to 70-year age group, and the male to female distribution was equal in both groups. On comparing the changes in the visual acuity at different intervals, we saw that the results in both groups were comparable. Also, the central macular thickness reduction in both groups was also seen to be comparable. So the final conclusion was that the efficacy of brolucizumab and aflibercept were comparable in terms of both visual acuity and central macular thickness reduction. These are the 2 landmark trials that have been conducted for brolucizumab in treatment of DME, and both of them concluded that it had excellent visual and anatomical improvements. But the main concern remained that is the risk of inflammation and vasculitis associated with these anti-VEGF injections. So the most important things that I'd like to conclude with is that aflibercept and brolucizumab have comparable visual outcomes, but the side effects of intravitreal anti-VEGFs like intraocular inflammation need to be informed to patients beforehand, and also the need for repeated dosing need to be explained to patients. These are my references. Thank you.
Is there any exclusion criteria or inclusion criteria of both groups?
Yes, sir. For my study, I included all diabetic patients with macular edema, and they had not received any prior treatment for diabetic macular edema. And apart from that, if they had any other retinal disorder or glaucoma or any other infective or inflammatory conditions, then also they were excluded.
And the drug used is randomly.
Yeah, these were randomly, the patients were randomly divided into these 2 groups, Group A and Group B.
How the randomization was done?
So simple randomized.
Same question I'm asking. How the randomization was done?
Simple randomized, like chi-square.
No, that's the analysis. Randomization, process of randomization. Because please try to understand, when you are presenting a study, RCT is a very high level of study. Case presentation is here. Case series is here. You are talking about RCT. RCT is one of the highest level of evidence. So when you are talking about RCT, you should be very careful about the study protocol.
Process of randomization,
Absolutely.
what should be the
Selection
sample size,
criteria,
everything you have
process
to
of
tell.
randomization.
So
Okay.
what's the necessity of comparing these two drugs?
Actually, the mechanism of action of these two drugs, both of them are anti-VEGF drugs, but it has been seen that since brolucizumab has a smaller molecular weight, so the drug penetration is more and the effect is seen faster. The visual outcomes are seen faster. So we wanted to compare if this has any better outcomes than the previous anti-VEGFs that were being used.
Is there any bigger randomized control trial already concluded? One is better than other?
So no, all of them have found that their results are comparable.
Okay. Because otherwise, ethical permission will be difficult to obtain. Understand? If something is proven to be better, ethically you cannot do the study. Okay? Thank you.
Thank you.
I hope all rest of the persons who will present, they have already loaded their things over there. If anybody has not done it, do it right now. Our next speaker will be Dr. Nikita Minch, DNB PGT Pathology.
This is good morning, everybody. Myself, Dr. Nikita, PGT Pathology, going to present a case study of generalized lymphadenopathy. Case presentation. A 66-year-old male presented in medical department with fever, bilateral parotitis along with generalized lymphadenopathy for 7 days in the month of July 2023. He was having red patches in bilateral lower limbs and generalized itching. This is the picture. No prior history of any allergy or drug intake was found. After medication, his fever and parotitis subsided, and he was discharged with persistent cervical lymphadenopathy, for which FNA was suggested, and FNA was done from left-sided cervical lymph node, which yielded this picture, which is highly cellular smear showing predominantly a monomorphic population of partially degenerated lymphoid cells admixed with few large lymphoid cells, no granuloma or malignant cell was seen. The impression was possibility of chronic lymphoproliferative disorder. TB gold was negative. CECT face and neck shows both parotid gland, bulky and heterogeneous. Multiple cervical lymph nodes were also seen. Largest of them were also measured. An impression was cervical lymphadenopathy, bilateral parotitis. The whole body PET scan also suggested the lymphomatous involvement, of which biopsy was suggested. And in biopsy, we got the specimen of right-sided left cervical lymph node, which was having this picture in the low power view, having the complete effacement of architecture by diffuse infiltrate. And in high power, we have seen the lymphohistiocytic population mainly, which was large mononuclear cells with prominent eosinophilic micronuclei. We will discuss this picture later on. And in reticulin stain, also there was the effacement of normal architecture and increased vasculature. Impression was lymphoproliferative disorder, for which the following this ISC was advised. And in ISC, we have got the prominent CD expressing T lymphocytes, of which the T lymphocytes also expresses CD2, CD5, CD7, CD30 focal, and CD56 and 15 were not expressed. In situ hybridization of Epstein-Barr virus, RNA was positive in majority of the lymphocytes. This is the picture. In the GEMSA stain, it demonstrates an atypical large cell with abundant mitosis. The tumor cells are also strongly positive of CD3 positive, and the TCR gamma is positive, and TIA1 was also positive. The Epstein-Barr encoding region in situ hybridization is also positive. This is the impression. We have got Epstein-Barr virus associated lymphadenopathy, in which the predominant cell type is cytotoxic CD8 expressing T cells. The term EBV associated T and NK cell lymphoproliferative disorder is a systemic illness in which the Epstein-Barr virus infected T and NK cell proliferate clonally. This is a new entity. It was previously subsumed in the subtype under the entity of PTCL NOS. The cutaneous involvement is unusual, in which our patient was also having. This is also a newly recognized entity, is rare and aggressive, and it is associated with underlying immune deficiency, mainly in elderly patients with the median age of 61 years. And main predilection is also found. Clinical features are splenomegaly, in which our patient was also having B symptoms, pleural effusion, lymphadenopathy, and laboratory findings are thrombocytopenia, elevated serum lactate dehydrogenase, and anemia. This is the Epstein-Barr expression. At least 30% of the lymphoma cells are positive for Epstein-Barr virus. Positive stains are CD3 and CD8. And negative stains are CD20, PAX, and 79. And this is the molecular genetics. And differential diagnosis are this one. Our patient is showing good response with steroid. These are the references. Thank you.
Your patient presented with bilateral parotid swelling,
Parotitis with generalized lymphadenopathy.
generalized lymphadenopathy.
Yes.
So what are the causes of this sort of presentation? Common causes.
So commonly, we can have any chronic inflammatous lesions, in which normally there is lymphadenopathy is also present, and in lymphomas also, like B cell lymphomas, they are B cell lymphomas are also there, and for T cell lymphomas, we differentiate in the basis of immunohistochemistry.
So would you not mention about sarcoidosis, tuberculosis?
Yes,
I thought sarcoidosis at the first instance when you first
yes,
projected.
in the FNSC we have excluded.
Yeah, that you have excluded, but you
Thank-
should, when you are enumerating the
yes.
causes, actually
Yes,
you
sir.
should think of
Yes, sir,
more
yes.
common causes earlier than.
Yes.
Was there a patient presented with fever?
Yes, sir, fever.
And what there was sore throat?
Sore throat was not.
Sore throat was not
Not
there because glandular fever. So Epstein-Barr virus related fever is one of the causes of sore throat
Sore
associated with lymphadenopathy.
Yes, sir.
So if Epstein virus infection should be one differential diagnosis. So did they do this test, pulmonary test and all for excluding from the Department of Medicine? I want to say that they have done pulmonary test or antibody test for Epstein-Barr virus at the initial go.
Initial go, all the serology was done, which was not.
You are not aware that what was there.
Serology was done, but we have they have already excluded, and they have thought it's a simple thing. Actually, they were not.
Not considered
not
Epstein-Barr virus
considered.
at the onset,
Yes,
because
sir.
any patient presenting with fever and having cervical adenopathy at a early stage,
Early
within a few days, we should think of Epstein-Barr virus infection. It is not uncommon, actually.
Yes, yes, sir.
Yes, sir.
Thank you.
Our next speaker is Dr. Sushreta Bonik, DNB PGT Pathology.
Good morning, everyone. Today, I'm presenting the case detecting and diagnosing a rare breast tumor, a step-by-step approach. Basically, breast tumor is the most common tumor in the world, but few of them are extremely rare. Case presentation. Case summary. A 32-year-old lady had presented to the surgical OPD of the B.R. Singh Hospital with painful swelling in her upper outer quadrant of the left breast for 2 months and with nipple retraction for 2 weeks. There was no associated complete symptoms like fever, weight loss, generalized weakness, night sweat, etc. Patient did not complain of any nipple discharge or any lymphadenopathy to any other site of the body. HRUSG revealed of left axilla revealed multiple enlarged and necrotic lymph nodes along with diffuse subcutaneous edema of the left breast. She was urgently referred to the Department of Pathology for fine needle aspiration cytology. Cellular smears prepared from the aspirate shows that moderate cellularity and composed of loose sheets and clusters of atypical cells on a hemorrhagic background. Cells have scanty cytoplasm, mildly pleomorphic enlarged nuclei, vesicular chromatin, prominent nucleoli at places, and irregular nuclear margin. So these are all cytomorphological features were highly suspicious of ductal carcinoma of the breast. An excision biopsy followed by histopathological examination was suggested. We received the specimen of left breast of the patient along with level 1, 2, 3 axillary lymph nodes from Department of Surgery shortly after this report. Macroscopic findings, on grossing we got a huge mass almost 10 by 9.5 by 8.5 centimeter at left breast at 3 o'clock position. Mass was solid whitish homogeneous and had capsulated lobulations. The mass was involving the deep resection margin. Nipple areola complex was grossly uninvolved. An area of skin puckering noted at the 3 o'clock position. Total 9 lymph nodes were revealed from the specimens labeled as level 1, 2, 3 lymph nodes. Coming to the microscopic findings, multiple sections from the growth showed diffuse monotonous sheets of the discohesive tumor cells infiltrating heavily by the lymphoid cells. Mass was comprised of cells with vesicular nuclei, many binucleated and multinucleated form, and eosinophilic cytoplasm. Necrosis was present at many places. Mitosis 8 to 9 per 10 HPF. No epithelial cell cluster, TDLU or DCIS was seen. 2 lymph nodes showed presence of tumor cell in level 1 lymph node. So we made the impression hematolymphoid malignant tumor or round cell sarcoma. We went for immunohistochemistry for further diagnosis, and here is the result. Negative, the tumor cells stained negative for pan-CK CME vimentin, which excludes the chance of sarcoma, and TDT, MPO, CD3, and CD10, which negative. So it also excludes the chance of any T cell lymphoma. Here LCA, CD20, BCL2, BCL6 is positive. LCA and CD20 marks that it is a B cell lymphoma, and BCL2, BCL6 and MAM1 positivity makes it DLBCL, that is diffuse large B cell lymphoma of breast. Ki67 was high, 70 to 80%. So these are the pictures: CD10 negative, MAM1 positive, BCL2, BCL6 positive, and Ki67 negative. From above all the histological and IHC reports, we made the diagnosis as primary diffuse large B cell lymphoma of the breast. Coming to the discussion, primary breast lymphoma comprises of only 0.05% to 0.53% of all malignant diseases of the breast. The term PBL indicates that breast is the principal site, or in many cases the only site. Non-Hodgkin's diffuse large B-cell lymphoma is the most common histopathological subtype of PBL. There is bimodal age group distribution, 30 to 35 years and 55 to 60 years. Our patient comes to the first age group. The most typical sign is rapidly growing painless lump, and ipsilateral axillary lymphadenopathy may or may not be present. It can resemble inflammatory breast carcinoma, as because sometimes it expresses that nipple discharge, skin changes, etc. Clinical and imaging findings are non-specific and overlap with the malignant, even benign breast tumors. DLBCL has aggressive clinical behavior compared to the other subtypes. Most common site of relapse include ipsilateral and contralateral breast and central nervous system. Hans et al. Subclassified DLBCL into non-GCB type, which is CD10 negative, MAM1 positive, and BCL6 expression is not that much important. Non-germinal center B-type DLBCL is the most common variant and have poorer prognosis. Take-home message: as treatment modalities and outcome differs from that of breast carcinoma, adequate histopathological and immunohistochemical studies are mandatory for acute diagnosis. These are my references. Thank you.
Hello, this is a very rare case, definitely. I will manage.
The patient has got 6 cycles of chemotherapy, basically R-CHOP regimen, and followed by that they went for a PET CT, which shows nothing, no residual cancer cells in the body.
Prognosis?
Prognosis, sir, basically it is a non-germinal center B lymphoma basically. So the prognosis is not good, but our patient is okay. There is no other problems there right now.
Okay.
Pregnancy, the prognosis is not good, should not be the answer.
No, what's prognosis?
You have to say that the 5-year survival rate is this. The prognosis cannot be say not good, good, bad. It should be quantified that 5-year survival or 2-year survival rate is this. Then people will understand that what it means. Okay.
So how this patient presented? How long is she was suffering?
Sir, basically, the patient presented on June or July. She has a cholecystectomy operation on January, and she came to our OPD, surgery OPD, for the regular routine checkup. And at that time, she had the breast enlargement. 2
So
months.
you did not know 2 months, 2 to 3
months.
months. So the patient did not notice it for a long for this period.
No, sir. Actually, these things are rapidly enlarging cases. So time will not be that much. Thank you, sir.
Okay, thank you.
Our eighth speaker is Dr. Annesha Chandra, DNB PGT, Anesthesia.
Good morning, everyone. Today, my topic of discussion is a comparative study of perioperative hemodynamic events between combined epidural and general anesthesia versus general anesthesia alone in laparoscopic gynecological surgeries. As we all know, laparoscopic gynecological surgeries are traditionally performed under general anesthesia, but laparoscopy induces some adverse hemodynamic changes due to pneumoperitoneum, as shown in the pictures. So recently, regional anesthesia, especially epidural anesthesia, has been introduced in the field of laparoscopy, and the combination of the two techniques have been shown to attenuate decrease the adverse hemodynamic changes due to pneumoperitoneum by decreasing the systemic vascular resistance, the mean arterial pressure, and also the need of various anesthetic agents. It also improves the surgical field by contraction of the bowel due to sympathetic blockade and thus induces first recovery. There are very few literature available that provokes me for further research. So my primary objective is to compare the perioperative hemodynamic parameters and well-being of patients coming for laparoscopic gynecological surgeries with two different modalities of anesthesia, that is EAGA and GA only. So this is a randomized case-controlled prospective study held in the Department of Anesthesiology in collaboration with the Department of Gynae from February 2023 to December 2023. My study includes the patient scheduled for elective laparoscopic gynecological surgeries of physical status ASA 1 and 2 of age 18 to 60 years. After getting the institutional ethical clearance, I started my data collection, and my study includes the patients, and we divided the patients in two groups, that is EAGA group and GA group, randomly, and each group containing of 40 patients each. These are the demographic profiles of my patients. Now coming to the results, we compared the intraoperative variability of heart rate changes between the two groups starting from pneumoperitoneum at 10 minutes interval. And it clearly shows that during the pneumoperitoneum period, the heart rate was relatively low in the EAGA group, and the difference between the two groups, that is EAGA group and GA group, is statistically significant. While comparing the systolic blood pressure in the two groups, it also shows that SBP was well maintained in EAGA group. Comparing the diastolic blood pressure in the two study groups, it also shows the statistically significant value between the two groups. While comparing the mean arterial pressure between the two study groups, it also shows the MAP was well maintained in the EAGA group. Baseline ETCO2 was comparable between the two groups, and the stress response to surgery during pneumoperitoneum was better with group EAGA. Time to recover from anesthesia was shorter in EAGA group than GA group, and there is a sharp decline of PONV, that is post-operative nausea vomiting episodes, in EAGA group.
So with the study results, we can come to a conclusion that pneumoperitoneum period under GA causes an elevation of heart rate, SBP, DPP, and mean arterial pressure. In our study, by adding epidural anesthesia to general anesthesia, we are successful to lower down the unnecessary elevation of these parameters. So the conjunction of these two anesthesia techniques can be used safely in patients undergoing laparoscopic gynecological surgeries. These are my references. Thank you.
Thank you very much. Nice presentation, nice thought.
Thank you, sir.
Your study says it is you're always mentioning laparoscopic gynecological surgery, but the study says it is only total laparoscopic hysterectomy.
Yes, sir. Actually, we did the study on total laparoscopic hysterectomy patients. We found very few patients for other laparoscopic procedure. So we take the all patients for TLH operations.
Then you mentioned that this is only for TLH operations.
Okay, sir. Okay.
One. Second is the age group also matters. So you're talking about a huge age group where the TLH is done from very younger age group with less comorbidity, and the later group where there may be a possibility. So unless you exclude the comorbidities, it
Yes,
is
sir,
difficult to compare the two things, because you are comparing the immediate event. There is a second event. You are talking about the pain relief. You are talking about the post-operative recovery. All these things also matters when you are comparing these two things. Because unless the epidural, the problem is in the word, somebody has to maintain that one. So this is another part. So how you manage that?
Sir, actually, we did a post-operative VAS score analysis that is not included in my study, but
That is the one which will be, because three things would have been enhanced the study. One, you have selected the case of comparable age group and excluded the comorbidity. Second, because if it is a bigger fibroid, it's a bigger, so it takes longer time, so and the more blood loss compared to the smaller, so that also matters. So another thing is comorbidities, and then you follow up with the post-op period. Then it would have been enhanced.
yes, sir, that is the drawback of my study. I must mention that is the drawback of my study, because I didn't go for the post-operative pain management pain score. We did the VAS score, but there is definitely difference in the management of.
Thank you. Thank you, sir. Thank you very much.
Thank you, sir.
Our next speaker is Dr. Orpon Ghosh, DNB PGT Medicine.
Good morning. Myself, Dr. Orpon Ghosh, DNB Medicine PGT. My topic is diagnostic value of adenosine deaminase level in ascitic fluid of different etiology. Ascites is defined as pathological fluid accumulation within the abdominal cavity. It may be high sag, more than equal to 1.1, or low sag, less than 1.1. Adenosine deaminase enzyme is generated when DNA of lymphocyte is broken down. It exists in two isoforms, ADA1 and ADA2. In majority of patients with TB peritonitis, the level of ADA in ascitic fluid is more than 40 international unit per liter. But high levels are also seen in various conditions in malignancy like lymphoma, etc. The gold standard test for TB peritonitis is diagnostic laparoscopy, biopsy with histopathological examination, AB stain, CBNAT of ascitic fluid, though yield is very poor. Now, adenosine deaminase activity, the reagent used in this test, diazyme ADA reagent. 1 unit of ADA is defined as the amount of ADA that generate 1 micromole of ionosine from adenosine per minute at 37 degrees Celsius. and kits should be stored at 2 to 8 degrees Celsius. And limitation is ADA releases some ammonia. So patients with hyperammoniac condition like kidney disorder, liver disorder, they can present high level of ADA value. And patient with chronic malnutrition and HIV can present low level of ADA value. And higher level of ADA are also found in leprosy, lymphoma, brucellosis, peritoneal carcinomatosis, viral hepatitis, infectious mononucleosis. So how to approach to ascites? So coming to approach to ascites, first after paracentesis, gross appearance of fluid should be checked, whether it is color transparent yellow or bloody or milky or dark brown. There are different causes of according to the color. Then coming to the cell type and cell count, the WBC cell type, if it is more than 500, and then coming to polymorphonuclear neutrophil cell, if it is more than 250, and there is single organism, then it can be SBP, spontaneous bacterial peritonitis. And if it is there is multiple types of microbiota is present in culture sensitivity, but polymorphonuclear cell is more than 250, then it may be due to secondary bacterial peritonitis, not spontaneous bacterial peritonitis. So you have to exclude the other abdominal condition by abdominal CT scan and other tests. And low sag, low protein, total protein if more less than 2.5, then it is the ascites due to nephrotic syndrome. So there are multiple causes of ascites: nephrotic syndrome, cardiac ascites, cirrhotic ascites, pancreatic ascites, SBP, tuberculosis ascites, peritoneal carcinomatosis. So this is the, in summary, the approach to how to approach to ascites. Now, what is the aim of our study? The aim of our study is the what is the level of ADA in ascitic fluid of different etiology and any different difference therein. To find out the cutoff level of ADA in ascitic fluid for different etiology, and to find out the sensitivity and specificity of ascitic fluid of ADA level in diagnosing ascites of tuberculosis etiology. The methodology: study area of the BR Hospital, study design cross-section, study period 2 years, and study population was the case under the OPD service and gastroenterology and different department. Sample size was 89. Study technique: hospital ethical committee approval was obtained to conduct the study, and valid written consent was taken. And detail of each patient was recorded and analyzed. Patient was followed up for 8 to 12 months. Statistical method: categorical variables are expressed as number and percentage of patient. Continuous variable were expressed minimum, maximum, and ROC curve diagram was generated for estimating the cutoff value for different etiology at 95% confidence interval, and alpha level of 5% has been taken if p-value less than 0.05. Inclusion criteria: patient with new onset ascites with or without pedal edema. Exclusion criteria: patients on maintenance hemodialysis, antenatal mother, comatose patient, patient admitted with history of trauma, patient presenting with massive upper GI bleed. In results, we have seen there are mean value of the ADA 29.33 and standard deviation 22.785, and 35 was our BR Hospital ascitic level cutoff value. Here, more than 35 was 40.45%, less than 35 59.55% in our study. This is the pie diagram showing a gold standard test in differentiating between the sign of cancer, sign of TB, and other cause. And this is the left side. This is the different causes that leads to ascites. So here TB peritonitis was 21.3% in our study, and peritoneal carcinomatosis was 12.44%. And this is the average fluid ADA level in different etiology. And this is the ROC curve diagram. ROC curve diagram was generated for each etiology, and we have found p-value less than 0.05. That is the significant in only 3 cases. That is liver cirrhosis, peritoneal carcinomatosis, and tuberculosis peritonitis. So using ROC curve diagram, we have made the cutoff value only for these 3 cases. This is the liver cirrhosis, and this is the TB peritonitis ROC curve. And we have measured the cutoff value from our study for liver cirrhosis was 12.5, TB peritonitis 43, and peritoneal carcinomatosis 29.5. But the sensitivities in case of TB peritonitis at that cutoff value 43, 89.47, specificity was 87.14, PPV was 65.38, and NPV was 96.83. And so diagnostic accuracy is 87.64, higher compared to the liver cirrhosis and peritoneal carcinomatosis. In case of liver cirrhosis, diagnostic accuracy is 73.03. In peritoneal carcinomatosis, sensitivity was 100% and negative predictive value was 100%, but PPV was very less, 25.5%. So coming to conclusion, measurement of ADA in ascitic fluid is a fast and accurate test for diagnosing TB peritonitis. Though ascitic fluid ADA can also be raised in peritoneal carcinomatosis, the specificity, PPV, and diagnostic accuracy are lower. For differentiating TB peritonitis from non-tuberculous ascites, the optimal cutoff value for ascitic fluid ADA is 43 unit per liter in our study. And in case of liver cirrhosis, it was 12.5, 29.5. However, in the presence of cirrhosis, the sensitivity and specificity of ascitic fluid ADA in confirming TB peritonitis is low in presence of cirrhosis. And the beginning of empirical treatment when a patient has a high ADA value in ascitic fluid seems to be a good approach while waiting for the result of mycobacterial culture or biopsy, because the yield is very poor. Though these are the main gold standard tests, ascitic fluid ADA level can be used as a diagnostic test in center where laparoscopy is not available, so biopsy is not possible. So it can also be used in very sick patients who are unfit for laparoscopy. Thank you.
Hello. Arpan, thank you very much for your nice presentation. Few suggestions. If you have got 4 minutes allotted, try to stick to your time. Telling more thing doesn't add. Being crispy adds. So there is a difference between in a lecture or in a presentation. Telling so much of thing doesn't matter. Telling it in a very crispy way matters. So that was absent in your. Second is, don't read. So text is written line after line and don't read. Slides are there to guide you, not to read. And third thing is, don't, I have mentioned in other presentation also, don't have the introduction for 3 minutes and you have got presentation for 1 minute. So the purpose is lost. The case is, introduction should be crispy, 1 slide. ADA, this. Used in this. My case, this many. That's all. You don't have to go on and on and on that. No, the message was pretty clear that if there is a ascites, ADA adds on, but it's not a very specific one. That's the 2 things was there. It could have been come out. Sir, please.
So it is a well-known fact that ADA is raised in tubercular peritonitis. So what new you have added from your study?
Sir, actually ADA can be raised in during my study procedure. I have seen ADA was raised in peritoneal carcinomatosis case also. So in the initial of my study, I have thought that at the last I have found that ADA is non-specific for tuberculous peritonitis, but ultimately it has been shown
I think I'll reframe sir's question. It's very valid. ADA is known to be associated with tuberculous peritonitis.
Yes.
ADA is known to be non-specific. What else you want to know from this study, presenting this one?
You have told the AD drug can be started on the basis of ADA. Is it true?
Where laparoscopy is not available.
No, it is not medically.
No, gold standard test is the diagnostic laparoscopy and biopsy and CBNAT, TrueNAT. But if ADA is more than 40 and clinically suggestive of TB, and in the rural area where laparoscopy is not available, patient is very unfit to laparoscopy, then
it is suggestive, but not
empirical
diagnostic.
Suggestive. Empirical ATT can be given.
Empirical ATT, I think not permissible now. With so many.
Yes, it is not gold standard test. Gold standard test is
you cannot give ATD unless and unless you inform the local authority. Yes. Those days are gone. The patient cannot do, let me try this one. So no one will save you. Once the patient develops jaundice and dies, then no one is going to save you. So those days are actually gone. Okay, thank you.
Our next speaker will be Dr. Shobboshachi Ghosh, DNB PGT Medicine.
Good morning, respected judges and respected delegates present here. Myself, Dr. Shobboshachi Ghosh, DNB General Medicine PGT. My topic is clinical and etiological profile of hyponatremia in hospital admitted elderly patient in a tertiary care hospital. Coming to introduction, hyponatremia is the most common electrolyte disorder in hospitalized elderly patients. Depending on the serum sodium concentration, hyponatremia is classified in three varieties: mild, moderate, and severe. Clinical presentation has a wide spectrum varying from asymptomatic to nausea, lethargy, body cramp to seizure, even coma. Hyponatremia is associated with adverse outcome and mortality if not diagnosed and treated promptly. Hyponatremia in elderly is more complicated as they have lots of other comorbidities. SIADH is the most common etiology in elderly. Besides that, low salt intake, GI loss, renal loss, and drugs like diuretic are the leading etiology. SIADH diagnosis may be problematic due to its multifactorial etiology, which includes CNS disorder, pulmonary disease, neoplasia, drugs, etc. Diagnosis of hyponatremia in my study is based on symptomatology, laboratory findings, and volume status of the patient. Coming to the objectives, to classify the hyponatremia according to its severity in hospitalized elderly patients, to describe the causes of hyponatremia among study participants, to correlate the clinical features with severity of hyponatremia, to identify the demographic, clinical, and etiological factors associated with it. Now coming to the methods, it is a hospital-based observational study. It is done in the Department of Medicine and all elderly aged patient more than 65 years, and the study duration was 18 months from August 2002 to 2024 January. Exclusion criteria is pseudo hyponatremia and postoperative patient. Diagnosis of hyponatremia was done based on combination of clinical and laboratory finding and standard investigations like serum sodium, serum burn, and RBS, and the serum osmolarity, urine osmolarity, and serum TSH level, and standard statistical analysis was done. Now coming to my observation, the maximum number of patients are seen in the age group 70 to 74, and next is 75 to 79 years, and it is shown in the bar diagram. And in my study, maximum population was from male 57, and as per severity, the 50 number of patients are severe, 29 are moderate, and 26 are mild. Coming to the distribution of patient according to the comorbidities and severity, hypertension and diabetes are the leading associated comorbidities with these participants. And coming to the volume status, it is a maximum number of patients seen in euvolemic status, and thereafter the hypovolemic patients, and thereafter the hypervolemic patients. And coming to the SIADH, the maximum number of patients shown in the diagram is from neurological point of view, and then pulmonary, then drugs, and the lung carcinoma. Now coming to the symptom, the severely symptoms are altered sensorium, seizure, and the muscle cramp. As asymptomatic patient were 19. Now coming to the treatment, it was treated with 3% NaCl, 0.9% saline, oral salt, diuretic, and water restrictions. Now coming to the outcome, that 18 number of patients were died, and 87% were discharged, and from the age group 80 to 89, there is a total 5 patients out of 4 is died. Now coming to the conclusion, clinicians need to be aware of common occurrence of the hyponatremia in elderly. From the patient study, I concluded that there is an increasing tendency of hyponatremia to occur with increasing age and use of diuretics and comorbidities like hypertension and diabetes. Lethargy, muscle cramp, altered sensorium are the most common but non-specific symptom. And SIDs was observed to the most common etiology of hyponatremia in elderly, as well as etiology with highest mortality. So since mortality outcome are significantly associated with severity and etiology of hyponatremia, a systemic approach is considered. Thank you.
Good selection, simple topic, executed nicely. Only a good thing could have been done is improving your slides, not writing this one, as I mentioned before. But it's a good one.
Thank you.
Yeah,
Sure.
thank you. Good presentation and good observation also. So, how did you treat this patient? You administered 3% in all, or?
So patient were treated according to the cause, according to the volume status, and in my study, maximum patient were seen from euvolemic, and SIDs patients, and my main study population are elderly patients. And yeah, I treated I know the SIDH is the euvolemic, and so water restriction is the first treatment, and following which, if not responded, then oral salt, and also given the, in case of severe hyponatremia, I consider the 3% NaCl, but in case of mild cases, only oral salt and water restriction suffice.
Now, last question is that how these patients become symptomatic with hyponatremia? I mean, many patients may be hyponatremic, but how the symptoms develop?
There are lots of patients of hyponatremia, they are asymptomatic, but they usually tell there is some lethargy, there is some muscle cramp, there is some vague symptom. So that's my point is that their symptoms should be first addressed.
Yes. So no, your answer should be that it is the rapidity of onset of hyponatremia that determines the symptom. Suppose a patient having normal status today, by evening becomes severely hyponatremic, patient will have convulsion, drowsiness, all these things. And then you should treat with this 3%. But a patient on cirrhosis of liver or congestive cardiac failure suffering for a long time, they may have sodium level 115, 120.
That patients are chronically
They may have some subtle symptoms. So that your answer should be symptoms of hyponatremia develops with rapidity of onset of the symptoms. Okay, thank you.
Hello. You should give the incidence of hyponatremia with some different medicine, because elderly patients always take some medicines. Have you?
The main in my study, it is shown that lots of patients takes diuretics injudiciously. In older age patient, we should take care of diuretics because it is the most common drugs, and patients.
Do you have any relation to drugs?
Yes, sir. Drugs causing it is diuretics mainly, and also other drugs like in some selected group like cancer drugs. It may cause. There are some drugs causing SIADs like tricyclic antidepressant, which we use elderly patient takes for antidepressant. It may cause the SIDs.
Thank you. I think a nice presentation. The only thing correction is that they take diuretics injudiciously, or it should be rectified, they have been given diuretics by doctors injudiciously. So that should be the rectification. Thank you.
Thank you.
Our next speaker is Dr. Atul Anand, DNB PGT ENT from Garden Ridge Hospital.
Good morning, everybody. I'm going to, my topic is cartilage tympanoplasty techniques and scrutiny. There are many graft materials present in and around ear for the purpose of tympanoplasty purposes, out of which mostly we use temporalis fascia graft and cartilage graft. Why I am stressing upon the cartilage graft here, because most of the other grafts have their own complications. These, when coming to cartilage tympanoplasty, these complications are a little are minimal, and in addition, cartilage is rigid, resorption resistant, has a long-term survival, and it's largely nourished by diffusion. Therefore, graft is taken well in the postoperative period. Temporalis fascia success rate is generally seen to be only 60 to 75%. There are many reasons for that. And when we use cartilage tympanoplasty, these reasons are minimized. When we go for cartilage tympanoplasty, we have to take into account the biomechanics of the cartilage tympanoplasty. A thick graft will provide stability, but as you see, the sound will get reflected more from a thick graft. Therefore, conduction of sound will be less. Therefore, acoustically speaking, thick cartilage will be acoustically not that much good when compared to thin graft. Thin graft, unfortunately, will have a problem of stability. So when we go for cartilage tympanoplasty, we have to keep both of this in mind and get a balance between the two. There are many indications for cartilage tympanoplasty. For example, in case of subtotal perforation or anterior perforation, we have to go for thin graft, it is much more better because it will give a more acoustic probability will be high for the patient. But when it comes to retraction pocket or reperforation, it's better to go for thick graft. Wherever a reperforation patient is coming or risk factors of reperforation is present, it's better to go for thick graft. Mucosal traction, which is a new put forth theory for this this graft material failure rate is much more minimal when it comes to cartilage tympanoplasty. There are various techniques available for cartilage tympanoplasty, and in and around the year we have so many donor sites. Basically, we go for mainly tragal cartilage as well as conchal cartilage. Let me talk about certain points. Tragal island cartilage. Here we take a tragal cartilage, then a small amount of cartilage is kept in a sea of perichondrium, and perichondrium is pushed into the EAC. Let me show you a glimpse of the tragal perichondrial grafting. Here tragus is getting, we are giving the incision and taking the cartilage out. Let me show you the tragal perichondrial graft placing. We are pushing the graft material inside, and slowly perichondrium is being spread towards the EAC walls. This is the post-op picture of a perichondrial graft. Coming to shield grafting, we take a graft and we give a V cut or a U cut and push it upon the malleus, resulting in a shield-like graft material. That's why it's known as shield placement. Let me show you a video. Here we are giving a U cut upon the this tragal cartilage, and we are placing it directly upon the incus. That's why this is known as shield cartilage. This is a post-op picture of shield cartilaging. This one is palisade cartilaging. Here we are cutting the cartilage into pieces, and we are keeping it either medially, laterally, or anteroposteriorly. A glimpse of palisading. Now, this is tulip cartilaging is a new methodology, a more advanced methodology of palisading. This is a post-op palisade picture. Butterfly grafting is basically like a buttonhole. We are keeping it upon a small perforation, basically for small preparations. Just put it there, that's it. Concerns of cartilage tympanoplasty are overcome by various methodologies, equipments nowadays available. Therefore, it's easy to do cartilage tympanoplasty. Acoustically, perichondrial graft, island graft is much more better than other cartilage grafts, because when it comes to cartilage tympanoplasty, we have to take into account various symptoms also. Because, for example, most of the patients, this is data of 160 patients extra I take into account. Discharge and hearing loss are the most common complaints, while retraction and perforation were the most common findings. In these cases, it is better to go for thick conchal cartilage rather than tragal cartilage, because stability of the cartilage is much more important in these particular cases. Therefore, in our hospital, we generally mostly go for shield cartilaging or palisade cartilaging. And especially when it comes to ossiculoplasty, canaloplasty like complex procedures, it's better to go for palisading or shield cartilaging. Outcome, as you see, ear discharge is minimal in the post-operative period. Audiological outcome is also comparatively, it's very good. In conclusion, cartilage tympanoplasty is known to help in achieving a safe ear, but is traditionally thought to bear a poor audiological outcome. Proper usage of techniques and modern technologies has helped in finding a balance, resulting in better patient outcomes, especially in revision cases, active mucosal disease, and unsafe disease. It also helps in preventing the dreaded post-op complication of cavity formation. These are my references. Thank you.
Thank you very much. Nice presentation.
Thank you.
It indicates how the subject has improved over the years. Those who are senior can understand what was there and how it is done today. You have mentioned that you prefer the sealed technique.
Yes, sir.
Is there any particular reason? You have mentioned it.
Yes, sir.
But just for us, 1, 2, 3, 4. This is the reason I choose this.
So shield cartilage tympanoplasty, which provide much more stability to the graft. With simple temporalis fascia graft, we have seen a failure rate because it's only 65 to 70% success rate only. This results in the post-operative period. After 3 months, when we go for the follow-up, we have noticed that many of the patients can manifest with a bit of retraction or a displacement. Such problems occurs, but when we go for tragal cartilage tympanoplasty, these problems generally is not seen. Therefore, that's
is the long-term follow-up result.
Sir, this is the 1 year data. So,
Failure rate?
failure rate, as you see, in 160 patients, we have done the cartilage tympanoplasty. 3 patients had a worsening of audiological outcome. Other than that, the other patients were having a good audiological outcome. And stability was there in 100% of the 160 cases we have.
Any inclusion criteria for this, only for this cartilage graft?
No, sir. I have taken
Any patient you can
arbitrarily
take. Okay.
Is there any particular reason why these 3 failures of audiological parameters happen? Have you analyzed that
Yes,
why
sir.
these
Because
3?
in these 3 patients, we have noticed that there were ossiculoplasty also done along with the cartilage tympanoplasty. So there we have used thick graft also. So thickness matters in case of cartilage tympanoplasty. It can cause problem.
As per my knowledge goes, this procedure is done in this city for last, at least I know, for last couple of 3 years like that.
Yes, sir.
So what is your take? Why did you take up this study? Because to show performance of your center, or you have compared with other centers like that?
Sir, basically because most
because
of
as far I know, this is now a standard tympanoplasty procedure.
Yes,
So
the thing is, sir, we have noticed that when I went through so many studies, I have noticed that most of the surgeons go for basic temporalis fascia grafting because it is much more easier to do. But these temporalis fascia graft is having more complications. I mean, failure rate is high. But when it comes to cartilage tympanoplasty, failure rate is much more low and the patient outcome is very good. That is why I thought I should present this topic.
Okay, thank you.
Thank you, sir.
Our last speaker is Dr. Alka Pandey, DNB PGT Gynae.
Good morning, everyone. I'm Alka Pandey, second year Gynae PGT, and I'm presenting a rare case of adrenal myelolipoma during pregnancy. Primary adrenal tumors are often functioning and exceedingly rare in pregnancy. It includes adrenal cortical adenomas or pheochromocytomas. With advances in imaging, uncommon tumors are more frequently reported. These are myelolipoma, lipoma, angiomyolipoma, and liposarcoma. Adrenal myolipoma are rare tumors with few cases reported during pregnancy. While incidentalomas are commonly identified with abdominal CT imaging or autopsy, pregnant women should undergo neither CT scanning nor autopsy. Therefore, identifying those rare functioning adrenal tumors in pregnancy is uncommon. Here, a case report of pregnant women with adrenal tumor is described to enlighten the obstetricians on fetal-maternal outcome and the management of this infrequent clinical entity encountered nowadays. The 36-year-old third gravida, para-1 living issue 1, presented to our antenatal OPD at 10 weeks with a large suprarenal mass on ultrasound. The maternal condition was stable, examination was normal with pulse rate of 80 beats per minute and the blood pressure of 120/80 millimeters of mercury. The ultrasound revealed a well-defined smooth overt hypoechoic mass of 8 into 7 centimeter over the right para-aortic region, suggestive of the right adrenal mass. Left adrenal region was normal. Fetus was normal and the placenta was fundoposterior. Urology opinion was sought and the MRI suggested fat-containing suprarenal mass of 9 into 6 into 5 centimeter, which was consistent with the right adrenal myelolipoma. This is the MRI picture depicting the same. Now, investigations, including all the investigations which we done in antenatal period, including homogram, kidney and liver function test, serum cortisol, 17-hydroxyprogesterone, metanephrines, urinary venyl, mandelic acid, adrenaline, and were normal. In the follow-up visit in the second trimester, we did the anomaly scan, which was normal. Due to the increased blood pressure, she was started labetalol. Patient was advised BP monitoring at home and was advised to follow up in the OPD every 2 weeks. In the third trimester, patient came to the OPD at 37 weeks, blood pressure of 160 and 100. She was admitted for the safe confinement of pregnancy. USG showed decreased diastolic flow in the uterine vessels, for which an emergency C-section was performed and the live male baby of 3.2 kg was delivered. Surgery went uneventful and patient was shifted to ICU for close monitoring. Post-op antibiotics We gave antibiotics and antihypertensives were continued. Mother and baby were discharged on post-op day 7 in stable conditions with the advice to follow up in the endocrinology and obs-gynae OPD. The adrenal mass was same in size in MRI after the 2 months of delivery, and the patient is asymptomatic till now, so has not been planned for surgery. Coming to the discussions, the myelolipoma has been reported in 0.08 to 0.4% of the diagnosed adrenal tumors. It occurs in 40 to 60 years of age with equal sex distribution. They are benign, non-functioning, asymptomatic neoplasm composed of adipocytes and hematopoietic tissues. The large adrenal tumor present as acute pain abdomen and due to rupture and hemorrhage. The differential diagnosis includes the adrenal adenomas and pheochromocytomas. Since my patient was pregnant and asymptomatic, so biopsy was not done. Studies have recommended the surgical removal of adrenal myelolipoma larger than 5 centimeter because of rupture or hemorrhage. Surgery during pregnancy has the risk of abortion, placental separation, preterm labor, prematurity, anesthesia risk, and fetal demise. My patient presented with tumor at 10 weeks without symptoms, so we planned to avoid adrenalectomy. To conclude, adrenal myelolipoma can be managed conservatively during pregnancy if asymptomatic, and surgery can be delayed with interval imaging. These are my few references, and thank you.
Thank you very much. Nice presentation. You're glad that it is not a pheochromocytoma, isn't it? Because as you understand, you're glad that it is not a pheochromocytoma. Otherwise, the prognosis, the management could have been completely different.
Yes, sir.
The only comments, this is a incidental finding, and you are very glad, or we are very glad that nothing happened. The only question is that you are mentioning she had hypertension. You have given her levodopa.
Yes, sir.
In the later part, you have just mentioned, it's a obstetric question, that at 37 weeks, you have done a emergency cesarean section because of decreased flow in uterine artery.
Yes, sir.
At 37 weeks. Why you are bothered about the decreased flow in uterine artery?
Because, sir, it can cause the sudden intrauterine death. And
at 37 weeks.
So because that the patient is my patient is having PIH and patient has already completed 37 weeks. So
that is a different thing.
So in PIH,
but that should not be the indication. It is a complete obstetric question. What you have managed is perfectly fine. That is not a problem. But the indication for doing a cesarean section in a hypertension should be hypertension itself.
Yes, sir.
It's just having a Doppler finding of uterine artery decreased flow will not be substantive.
No, sir, that was an added indication.
Okay. And you have already mentioned that 8 weeks follow-up, the size is still big.
Yes, sir. The size
so
is
you have not opted for any surgery yet.
Yes, no, sir.
But have you consulted the urologist again?
Yes, sir. Patient has continuously every 4 weekly she follows in endocrinology OPD and ROPD, and we do the follow-up every 4 weeks by USG and MRI as advised.
Sure.
So what is the normal protocol for managing such tumor in pregnancy?
No,
normal protocol. What is recommended?
Sir, these are very, very, very uncommon tumors. So protocol cannot be formed for such a rare case. I mean, in my whole lifetime, in 40 years of gynae, we have seen only one pheochromocytoma, that too in different unit.
So it depends upon the presentation. That's the
absolutely,
whole thing.
absolutely.
That should be your answer.
Yes, sir. That depends upon the presentation.
Any other?
Thank you.
Thank you very much indeed.
So we come to the end of this pre-paper session, but I will request Dr. D.R. Das and Dr. Pradhan to assist our judges to do the calculations and all. Dr. Pradhan, please help them. We have Dr. Somojit Basu with us. So I will request once the calculation is completed, the judges and Dr. Somojit Basu to please come and take their seat on the stage.
Subro, yeah, I have something to say to the
Sure.
presenters. All have done exceedingly well, and it is very difficult to differentiate who is better, who is best, like that. But we have to follow some protocol, otherwise we cannot make it first, second, third. So none get disheartened. So all of you have done exceedingly well, and by this presentation, I think you have learned a lot also in future, how you should present and how you should read more. Actually, IgG4, I told that should be, without that you cannot make this diagnosis. So like that, you have to read thoroughly to face any questions, because that there is also marks for question answering. So once again, I thank you all for your nice presentation, sir.
I think I must admit that you people present much better than us when we are in your age. So give them a big hand, please, because you have to understand what stage they are and then judge it. After doing 40 years, then your presentation, you people are doing very, very good. Presentation wise, only thing is what I mentioned before, the slides could be improved, number one, because you follow the simple technique of 6x6. 6 words, 6 lines. And bullet points, not this is case can be discussed like that and this is like that and not like that. It is just adding to your thing. You just look at that and say, fix your time. If you are giving time for 15 minutes for a talk, don't put the whole chapter horizon there. Or so understand the audience, understand that which schedule, what is the time given to you. Time is very important. Everybody loves it. The moment you can complete within time, you get 10 out of 10. You crosses, lose the 10 marks. So that is very important. And the third important thing is reduce your introduction. You are presenting something. Introduction should be this, the case or presentation should be this, and conclusion should be very crispy. When I mentioned to the medicine person, that conclusion should be very crispy, so that it comes out. The audience says, yeah, I understood. Nobody is interested. It can be done in these cases, and no one is listening to you. You just listen to that. Thank you. Thank you very much for this thing. Absolutely brilliant.
I think we can start by giving the certificates. Till the calculation is going on, it will take some 1 or 2 minutes. So I'll request one by one to collect the certificates from the judges. First is Dr. Ornesha Dashghosh. You can come, please come. Dr. Somojit Basu also, please come on the stage. Actually, we are setting the stage for the upcoming inauguration. So, okay, first I will request Dr. Ornesha Dashghosh. The names are written on the, you can please see. Okay. Next is Dr. Shondeep Sivapuja. I'll request all the PGTs to come and make a queue because we don't have much time. You know the sequence, please come and make a queue. And I also have got the results of the first, second, third. I will request Dipanjan to bring the medals also. Dr. Sagar Pushp, DNB PGT surgery. Dr. Jhilam Basu. Dr. Kiran Vaidya. Dr. Nikita Minj. Lots of claps I want. Dr. Susheta Bonik. Dr. Annesha Chandro. Dr. Orpon Ghosh. Dr. Shobhoshachi Ghosh. Dr. Atul Anand. And Dr. Alka Pandey. Now I'll request our judges and Dr. Shomujit Basu to hand over the medals. Sure. The third prize and the third medal goes to Dr. Annesha Das Ghosh. The second prize goes to Dr. Atul Anand. And the first prize goes to Dr. Shobhoshachi Ghosh. So before we end this session, I think Dr. Shomujit Basu has a few words to share with us.
Good morning, everybody, and it's a real privilege and an honor for me to be here. I'm Dr. Basu. I'm basically an orthopedic surgeon and subspecialized into spine surgery, and I'm into spine surgery for the last 20 years. So I'm really grateful that BR Hospital Doctors Club and the management of this beautiful hospital has been kind enough to start this memorial competitive short paper presentation in the name of my father, Dr. Eki Basu, who had spent more than 18 years in this hospital in his 27 years career in the railways. And he breathed BR Singh Hospital every moment of his life. And he was really proud to be associated with this hospital. We as very small kids used to visit this hospital on our way back from school. So for the 12 years we spent in school, we were there into this hospital on our way back and we went home together. So I have cherished very sweet and very nostalgic moments of my life in this hospital. Coming up to this podium and visualizing the beautiful papers which have been presented in the last 1 hour has been a real eye-opener for me. For all those who have presented, a real word of thanks for taking the effort to present. Please remember that in the current world, either you publish or you perish. whenever you're doing your post-graduation, it is imperative that you start presenting papers. It is an extremely important aspect of your training, and until unless you present, you're not going to gain communication skills, which is the hallmark of today's medical world. You have to communicate well with your patients, with your peers, and in all scientific forums. So this is extremely important. Just one word of advice for all of you who presented. Before you pick up a topic, select a research question. That what exactly are you going to talk about? Second is do a small literature review on what is the published data on this particular aspect. Third is pick up the methodology of research well so that your results can correlate well with the findings. I would not take much of your time. One last word of thanks to the judges. All the three judges were extremely hooked on to all the papers, and they have put in very relevant comments, and I really take this opportunity to thank the judges. Thank you very much.
चार गो होगा इस साल ना एक और देखो
How are you doing?
একটা দেশলাই কিন্তু ভালো লাগে দেশলাই
Hello.
कौन बोल रहा है देखो हेलो इसमें गाना गाएगा हेलो हेलो
मांग के दीजिए लगा अब उनको दे दीजिए नहीं तो नीचे जाएंगे
हेलो हेलो चेक हेलो हेलो चेक चेक हेलो हेलो हेलो
Honorable dignitaries, delegates, our guests, members of the Railway Medical Fraternity, ladies and gentlemen, a very good morning to you all. On behalf of the organizing committee of this 49th annual scientific seminar and CME program, I, Dr. Ungira Dasgupta and Dr. Dia Dash, welcome you all to this inaugural ceremony. This program will be formally inaugurated with the lighting of the lamp, and I will take the privilege of requesting Dr. Sugandha Raha DG Madam to kindly come forward and light the sacred lamp. I will also request the other dignitaries, General Manager ER, PCMD ER, MD BR Singh, and DRM SEALDAH to join in the lighting ceremony.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
As is the tradition, we begin with an invocation to the Almighty, sung by Dr. Sujata Basu. May the entire environment be filled with peace and purity.
নমস্কার নমস্কার ওম মধু ওম মধু ওম মধু मधुबातारितायते मधुक्षरन्ति सिन्धवः मार्धीर्न सन्तोषोधिः मधुनाक्त मुतोषशः मधुनां पार्थिवं रजः मधुदो रस्तु नः पिता मधुमान वनस्पति मधुनाङस्तु सूर्यः मार्धिर्गाव भवन्तु नः ॐ मधु ॐ मधु ॐ मधु
Thank you, Dr. Basu, for your excellent rendition. And it is now time for calling of our respected dignitaries onto the dais. I now take the prerogative of calling upon Dr. Sugandha Raha, Director General Railway Health Services and chief guest of this morning's function, for taking her place on the dais. And she will be escorted onto the stairs by Dr. Mihir Chaudhary, PCMD, Eastern Railway. Our respected General Manager, Sri Milind K. Deoskar, is kindly requested to come onto stage, and he will be escorted by Dr. Shubhashish Dash, Medical Director, PR Singh Hospital. Dr. M. K. Chaudhary, PCMD, Eastern Railway, is requested to come onto the dais, and he will be escorted by Dr. Champok Bishash, CS1, BR Singh Hospital. Medical Director, BR Singh Hospital, Dr. Shubhashish Dash, may kindly come onto stage, and he will be escorted by Dr. Paromita Bishash. Our Divisional Railway Manager, SEALDAH, Sri Deepak Nigam, may kindly take his place on the stage, and he will be escorted by Dr. Ochinto Shannal, CMS SEALDAH. Dr. Ordo Mitro and Dr. Choyan Bhattacharya, organizing secretaries, may kindly take their places on the dais, escorted by Dr. Kalpana Mondol and Dr. Paromita Bishash. With the seating of our esteemed dignitaries, let us welcome them on stage with a memento, keeping in line with the traditional Indian practice of welcoming our guests. Dr. Mondira Banerjee is requested to come onto stage for presenting a memento to Dr. Sugandha Raha, Director General Railway Health Services and chief guest of this morning. Dr. Paromita Biswas is invited to come onto the dais for presenting a memento to Sri Milind K. Deoskar, General Manager, Eastern Railway. Dr. Kalpana Mondal is requested to come onto stage for presenting a memento to Dr. M.K. Chaudhary, PCMD, Eastern Railway. I take the pleasure of inviting Dr. Ochinto Shannal to kindly come onto stage for presenting our medical director, Dr. Shubhashis Dash, with a memento. Dr. Shannal will again be repeating the honors, and he is requested for presenting a memento to Sri Deepak Nigam, Divisional Railway Manager, SEALDAH. Dr. Kalpana Mondal, ACMS Health and Family Welfare, will be presenting a memento to Dr. Arnav Mitra, Organizing Secretary, ER Medicon 24. And finally, Dr. Paromita Biswas will be presenting a memento to Dr. Choyan Bhattacharya, Organizing Secretary, ER Medicon 2024. So after the inauguration and presentation ceremony, it is time for a formal welcome to all our guests, dignitaries, participants, and the best person to welcome them is none other than Dr. Shubhashis Dash, Medical Director, B.R. Singh Hospital, and President of IRHSA, BRSH. Sir, may kindly step forward and say a few words of welcome, please.
Good morning, everybody. Respected Director General, Railway Health Service, Dr. Shugandha Raham, Madam. Respected General Manager, Eastern Railway, Sri Milind Deoskar, Sir. Respected Principal Chief Medical Director, Dr. Mihi Chaudhary, Sir. Divisional Railway Manager, Sri Deepak Nigam. All the esteemed delegates, faculty members, PCMDs from other zones, PCMOs, guests, ladies and gentlemen. A very warm welcome to all the distinguished guests. I hope this conference provides, through its various scientific sessions, knowledge in the medical advancement to improve the health and well-being of the patients from heart-centered approaches. The medical fraternity should have an inherent desire to heal and improve lives and treat the patient as a whole and not the disease only. I wish you are all a very highly enjoyable and fruitful conference. I hope you enjoy the City of Joy and this magnificent city. Thank you.
Thank you, Dr. Das. B.R. Singh Hospital, Eastern Railway, SEALDAH, is the chief zonal hospital of Eastern Railway under the aegis of SEALDAH Division. And it will be very appropriate to listen to Sri Deepak Nigam, our DRM SEALDAH, the chief of this division. I request Sri Nigam to come forward and say a few words on this occasion.
Good morning, Madam Raha, DG, Health, Railway Board, our Honorable General Manager, Mr. Milind Devaskar, CMD, Dr. Chaudhary, MD, Dr. Das, the organizing secretaries, PCMDs of the zonal railways, all esteemed doctors, and all those present here. A very warm welcome to this event being organized at the venue of SEALDAH division. It's a matter of great privilege for the division to host such a program wherein thoughts are exchanged, papers are presented on the latest medical developments. It's a wonderful platform where we get to understand the requirement of the medical department. Being from the general administration side at the moment, it is a proud moment for me to listen to some of the issues of the hospital. And let me assure you that we'll try our best to address the issues. Of course, on the professional front, you are the best, but whatever help that we can provide from the infrastructure side, we'll definitely do it. I once again welcome our DG ma'am to this event and all the esteemed guests present here. A very warm welcome to this 49th conference organized by the Eastern Railways. Thank you.
Thank you, sir. Dr. Mihir Kumar Chaudhary, the PCMDER and principal mentor of this program today, is the main pillar as well as an inspiration behind the conference. Sir, would you please come forward and for a very short lecture?
Good morning, everybody. Respected Dr. Sugandha Raha, DGRHS ma'am, Sri Milind K. Devaskar, GM Eastern Railway sir, PD Health Railway Board, PCMDs from the different zones of Indian Railways, Sri Deepak Nigam, DRM SEALDAH, Medical Director, B.R. Singh Hospital, all my beloved doctors attending this conference, coming from all the different zones of Indian Railways, representatives of recognized union, print and electronic media, ladies and gentlemen. It gives me immense pleasure that the medical department of Eastern Railway is able to host its 49th annual scientific conference and CME program for the benefit of the medical fraternity in the railways, especially the young IRHS doctors who are likely to be benefited most from the scientific deliberations in the conference. This CME program has been regularly organized at B.R. Singh Hospital, SEALDAH for the past 4 decades or more. During my student days in Kolkata Medical College in the early 80s, the conference used to be organized in the metro ward of B.R. Singh Hospital as the hospital auditorium was not constructed yet. I remember attending the conference during my resident days in medical college, and I myself got immensely benefited. Due to COVID and certain other constraints, we could not organize the annual scientific conference for a number of years in the recent past. But from last year again, Eastern Railway is regular in organizing this event. I am very much indebted
to our DG RHS, Dr. Sugandha Raha Madam, for attending the conference despite her busy schedule. I am thankful to her that she had taken the trouble of preponing her engagements in the Railway Board, including an important JCM meeting at board level, so that she could come to Kolkata and join the conference as head of our medical fraternity. Thank you, Madam. The medical department of Eastern Railway considers Dr. Sugandha Raha as a member of our family since she worked in this railway for many years after joining as a probationer in Lilwa Hospital long back in the year 1986. She worked in Lilwa and Malda Railway hospitals, and both the hospitals were benefited by her hard work and innovative leadership. If Madam permits me to say so, I am proud to mention that Dr. Raha and myself belong to the same IRHS batch, and as we worked in the same railway in the initial years of our careers, we shared certain common ideas and a long-lasting friendship. Dr. Raha inspected different facilities of Biashing Hospital yesterday and also this morning, and gave her valuable guidance on how to improve the facilities further. On Monday, she will visit Howrah Orthopedic Hospital and other health facilities of Howrah Division. I am sure Eastern Railway will be greatly benefited by your guidance, Madam. Our dynamic and beloved General Manager, Sri Milind K. Deushkar, has a soft corner for welfare of railway employees, and a holistic approach towards healthcare is his priority. On his guidance, we are organizing health checkup camps at the doorstep of the employees to enable 100% of our workforce to avail the benefits of healthcare. Sir is very supportive of medical department, and we expect to get benefited by his inspiring leadership in the coming days. The medical department in Eastern Railway is always ably supported by our AGM, PHODs, DRMs, and CWMs. I am very happy that our DRM SEALDAH is kind enough to attend today's program. Your presence means a lot to us, and your support always encourages us to achieve more, especially in SEALDAH Division and Biashing Hospital. IRHS doctors from all the zonal railways are attending the two-day CME program here. I am grateful to DG ma'am and all the PCMDs and PCMOs of zonal railways and production units for nominating and sparing the attending doctors. IRHS doctors from divisional and workshop hospitals of Eastern Railway, including the postgraduate trainee doctors of our hospitals, are also getting benefited from this program. Another notable thing I must mention here is that PED Health Railway Board and 13 PCMDs from the different zonal railways are present here today, which speaks volumes about the importance this program carries in all over Indian Railways. The 3 PCMDs who are not present here today could not attend personally due to certain urgent official engagements and expressed their regret for the same. I extend my gratitude to DG Madam for nominating all the PCMDs, and I am thankful to all my PCMD friends for attending the conference in person to make it a grand success. The medical department of Eastern Railway is one of the oldest and may boast of having many facilities for the first time in Indian Railways. Biashing Hospital, having 525 indoor beds, is the biggest railway hospital in India. It had the first in-house CT scan machine installed in the year 2015, and I am happy to inform you that the first in-house MRI machine will also be installed in the same hospital very soon. We in Eastern Railway are having many dedicated super specialty services like Advanced Cardiac Center with cath lab and cardiac surgery facilities, neurology, gastroenterology, endocrinology, rheumatology, and neurosurgery units with IRHS super specialists at BR Singh Hospital. Eastern Railway has a dedicated orthopedic hospital at Howrah where joint replacement and arthroscopic surgeries are performed on regular basis. These facilities are utilized by not only patients from Eastern Railway, but patients from neighboring zones also. All our divisional and workshop hospitals are having specialists in major specialties like medicine, surgery, gynecology, anesthesia, eye, ENT, etc. As a result, we are capable of treating the majority of railway beneficiaries coming to our hospitals, and very few patients need to be referred to our tie-up hospitals. So the expenditure on tie-up hospital bills is one of the lowest in Eastern Railway among all the zones. Many of our hospitals, like BR Singh, Howrah Orthopedic, and Asansol Divisional Hospitals, are imparting postgraduate training to doctors in many disciplines. 50% of such postgraduate DNB seats are reserved for IRHS doctors. The reputation of our railway hospitals as DNB training centers is quite high, and these are the preferred choices for candidates selected through All India NEET PG examination with high ranks. We always try to upgrade our hospitals with the latest equipment and facilities so that best quality treatment can be provided to our beneficiaries. With active support of DG Ma'am and guidance of GM Sir, I am certain that the railway medical system of Eastern Railway will achieve greater heights in the coming days to the utmost satisfaction of our beneficiaries. Once again, I thank all of you for joining us today. I hope that all the delegates attending this conference from across the country will be highly benefited by the scientific deliberations of the conference and will return with pleasant memories of the City of Joy. Thank you so much.
Thank you, sir, for your wonderful deliberations, and your words provided the background behind this mega event, as well as showcased the activities of IRHSA Eastern Railway. With a series of speeches in succession, I think it is time enough for felicitation of two of our hospital staff for outstanding performance in their sphere of work and sincere devotion to duty. For the year 2023, Dr. D.P. Dashgupta Memorial Best Worker Award, instituted in the memory of a versatile and ex-physician of this hospital, comprises a certificate of merit and a cash award of rupees 1,500. I now take the pleasure of requesting our distinguished General Manager, Sri Milind K. Deoskar, to kindly present the awards to Srimati Shumana Mojumdar, Chief Nursing Superintendent, BR Singh Hospital, and Sri Biplab Dash, Housekeeping Assistant, BR Singh Hospital. Both the awardees are kindly requested to come onto the stage and receive the awards from our General Manager. Our General Manager will also be presenting a second award to Sri Biplab Dash, Housekeeping Assistant, BR Singh Hospital. Sir, it was our pleasure for doing the honors. And it is now time to listen to our respected General Manager who took over charge of this zone from his immediate past assignment as Secretary Railway Board. With years of experience of working in the railways in different capacities, let me take the privilege of inviting Sir for addressing this morning's august audience.
respected DG RHS, Madam Sugandha Raha, PCMD, Mr. Dr. Chaudhary, our DRM SEALDAH, PED Railway Board, all PCMDs, all the doctors available. It's my first time addressing a large crowd of doctors, and I'm definitely not at ease. I have spent some 35 years in Indian Railways, and as a procurement officer, I was only supporting the doctors whenever I came in contact. So when I remember that when Dr. Dalmia of Baikala Hospital wanted some good cameras and all that, he used to say that because of this procedure, I am not getting the equipment which I want. So somehow we could find a way, or maybe talk to my colleague officers to give the doctor what he wants. Same way, I remember my encounter with orthopedic doctors of Baikala. I think Dr. Vijay is quite renowned, and he wanted some particular make of implants. So maybe our government procurement policy does not permit us to get what we want, but still we could find some way. Thereafter, I had some good experience in buying everything for Mancheshwar Hospital in Bhubaneswar. So there we used to find some way that whatever machinery or whatever equipment doctors wish to have, so we will hold a meeting and maybe try to get. And we really were successful in setting up Mancheshwar Hospital, very good facilities. And of course, I had a good experience of, we were knowing only this Baikala Hospital and GRH Hospital, they are very good. Then I happened to work in Chennai, so Perambur Hospital is also very, very reputed. But somehow I had never worked in Eastern region. And after coming here, I came to know that BR Singh Hospital is very good. Orthopedic Hospital is very good, and it is not from the word of from the mouth of doctors, but it is from common man. And I know that the reputation is not made in a day. It requires toil of lot of doctors, uh, lot of people who have come here, and that's why the image has been built. And I'm really happy that this hospital is doing very well. I also had very good experience when I was DRM Pune, as a ADRM Pune and DRM Pune. I really have, you can say, helped come up this Pune hospital, so much so that in 2020 it was designated as a COVID hospital. Being a divisional hospital, and that too just a 60 bedded hospital, it was designated. And again, I will say that I had Mr. Ramakrishnan, who was CMS, and he was not only a great surgeon, but he was a good administrator also. So we could expand even through a contract some dialysis facility, physiotherapy facility. We just gave them some space and we floated a tender, and CGHS minus certain percentage, and we had, you can say, after 1 month or so, we had a dialysis facility created by sacrificing one VIP room, and technicians and nephrologists coming. And initially people were wanting that we will go to some swanky hospital, but I realized that when a railway employee, when he goes out to a referral hospital, he is actually very shy. He is his all the smartness is in the railway hospital only. When he has got a when he has got a great support of our unions, or maybe he is at ease in railway family. So I was able to say that, look, you are going, and maybe when the dialysis is due, he is asked to come a day later or something, and the frequency is not being maintained. So once we had some 20 patients, and based on the frequency we had dialysis setup, and they were very happy, they were at ease, as if I have seen in Jaslok hospital, uh, people coming for dialysis in a very very comfortable way, as if they will just inject themselves that after to compensate the blood loss and all that. So that you can say is normally that hospital syndrome or a white coat syndrome, which a patient suffers. And if somehow in our hospitals we can give such a surrounding or a setting, so at least his suffering can be reduced to some extent. In Pune division, we could convince our union persons. They were coming to me that we are not being given referral. So X person is given referral and Y is not given referral, and all sorts of issues were there. But I knew that the doctors know which case deserves to be referred and which case doesn't deserve to be referred. And somehow we could convince both the set of unions that, look, you don't go for swanky buildings and swanky hospital. It is the doctors who matter, and they will not put you in a loop of unnecessary tests, and uh, they will they will really look after your health. And I must say that uh, thereafter, after couple of months, I could find a sea change, and people were really very happy. We gave inputs, we also made efforts to make our building also, if not swanky, at least neat and clean. And as a matter of fact, we even stopped spitting. Initially uh, we just publicized that don't spit in hospital premises. Thereafter we started fining them also, and they readily paid the fines also. The And we had a very good hospital, and later on we planned for the expansion also, and the wards also, the privacy. And as a matter of fact, during when we give the treatment, the dignity of the patient is also very important. And maybe for the doctors, it is just a routine matter, and probably they are sometimes it's a routine matter for them. And what is a some special thing for a patient, and the doctors are already past that point, that I have also observed. But I will say that in Pune we had a very good experience, and doctors, even some of the doctors were very rude also. Then they also were our unions were persuaded that you want a doctor with a good bedside manner, or a rude doctor who cures you. So these were some of the experiences, and I am very happy that such conference is being held at Calcutta, where the focus is on. I just asked Dr. Chaudhary today, what is this CME? Then he said that continuing medical education. And although I know my cousins are also doctors, and they keep on going on conferences, and yes, that's true that that advancement in the technology is so much that there is a need for continuing the updation. And as a matter of fact, in dental field, I had some good acquaintances in the dental field. There, if you are not updating yourself, maybe you will be not relevant. So I must say that such opportunities where the knowledge is shared, and this will be in overall larger interest of all our railway men. And I wish this conference a great success. And I am very happy that Dr. Sugandha Raha, with whom I had interacted for 6 months, and I could see that such a compassion and such a clarity of thought at apex level. You all are really blessed that that doctor from this area who will have definitely some soft corner, and some soft corner for this place. And yes, this place is really a city of joy, which I am soon realizing. When I went to Bhubaneswar, they said that land of rising sun. They said that welcome to the land of rising sun. So this is a city of joy, and it is in your hand, because once the health of one of the member, as long as you are feeling good and your health is good, maybe all other things can be tackled. And you are the persons on whom the responsibility is that this city remains city of joy. So my best wishes for this conference. Thank you.
Thank you, sir, for your wonderful words and feelings from the core of your heart. And the solemnity of the occasion deserves a break, and that will be in the form of a release of a colorful souvenir highlighting the achievements of B.R. Singh Hospital and various divisions of this zone. I take the privilege of requesting DGRHS ma'am, Dr. Sugandha Raha, for releasing the souvenir published on this occasion. Thank you, madam, for doing the honors. Dr. Sugandha Raha, Director General Railway Health Services, highest executive of the medical department in Indian Railways, and our chief guest of the morning, will be delivering her speech now. With her vast experience and knowledge of working in various railway zones all over India in different capacities, I take the pleasure of requesting her to kindly address this distinguished audience.
নমস্কার অ্যান্ড ভেরি গুড মর্নিং। আপনাদের সবাইকে আমি আমার প্রীতি শুভেচ্ছা আর ভালোবাসা জানাই। রেসপেক্টেড শ্রী মিলিন্দ দেউস্কর সাহেব, জেনারেল ম্যানেজার ইস্টার্ন রেলওয়ে, ডক্টর মিহির চৌধুরী, PCMD ইস্টার্ন রেলওয়ে, শ্রী दीपक निगम जी, DRM SEALDAH, MD BR Singh Hospital, Dr. Shubhashish Das, organizing secretaries, presidents, PED Health, Dr. Ravindran, and I can see our ex-PCMD, PED Health, Dr. Malhotra Sahab also, PCMDs, NWR, NCR, South Central Railway, Central Railway, Northern Railway, Eco Railway, Western Railway, ECR, NER, and SWR. All the delegates, PCMOs, MDs, CMGs of the Indian Railways, and all the doctors present here. It's a great pleasure to be at Kolkata, my own city, for the 49th Annual Scientific Conference organized by IRHSA, Eastern Railway. Standing here at dais, it's mixed feelings for me because I have started my journey of Indian Railways with Eastern Railway. I had my field training in BR Singh Hospital. As probationer, I have an image of BR Singh Hospital. I have learned so many things from BR Singh Hospital with so many stalwarts guiding us. So being here with Eastern Railway, with BR Singh at this BC Roy Hospital, it's very close to my heart. I would thank Shri Milind Devskar ji, GM Eastern Railway, for giving me this opportunity. Also, I would thank the organizers for their efforts to make the event possible. The medical science is advancing fast. We must update our knowledge, skills, techniques, so that we will be at par with the world around. This conference is aiming to provide the same, and the theme of recent advances in medical sciences conveys it all. Each and every field of medicine, modern medicine, is having some or other new concept which should be utilized in our day-to-day activities, our practices. May it be etiology, pathogenesis, evolution of disease, presentation of patient, symptoms, clinical science, differential diagnosis, diagnostics, pharmacology, and progress and course of the disease. It includes all. This will help us in alleviating the problems faced by our beneficiaries at large. Each patient is unique in her presentation of disease, and same is true for reaction or response to the treatment. So sharing our knowledge and experience by discussions in such conferences enriches us to tackle the various clinical conditions intelligently and confidently. Here again, I would like to emphasize that the knowledge helps us to know about the do's, and the experience sharing guides us about do's as well as don'ts. So sharing the experience of facing or tackling difficult cases, the negative responses, or adversities faced during management of cases do help us by equipping on what not to do. I am happy to know that surgical workshops were held yesterday. Discussions related to various streams, onco, cardio, obs gynae, ophthalm, endocrino, neonatology are arranged. Again, I would take this opportunity to request you all to please conduct preventive and promotive health activities also. Special emphasis should be on number one, health checkup camps to detect early diabetes, hypertension, cancers, gynecological cancers, oral cancers, where early detection is easy and leads to better quality of life and less morbidity. Number two, health awareness activities, especially regarding hygiene, nutritional issues, obesity and its complications. I think our ADMOs will face the obesity problem in near future. Most of their OPD patients, either in pediatrics or in adult, will be having obese morbidity problems and complications related to it. We should also stress upon importance of regular exercise, menstrual health, and early symptoms of cancers, antenatal and postnatal health conditions, immunizations, vector and waterborne diseases. We must reach out to our beneficiaries, especially women employees, women dependents of serving employees, as well as retired employees. As I always say, our women employees or say women dependents of serving employees or retired employees usually don't like to visit hospitals. So conducting health checkup camps or health awareness activities, especially in colonies where they will feel comfortable rather than conducting it in hospital, I think will help our society, our railway organization. With this, I would like to thank again the General Manager, Eastern Railway, for providing guidance for organizing this conference. Also, thanks to PCMD Eastern Railway and his team for making this conference happen. And I would thank DRM Shialda and his team for the strong support offered for carving the dreams into realities. I wish a grand success to this conference. Thank you all. Namaskar.
Thank you, Madam, for your wonderful words. Your vision and advice will provide the much needed encouragement and inspiration to the serving officers and newer entrants to the medical department. Before we close today in this morning's program, it is time to offer our thanks and gratitude to our guests and dignitaries present on the dais as well as off the dais. Dr. Arnab Mitra prefers to be in silent mode today. Hence, I will be inviting Dr. Chayan Bhattacharya to come and propose the vote of thanks.
Respected ladies and gentlemen, dignitaries, our esteemed guests, and members of the Railway Medical Fraternity, I, on behalf of IRHS Eastern Railway, express my sincere gratitude and heartfelt thanks to our esteemed DGRHS Railway Board, Dr. Sugandha Raha, for sparing her valuable time in attending this function and the CME program. Our thanks go out to our respected General Manager, Eastern Railway, Sri Milind Kumar Devaskar, for making it convenient to attend this inaugural ceremony in spite of his extremely busy schedule. We acknowledge the kind presence and participation of AGM Eastern Railway, PCMD Eastern Railway, DRM SEALDAH in this August inaugural function. We are extremely grateful to all PCMDs from other zonal railways present on this occasion for helping us to make this inaugural ceremony a grand success. Dr. Shubhankar Home, Secretary IRHSA BR Singh, and Dr. Ashok Shaha, Honorary Secretary IRHSA, deserve a special round of applause for their untiring support and cooperation. I'll be failing in my duty if I do not acknowledge the participation and help received from all our sister departments, print and electronic media, CPRO's office, and the innumerable workers who have worked tirelessly to make this program and conference a grand success. Thank you all.
Thank you, Dr. Chayan Bhattacharya. With this, we wind up today's program, and I place the request to our guests to stay back for some time more for a grand debate, IIHM debate, on the very relevant yet controversial topic which we will be presenting shortly. Thank you. Thank you for being here and being such a supportive audience.
ওদেরকে ডাকি একটু রেডি করি, ওদেরকে একটু ব্রিফ করে দিই। দেখো নিচে সব কি হচ্ছে। তুলে নিয়ে গল্প খাওয়া হয়েছে জাহাজটাকে এদিকে সরানো যাবে?
স্যার একটু এই সাইডে করা যাবে।
অন্যটা দাঁড়াবে।
এখানে এসে বলবে।
ও এখানে এসে বলবে?
এখানে এসে বলবে।
দেন ইটস ওকে।
হ্যাঁ, তাহলে একটু বাস আর করো না। ঠিক আছে।
তাহলে সঞ্জিতা দি দেখতে পাচ্ছ এখান থেকে? এখানে দাঁড়িয়ে বলবে ডিবেটার উইল স্ট্যান্ড হিয়ার। ঠিক আছে বলতে এটা হলে এখান থেকে দেখা যাবে না। স্টেজটা আচ্ছা বড় মিলে
So good morning, ladies and gentlemen. After a days of scientific deliberations and the inaugural session in the morning, it's time for a little change. It's time for the IIHM grand debate. And for that, we have eminent personalities from different walks of life. So equitable healthcare in India is a mirage or not. That's what we're going to debate today. And for that, may I call on stage our first debater, who's a name to reckon with in the world of healthcare in Eastern India. He is a person with inherent talent to look beyond barriers, has an eye for futuristic views and induction of new technology. He's been one of the most versatile leaders, leading several corporate hospitals before joining AMRI Hospitals as Group CEO in 2014. Since then, he has taken over the role of advisor strategy and planning to Manipur hospitals in December 23. A health care career spanning over 3 decades, he has held several leadership positions in major corporate hospitals. Ladies and gentlemen, please welcome on stage to speak for the motion, Mr. Rupak Borua. Our next debater, he is a creative, innovative, and enthusiastic professional with 17 years of qualitative experience gained as a reporter, story contributor, editor, and key planner across media industry. A founder member of the famous health magazine, Shorir Oshasto. He is the 5th Bengali to receive the prestigious Statesman Rural Reporting Award in 2017 for pre-assembly Jungle Mahal coverage. He has, to his credit, covered pre-Lok Sabha elections of 2019 in Tamil Nadu and Karnataka, and also the West Bengal Assembly elections in 2021. He has nurtured contact base in literally everywhere, from WHO to UNICEF to NMC, from pharma industries to doctors and corporates. Please welcome a person who puts relentless attention to details in a fast-moving, breaking news environment, Mr. Bishwajit Dash. Please. So he'll be speaking against the motion. And our next speaker, well, many of you would be knowing her well. She has been in the field of education for over 32 years and did her graduation and post-graduations from the iconic institutes like St. Xavier's College, Presidency College, and Calcutta University. She has been recognized by the British Council for incorporating international dimensions in the school curriculum and mentoring different schools. She has received several awards as an inspiring teacher, a principal, and innovative educator. The Mother Teresa Award for Education, honored with one of the most impactful school leader award in 2023 by the IPN. Please welcome the principal of an internationally renowned school with nearly 2 centuries of education excellence, La Martiniere for Girls, Mrs. Rupkatha Sarkar. She'll be speaking for the motion, And our next speaker, after doing her master's in broadcasting from the University of Sheffield, she was a lecturer in journalism and marketing communication at St. Xavier's College for 6 years. A regular contributor to newspapers with her own fortnightly columns, she has authored official coffee table books. A fundraiser for charities, she has been an entrepreneur for over 35 years. The founder CEO of India's only brand of fitted garments, Necessity. Please welcome a lady who has a big fan following among youngsters, and a person who loves to debate both in Hindi and English. This is Swati Gautam. And our next speaker is an iconic face in the finance world and one of the youngest ever Bengali chartered accountants to have been elected as the chairman of the Institute of Chartered Accountants in India. In the professional field, he has a strong corporate exposure of 16 years in the world's best MNCs and top private sector banks in India. A former retail credit head of Yes Bank, a former zonal credit head East in ICICI Bank. He has strong communication skills and an ability to influence people. Please welcome the man with a strong visibility in the press and media, both local as well as national, Chartered Accountant, Mr. Anirban Dotto. And finally, the last speaker who will be speaking against the motion is a consultant surgeon, both vascular and endovascular surgery with the AMRI hospitals. He serves as an examiner of Royal College of Surgeons, Edinburgh, has a keen interest in medical laws and ethics, serves as the collaborative reviewer of the Institute of Medicine and Law in Mumbai, and was the course coordinator of PGDML, a postgraduate program administered through NUJS, Kolkata. He has been a keen debater and has a strong lateral interest in the social perspective of medicine. So please welcome a doctor who has been a regular writer in mainstream newspapers over these issues, and an avid debater over the years, Dr. Krishnendu Mukherjee. And finally, a person we are privileged to have amongst us today. He is one of the best known writers on business and economics and a biographer of the men behind business. He runs his own research, survey, and writing company. He is a co-founder of Bengal Initiative, a liberal think tank, an author and advisory editor, Kolkata on Wheels. He is a founder trustee of Kolkata Debating Circle. He is a secretary, Bengal Chamber of Commerce and Industries. His books include Calcutta Medical College, 190 Years of Excellence, $1 Million Smiles, and a host of others. He has been a welfare worker over 30 years. Please welcome a person with over 500 articles in Economic Times and Business Standards, a person we feel honored to have as our debate moderator, Mr. Pradeep Guptu. And with that, I hand over to our moderator, Mr. Pradeep Guptu, to take over from now on. And I hope you all sit back and just enjoy it.
Thank you for the very kind series of introduction. I'm sure all the ladies and gentlemen seated on the stage will thank you with equal warmth for the very kind words you said about us. I am completely unqualified, underqualified, non-qualified to be sitting in this chair in the presence of Krishnendu Da, eminent writers like Vishwajit, my partner in crime in Calcutta debating circle, Swati, Mrs. Sarkar, Rupak, and Anirban. We have a tight schedule to maintain, so first the rules. There is only one rule: do not exceed your time. There is also a suggestion: do not cross over to the other side. I know elections are approaching, don't do that. So it's not advisable. There are two teams: for the motion and against the motion. And the motion is something that agitates our mind at the present time. Equitable healthcare in India is a mirage. I am sure the wonderful speakers we have on the dais will entertain you, inform you, educate you, and above all, make you think, so that even after you leave the hall, you will have a memory of this debate and the issues that they have raised. And I'm quite confident, given the wonderful quality of speakers, we will be discussing issues and not individuals. And we will be discussing, perhaps we will be lucky enough to get a view into what can be some sort of way forward. To be fair, we are here in a medical conference. Equitable healthcare by itself is unfair. Why not equitable education system? Why not equitable judicial redress? To put the burden of, is it a wrong English, Swati, to say equitability on healthcare alone is perhaps not such a fair thing. But so let us hear what our thinkers on stage have to say. For the motion usually goes first. The time you have been permitted to speak up to 8 minutes, but there are only 6 of us here. And Swati there's going to be some degree of parallel banter here. She can't let go of this. So from your side, who will be opening? Yes. So can I ask Rupak Borua, an eminent public person and a thinker, a commentator in the media who doesn't get into trouble? Rupak, over to you. Yeah.
Good afternoon, everyone. I will not waste my time because speaker already we have been given this your 6 to 8 minutes time maximum. I'd just like to come to the point of discussions today. The subject matter: equitable healthcare in India is a mirage. I'm not whether it's a you agree or not agree. That's a different issue. But I would like to put forward few of the challenges which Indian healthcare is facing. And now you are the best judge to decide whether it's a reality or a dream. First of all, Indian healthcare, all we know that Indian healthcare is growing everywhere. You all are the doctors and you all know because you are fully involved with this subject. But one basic thing we need to understand, that's the population, the diverse population. Exceeding 1.4 billion population in India is an incredibly diverse socioeconomic status, your culture, your geography, and it's actually putting India to introduce this your equitable healthcare is a great challenge in both in terms of financially and it's logistically. First of all, I would like to let you know that I'm criticizing. I'm just putting forward some of the practical issues which the Indian healthcare is facing as of today. There are 3 subjects whenever we are discussing about equitable healthcare, 3 areas that we'll have to understand, we'll have to highlight. That is one is the infrastructure, because the patients, the population will have to get access to the property or the hospitals, whatever you are talking about. The second one is the financial part that we'll have to take care, we'll have to see. And the other part, that's one of the major challenges, is the human resources that we know. Now, so far the infrastructure is concerned, we need to understand that predominantly this is Indian healthcare, though it's a government support is required in terms of accessibility to healthcare, but the only 2.1% of the total outlay of this your budget, in terms of your healthcare budget, it is extremely difficult for Indian healthcare to provide accessible healthcare. Now, what's the rest? Rest is the private healthcare. The private healthcare actually is dominating 70 to 75% of the total healthcare infrastructure as of today. Now, there is a dichotomy in terms of the population, divide the population. The population is a 30% population actually stays in this urban area, 70% population actually in this rural areas. But if you talk about this infrastructure, the healthcare infrastructure, availability of healthcare infrastructure, there is 75% of the total infrastructure, healthcare infrastructure I'm talking about, is available in the urban area. 25% around is there in the rural areas. So the major issue is 75% of the healthcare infrastructure is being enjoyed by 30% of the population in urban area, and around 25% of the healthcare infrastructure is being enjoyed by this 25% of the 70% of the healthcare, 25% of the healthcare infrastructure is being enjoyed by 70% of the population in the rural areas. That is one of the major issue, that is accessibility of the healthcare. Now, whenever we talk about accessibility healthcare or equitable healthcare, there are two parts actually. One part that the service delivery, access to the service delivery, and the other part is the financial protection. Whenever we talk about financial protection, that's all we know that how we are managing. 63% of the total expenditure is out-of-pocket expenses. 63% of the total expenses, healthcare expenses. 39 million people, 39 million population actually, every year goes under this poverty because of this healthcare inequality. Now the question is how to sort out the issue. Now, if you see this world, our global average, that is 22% only. 22% is the out-of-pocket expenses. In our case, 63% is the out-of-pocket expenses. There is no other way that the people, because of this inadequate support system in the public sector, because it's obvious, I'm not criticizing, but it is only 2.1% of the total GDP. If it is being spent in this healthcare, it's very difficult to provide equitable healthcare to population, the 1.4 billion population. Now, if you see this infrastructural deficiency, there is a per 10,000 bed. If you see, our bed strength is only 12 as of today, per 10,000, means 1.2 per 1,000. If you see the global trend, there is almost 29 beds per 10,000. Now, if you really want to reach out to this equitable healthcare to 1.4 population, and you can understand what number of beds or what kind of infrastructure you will have to develop. Come to the point, whenever you have the infrastructure, you have the financial protection. Now, what will happen to this human resources? If you see the human resources today, it's an incredible situation, human resources. There is no doctor. It is very difficult to get a doctor, very difficult to, the nursing shortage is a huge nursing shortage, and the paramedic staff as well. Our doctor strength, by 10,000, it's 9 doctors per 10,000 beds, 10,000 population. And if you see the global average, it is almost 18. So means is that we are just managing. I'm talking about the global average, considering all the countries, there is only 9 we have. So it is just half of the strength of the global average. If you talk about the nursing strength, we are having around 17 global average, but it is there in the global trend, it is 38. So there is 50%, almost half of the average of the global average, we are managing the human resources. So that is one part, a solution. major solution, as we are talking about 63% of the total, your 63% is your total out-of-pocket expenses. That's the only solution is the insurance. Government is talking about the insurance by 2047 we'll be able to reach cover the population is almost your 56 or 60%, but by 2047, as of today, it is a 15% is the population we are covering. So until and unless insurance sector is not aggressive, is extremely important. That is, equitable healthcare in India will be a mirage. Thank you.
That's absolutely perfect timing. 2 seconds short of 8 minutes. Thank you. That's a wonderful opening presentation. And I think the two takeaways from that is the challenge between access and the cost of healthcare. And from the non-medical side, the terror of every family who understand that healthcare can actually be a socially, financially destructive transaction with society. This is something that every family in India, in some way or the other, either directly or indirectly or through close relatives, experience. So against the motion, who's going first? Krishnenduda. I see. So we have Brian Lara on one side and Virat Kohli on the other. Please. Oh, he would like to be described as Malcolm Marshall, the star bowler. Over to you, Krishnenduda.
Should I kneel down or because the mic is... Okay. Namaskar. Like any publication in a good medical journal, I think I'll have to start by declaring conflicts of interest. Number one, Mr. Rupak Barua is a very good friend of mine. Number two, I do not support any political party. And number three, Mr. Pradeep Gupta is also a very good friend of mine, and he understands the importance of equitable debating. So since I'm a weaker speaker than Mr. Rupak Barua, I'm sure he's going to allow me 1 minute extra time. Mr. Barua has drowned you with statistics, some of them were wrong, and with problems. In the process, he got drowned himself. Ladies and gentlemen, we know there are problems in trying to even think of equitable healthcare in India. That is the reason we are here to debate on it. Now, if you want to prove that it is a mirage, you will have to prove those problems are insurmountable. We are here to accept, yes, there are problems, but we are here to offer you solutions that, yes, it's possible and some positive steps have been taken. Mr. Barua said that the population of India is huge, it's 1.4 billion, as if the population is increasing day by day. To be honest, no. The population of India is now steady, showing early signs of decline. He told you out-of-pocket expenditure, OOP, is 63%. Yes, it was in financial year 14-15. In financial year 19-20, out-of-pocket expenditure has come down to 42%. So some right things are being made somewhere. But the most important thing that Mr. Rupak Barua said is that we are a very diverse and heterogeneous population. Ethnicity, socioeconomic status. Ladies and gentlemen, that is precisely the reason we need to think of an equitable healthcare. Mr. Chairperson, equitable healthcare is not synonymous to equal healthcare. The route to achieving equity, and this is not me saying, this is Paula Dressel, the route to achieving equity will not be accomplished by treating everyone equally. It will be achieved by treating everyone justly as per or according to their circumstances. So equity in healthcare rests on fairness, decent and reasonable and honest submission of what you can offer and what you cannot offer. It is perfectly equitable to say that we cannot provide anything more than palliative care if you are diagnosed with a cancer above the age of 80. If you have to afford it yourself. We cannot offer you primary angioplasty and AMI in a small district rural town. We cannot offer you laparoscopic repair of an inguinal hernia. It has to be a standard approach that is perfectly equitable. Now, one very important thing, ladies and gentlemen, when we talk about healthcare, we tend to think of diseases. Fracture eczema, breast cancer, strokes, heart attacks. That's a lot of medicine into it. But from the individual, from the personal, you have to move away to the collective. Otherwise, you will not be able to understand what is actually equitable healthcare. That has got much more to do with economics, sociology, and of course, politics. Now, it does not start with the science of medicine. And as rightly pointed out by Mr. Rupak Bodua, it does start with things like infrastructure, economy, human resource, etc., etc. Now, we have 806 districts. At a go, we need about 40 to 45,000 crores to create more infrastructure. I'll talk of human resources later if time permits. And we spend only 2% of GDP, right? Malaysia, Thailand to our right, Tunisia, Uganda to our left, they have done much better than us. We have done better than ourselves. Our Kakwani index has improved. But what then is the way forward? From Konkan railways to power and energy to infrastructure, government has floated bonds. Why haven't you thought of a national healthcare bonds offering 7% or 7.5% tax-free interest? Within 6 months, government of India can get 50,000 crores. That's enough to build the infrastructure and the running facility in 806 districts. Now, do you know the reason why it cannot be done, ladies and gentlemen? And that is the real crux of the motion today, because unless that happens, we can never begin to provide equitable healthcare. Health belongs to state subject. That is the legacy of the British colonial rule from 1935 Act. And only 1/3 of the expenditure is the center and 2/3 is the state. We need an essential amendment to our constitution where power of health enactment is with the center, and then power decentralizes to the municipalities. Once that happens, it's relatively easy to, like what the Indian Railways have done, to rake up enough money from the community itself to build up infrastructure. You talk of human resources. We have had knee-jerk responses, increasing number of seats in MBBS, increasing number of seats in MDMS, DM. But that's a long-term plan. Where does the training come from? What about the indigenous informal providers? I have personal experience with it. For 6 years, I have run a training program for informal healthcare providers. We have received parliamentary recognition for it. Have you heard of ASHA workers, accredited social healthcare activists? ASHA workers and Anganwadi workers, they have done a great job in some states, particularly Karnataka. We need to mobilize, train, and regulate these informal providers. You do not need a doctor for every primary health center. Now, obviously, the question is, if power is decentralized to the local municipalities, what about pilferage and corruption? Ladies and gentlemen, the protection against corruption and pilferage is not through ED and CBI. It is through empowerment through digital technology. And that too has started, Ayushman Bharat Health Account. If we can empower people with their mobile phones that this is what they're supposed to get, this is what the government can afford, then automatically there'll be a reduction in pilferage, corruption, and there'll be an improved accountability from the entire healthcare delivery system. So it is possible. It is not a mirage. Thank you.
Thank you. Dr. Krishnendu Mukherjee never ceases to amaze me. And this speech in particular, you have 1 more minute? Oh, I see. I thought he was going back to resume his speech for a moment, which would really strain the laws of equitable debating, let me assure you. No, I was so amazed that for a person who said who does not belong to any political party, His suggestion on the healthcare bonds will make a lot of finance ministers at multiple state capitals and at New Delhi to think about it. Because it is true, is it not, that you have enough good people in this country to support a good initiative. Swati runs an NGO, she will tell you. Only yesterday, and it's a sheer coincidence, I'll take 30 seconds of your time. Yesterday, my Rotary Club commissioned a blood bank worth 1.2 crores at the Howrah Municipal Corporation, entirely from CSR funds of our members. The Sheetal Ghosh Thalassemia Center is now equipped with a comprehensive blood bank. The government did not pay anything. It only provided a derelict building, which we renovated and put up that blood bank, spread over 2,500. So it's very reassuring to know that we have people in society, businesses and otherwise, who are willing to come forward to invest in equitable healthcare infrastructure. Not that it should influence you anyway on the progress in this debate. So who's the second speaker from the proposition? Mrs. Rupkata Sarkar. Please, ma'am, we are very eager to hear another non-medical view after Krishnendu Das' medical perspective on this motion.
Good afternoon, and thank you so much, moderator, sir. Sir actually trains my debaters in school, my girls. And today, you know, I am a little wary to stand here and be one speaker on the same stage as him. But, well, sometimes you have to try out what you hear and what you are trained with. Well, a non-medical person talking about equitable healthcare is a very humbling experience and slightly anxious moment for me. Standing in an auditorium, which I was told was one of the first auditoriums in the city, named after one of the most famous doctors in the country, Dr. Bidhan Chandra Roy. What a fitting place to have a debate of this nature. My speaker before me, Dr. Krishnendu Mukherjee, a very stalwart person, actually made our work easy, proposing the motion. I was thinking when Sir Rupak and I were just exchanging our notes, and he said, well, the statistics that I put forward of 63%, you know, out of pocket has actually increased by now because it was 2022. And what Sir Krishnendu said was actually what we are talking about. That yes, there is a way forward. We are human beings, we will evolve, we will make a change. But what is the situation now? We are talking about that. And thank you, sir, for helping us to propose the motion. You've actually furthered our motion. Health is wealth. This morning when I was talking to my son, he said the London School of Economics alumni have actually organized a work program where they have said that graduates, wherever you are, work towards a program where you can make a difference in your environment. And so he was at the beach trying to clean the refuse that was there, helping to make an environment that would be more sustainable to the people living. Ladies and gentlemen, this is exactly what we are saying. Healthcare begins at a very grassroots level where people are aware of their health. People in the rural and urban areas know what is good for them. Today, people in the urban areas, are we really aware of our health? If we are not aware of our health, then how do we take care of our health? We will drive our own cars in a family of 4 or 5. We have 3, 4 cars. We don't think of carpooling. And I say this with great anxiety because in our school we tried it. And we have people from very affluential families and homes. Of course, they may have their good reason, but they do not want to carpool.
So, ladies and gentlemen, where are we standing? We are talking about equity, equitable healthcare. A difference between equality and equity. We must be very clear and understand what is equality and what is equity. Children from this side of a school compound wanting to watch a football match on the other side of the compound has a wall in between. You may be knowing this example. So they are provided with some boxes, same size, same height. But the children who are watching are of different heights. So some of them get to see, some of them don't get to see, but they all have equal size boxes. Today, we are not talking about equality, we're talking about equity. That means you give things according to the need of the person. You provide resources according to the need of the people. In a country like India, where we have so much of diversity in terms of demography, geography, race, culture, it really requires a lot of thought to provide an equitable healthcare system. Even in an urban area, we feel that we have access to hospitals. But you and I can touch our hearts and say, when we fall ill, we think which hospital to go to. We first look at our bank balance, whether we will be able to, we can manage it or not. Personally speaking, I'm scared to fall sick. And then when we do these blood tests in different pathological institutes, people coming and doing it, we are thinking whether the report we get will be ours or somebody else's. And it has happened. So it's not that only rural areas are suffering because of there is a lack of understanding, awareness. We heard from our moderator how the civil society is getting together to help people who need healthcare. I think this is a very, very important thing. Sometimes, we feel, all right, we will, do a medical camp. We have some medicines, we have something, which is already there in the stock, and we pick up our bags and we drive our cars and we go to a place and we distribute, we take a photograph and we post it on social media. But maybe those medicines are of no use to the people there. They don't need it. They need clean toilets. They need good, nutritious food. So it's time now that we look at equitable healthcare, and it is a mirage. Morichika. Mone hocche পাচ্ছি কিন্তু পাচ্ছি না মনে হচ্ছে এই পৌঁছে যাব কিন্তু পৌঁছাচ্ছি না So, ladies and gentlemen, it's time when each one of us will have to contribute in our own way to go forward to provide for this equitable healthcare system in our country. We know all, if you open the Google, all the the reasons will be there why we cannot or why we do not have it. But today, I think in the presence of so many doctors and entrepreneurs and people who are thinking about health, when we have gathered together, let us not waste this time. This is a very serious resource we have in our hands. Let us think of ways how we can make access possible for every person, the right kind of medical facility possible, and also to move ahead so that, yes, irrespective of any government or any nation, we move towards good health, which is not only of the body, but also of the mind. Thank you so much.
Thank you, Mrs. Sarkar. I think what she's really highlighted in her speech is that healthcare is not when you go running to a doctor saying, my child is unwell or my parent is unwell, or terrifyingly, I am unwell. It's your exposure to the environment, the pollution, the preventive part of healthcare that she has highlighted in her speech. And that's indeed something that we need to pay a lot of attention to. I think Krishnaduda will agree, the air quality index in Kolkata, for example, and the noise pollution level in our city can be directly connected to many of the ailments that our hospitals have to treat, particularly relating to air quality index. I, for one, am a sufferer of the air quality index in the area I live and the area I work in, which is essentially Park Street and Dalhousie Square. So let's get to the second speaker, Bishojit. Bishojit is an eminent writer on the healthcare sector, and he will speak in Bengali. And I'm sure, given the force and power of his arguments, he will persuade you despite varying levels of proficiency in that language. Bishojit, over to you.
প্রথমত সবাইকে ধন্যবাদ জানাই, কারণ আমি এখানে আসার পর থেকে মুগ্ধতা আমার পিছু ছাড়ছে না। আমার যখন কেরিয়ার শুরু হয় তখন কলকাতা রাজবাড়ি বলে একটা বিভাগ নিয়ে আমার কেরিয়ার শুরু হয়েছিল। তারপর ধাপে ধাপে বিভিন্ন ক্ষেত্রে ছড়িয়ে পড়ে। তো এখনো পুরনো বাড়ি, পুরনো খিলান, বড় দরজা, বিশাল বড় জানলা, সুন্দর কাজ, এসব দেখলে মুগ্ধ করে। আর যখন আমি নামলাম, আপনাদেরকে প্রচুর ধন্যবাদ জানাই যারা আয়োজক, তারা আমাকে, আমার মতো সামান্য মানুষকে আপনাদের মাঝখানে আসার সুযোগ করে দিয়েছেন। আর আমি বারবার মুগ্ধ হচ্ছি আর ভাবছি যে কি কি করা পসিবল ছিল, কি কি করা সম্ভব, আর্কিটেকচারে, স্থাপত্যে কি কি করা সম্ভব, এবং এই অডিটোরিয়ামও এত সুন্দর করে বানানো, এত সুন্দর একটা ভারসাম্য রাখা হয়েছে, বাইরেও এত সুন্দর একটা ভারসাম্য রাখা হয়েছে। আমার সম্ভবত এই ভারসাম্য নিয়েই যাবতীয় কথাবার্তা। আমি একটা গল্প দিয়ে শুরু করছি। সেবার আমার দায়িত্ব ছিল হচ্ছে বিধানসভা নির্বাচনের আগে সরকার কি কি প্রতিশ্রুতি রেখেছে, যা যা দাবি করেছে তার কতটা করেছে, কতটা করেনি। গোটা জঙ্গলমহল এলাকা আমার দেখার কথা ছিল। তো বিভিন্ন জায়গায় ঘুরছি আর কি। ঘুরতে ঘুরতে বাঁকুড়ার খাতড়া বলে একটা জায়গা আছে, কোনো জায়গায় গাড়ি থেকে নেমে যাচ্ছি, কোনো জায়গায় বাইকে করে ঘুরছি, কোনখানে হেঁটে ঘুরছি। তো গাড়ি করে ঘুরতে ঘুরতে দেখলাম যে বাঁকুড়ার খাতড়ার একটা মোড়ে আমরা যেরকম টিভি সিনেমায় দেখে থাকি একটা দুর্গা মণ্ডপ, ঠিক ওই রকম একটা দুর্গা মণ্ডপে কয়েকজন মানুষ বসে গল্প করছেন। তো আমি গাড়ি একটু আগে রাখলাম, নেমে দাঁড়ালাম, গিয়ে তাদের কাছে গেলাম। তারা তো প্রথমে অচেনা লোক দেখে ইতস্তত বোধ করলেন, তারপরে আস্তে আস্তে তাদের আর ভাঙলো এবং তারা গল্প করতে আরম্ভ করলেন। যাদের মাঝখানে আমি গিয়ে পড়লাম তারা সবাই সম্পন্ন চাষি। তারা সব গল্প করছেন এবং গল্পের মূল বিষয় হচ্ছে তাদের জন খাটার লোক নেই। আমি বললাম এরকম হলো কেন? তো তারা বললেন যে 100 দিনের কাজ চালু হয়ে গেছে, আমাদের জন খাটার লোক পাচ্ছি না। আজকের যে বিষয় নিয়ে আলোচনা, এই বিষয়ের পক্ষে আমার বলার কথা থাকলেও আমি এই সামান্য একটা দুটো মোড়ের কথা উল্লেখ করছি, যেখানে আমরা বেসিক্যালি আজকে এই নিয়ে আলোচনা করার জায়গাতেই নেই। তার কারণ হলো আমরা আরো 10 বছর আগে এরকম আলোচনা করলে ঠিক আছে, যে আমরা পাহাড়ের ওপরে দাঁড়িয়ে আছি আর আমরা নিচে যারা ইকুইটেবল হেল্প পাচ্ছেন না তাদের নিয়ে আমরা দুঃখ করছি, কষ্ট করছি, দারিদ্র বিলাস করছি, তারপরে গাড়িতে চাপছি, ঠিকঠাক জায়গায় চলে যাচ্ছি, তারপরে আবার আমরা এরকম একটা ডিবেটে অংশ নিচ্ছি। আসলে আমরা এই জায়গাতেই নেই, আমরা এখন উল্টো সাইডে আছি। সত্যি কথা বলতে গেলে যদি ইকুইটেবল হেলথ কেয়ারের কথা বলতে হয়, আজকের মতো ইকুইটেবল হেলথ কেয়ারের জায়গায় পৃথিবী এবং ভারতবর্ষ এর আগে, আমি ভারতবর্ষের কথা আরো নির্দিষ্টভাবে বলি, এর আগে ছিল না। যে লোকটা, যে খেটে খাওয়া লোকটা 10 বছর আগে বাইপাস সার্জারি করার কথা স্বপ্নেও ভাবতেন না, 15 বছর আগে স্বপ্নেও ভাবতেন না, এখন ইন্স্যুরেন্সের কল্যাণে, বিমার কল্যাণে তিনি প্রথম সারির একজন ডাক্তারের কাছে বাইপাস সার্জারি করাতে পারেন এবং ইন্স্যুরেন্স কারা দিচ্ছে। 1952 সালে ইএসআইসির প্রথম ইন্স্যুরেন্স স্কিম শুরু হয়, ইএসআইসি। আপনারা যাদের মাঝখানে, যে সম্মানীয় মানুষজনের মাঝখানে আমি দাঁড়িয়ে আছি, আপনারাও একটি ইন্স্যুরেন্স স্কিমের মাধ্যমে সুরক্ষিত, সিজিএইচএস। ইএসআই এর মাধ্যমে শ্রমিকরা সুরক্ষিত এবং পশ্চিমবঙ্গের নাগরিকরা এখন স্বাস্থ্যসাথীর মাধ্যমে সুরক্ষিত। দেশের একটা বড় অংশের মানুষ আয়ুষ্মান ভারতের মাধ্যমে সুরক্ষিত। বস্তুত এখন সরকারি এবং বেসরকারি স্বাস্থ্য পরিষেবা বলে কিছু নেই। এখন যা আছে তা হচ্ছে ইন্স্যুরেন্স সেক্টর। ইন্স্যুরেন্স সেক্টর রামু সর্দারকে আর যতীন সামন্তকে এক জায়গায় দাঁড় করিয়েছে। ইন্স্যুরেন্স সেক্টর কালা বিবিকে এবং স্বর্ণলেখা মুখোপাধ্যায়কে এক জায়গায় দাঁড় করিয়েছে। হ্যাঁ, বলতে পারেন এখন স্বর্ণলেখা মুখোপাধ্যায়ের অসুবিধা হতে পারে যে কালা বিবি কেন তার পাশে চিকিৎসা পাচ্ছে। কালা বিবি এরকম বড় বড় চোখ করে দেখাতে পারে, বাবা কি বড় টিপ, কি সুন্দর কাজল পড়েছে। কিন্তু ইন্স্যুরেন্স সেক্টর ভবিষ্যতের 50 বছর নিয়ন্ত্রক হতে চলেছে। কোনো সরকারি ক্ষেত্র নয়, কোনো বেসরকারি ক্ষেত্র নয়। ইন্স্যুরেন্স সেক্টর, স্বাস্থ্য বীমা ক্ষেত্র, এই এখন পূর্ব ভারতে দেখা যাচ্ছে হেলথ কেয়ার সেক্টরে একটা বুম লেগে গেছে, সবাই এসে বিনিয়োগ করছেন। একটি বড় হাসপাতাল গোষ্ঠী ছোট ছোট হাসপাতাল গোষ্ঠীকে কিনে নিয়ে প্রায় 8টি হাসপাতাল হয়ে গেল। সবার মনে হতে পারে পূর্ব ভারতে প্রচুর রোগীর চাহিদা আছে, পূর্ব ভারতে রোগের চাহিদা প্রচুর আছে। সেসব তো আছেই, না হলে সারা দেশের পূর্ব প্রান্ত থেকে পূর্ব দিকের রাজ্যগুলো, দেশগুলো থেকে বা উত্তর এবং মধ্য ভারতেরও কিছু জায়গা থেকে এখানে আসে কেন? আসল কারণ হচ্ছে যারা এই বিনিয়োগটা করছেন তারা খুব ভালো করে জানেন যে টাকা দেবে কে? টাকা দেবে হয় সরকার দেবে, নয়তো বীমা কোম্পানি দেবে। 10 বছর আগে এই সিচুয়েশন ছিল না। বড় বড় বেসরকারি হাসপাতাল ক্ষেত্র তারা চোখ রাঙিয়ে বলতো যে ভাই, তোমার কাছে নগদে টাকা থাকলে তুমি আমার কাছে পরিষেবা পাবে, আর তোমার কি ইন্স্যুরেন্স আছে? ওই ইন্স্যুরেন্স কোম্পানিকে বলতো তোমরা পিপিএন এর মধ্যে আমাদের আনার চেষ্টা করো না, প্রেফার্ড প্রাইভেট নেটওয়ার্ক, আমরা করবো না, তোমরা যাও, এখান থেকে বেরিয়ে যাও। এখন ঠিক উল্টো কথাটা তারা বলতে বাধ্য হচ্ছে। তার কারণ হাসপাতালে যারা আসছে এখন, তারা সরকারি হাসপাতাল হোক বা বেসরকারি হাসপাতাল হোক, তারা কোনো না কোনো ইন্স্যুরেন্স সেক্টরের মাধ্যমে সুনিশ্চিতভাবে চিকিৎসা পাওয়ার কিছুটা অধিকার অন্তত অর্জন করেছে। এই প্রথম পরিকল্পনা যখন শুরু হয়েছিল 2003 সালে, যশস্বিনী যোজনা, একজন বিখ্যাত নামজাদা হার্ট সার্জন, তার নাম ডক্টর দেবী শেঠি, তিনি এটা শুরু করেছিলেন। তারপরে কালক্রমে 2012, 2013, 2014, এখন 25টা স্বাস্থ্য বীমা যোজনা আছে সারা দেশ জুড়ে। 25টার বেশি হবে তো কম হবে না। ইনইকুয়ালিটির জায়গা কোথায় আছে? ইনইকুয়ালিটির জায়গা আছে অন্য জায়গায়। এখন আমরা একদম ইকুয়াল জায়গাতে আছি, অনেকটা ইকুয়াল জায়গায় আছি। এখন আমার বাড়িতে যে কাজের মেয়ে, যে কাজের পরিচারিকা কাজ করেন, তিনি স্বাস্থ্যসাথীর মাধ্যমে তিনি অর্থোপেডিক ট্রান্সপ্লান্ট করাতে পারবেন। কদিন আগে আমার সঙ্গে উড়িষ্যার একজন ভদ্রমহিলার কথা হচ্ছিল, তিনি বিজু পট্টনায়ক স্কিমের মাধ্যমে স্টেম সেল ট্রান্সপ্লান্ট করালেন নিউ টাউনের একটা নামকরা হাসপাতালে। 16 লাখ টাকা খরচা পড়লো, 9 লাখ টাকা দিয়ে দেওয়া হলো, 3 লাখ টাকা ক্যাশে দিলেন, বাদ বাকি চেষ্টা করছেন এদিক ওদিক থেকে দিয়ে দেওয়ার। কিভাবে সম্ভব হলো? তিনি তো কোনোভাবেই 9 লাখ টাকা পকেট থেকে বার করতে পারতেন না। ভোট ব্যাংক কিংবা নানা রকম কারণের জন্য বিভিন্ন রাজ্য সরকার, কেন্দ্রীয় সরকার তারা চেষ্টা করছে, কিন্তু যে কারণেই করুক না কেন এগিয়ে তো যাচ্ছে। ইনইকুয়ালিটির জায়গা থেকে ইকুয়ালিটির জায়গায় পৌঁছাতে পারি আমরা, আমাদের হচ্ছে সমস্যা। আমাদের বুক ফাটে, মুখ ফাটে না। আমরা যদি বিপদে পড়ি, মধ্যবিত্ত এবং উচ্চবিত্ত সম্প্রদায় কি হবে? এখন সব থেকে বেশি সুনিশ্চিত হচ্ছে যাদের নিয়ে আমরা 10 বছর আগে দুঃখ করতাম, কষ্ট করতাম। যদি আমার বক্তব্য হচ্ছে, যদি সরকারি স্বাস্থ্য বীমা যোজনাগুলি বিভিন্ন রাজ্যে যা যা আছে একটু ফ্লেক্সিবিলিটি দেয়, যে তুমি ভাই তোমার যা ক্যাপিং রয়েছে, আমার যে 5 লাখ বা 10 লাখ টাকা যে সাম অ্যাসিওর্ড আছে, আমি যদি পেমেন্ট করি সামান্য কিছু, তাতে যেন আমাকে সাম অ্যাসিওর্ডটা বাড়ানোর সুযোগ দেয়। যে 5 লাখ টাকাটা আছে সেটা 7 লাখ, বেশি সাম্যতা থাকবে। এখন সাম্যতার জায়গায় আমরা অসাম্যের জায়গায় আছি। যাদের নিয়ে আমরা দুঃখ করতাম না, তারা সাম্যের জায়গায় আছে। ধন্যবাদ।
Thank you. To sum up what Bishwajit said, his point is that between the coverage of various state government health schemes and the central government health schemes, and the health schemes that cover employees of institutions such as yours, the railways, and private medical insurance companies, equitable healthcare is now no longer a mirage, because it's very clear that even a resident of an underprivileged urban area or a rural citizen can have access to healthcare that is comparable to the best or the more affluent segments of society. Very firmly tongue-in-cheek, he said that maybe the very affluent individual will be slightly uncomfortable because in the bed next to the next patient is somebody who comes from a totally different social spectrum. But this mental discomfort apart, healthcare now covers a lot more Indians than we could have imagined 10 years ago. He mentioned Dr. Devi Shetty's scheme, which was launched 10 years ago. Yes, about 20 years ago. But he says that the coverage is such that there is scope for enormous hope. That with a little bit of flexibility and a little bit of tinkering, universal healthcare can indeed cover almost all Indians. So thank you, Bishwajit, for a very passionate. I must sit down with you to listen to all your stories about your other street corner addas, which are a fascinating experience. He mentioned a small village in Bankura. So now, while he was speaking, my good friend, Chartered Accountant Anirban, was getting most restless because I'm sure he has lots to say. So over to you, Anirban.
After Brian Lara and Virat Kohli and perhaps Mr. Gundappa Biswanath, I can become only a Rinku Singh to have some quick runs. Moderator sir, we can't avoid politics. Bishwidha has started that a bit. And we can't have a debate on this topic. Bishwidha was saying that if we would have discussed this thing 10 years back, I don't know whether some of you would have organized a debate on this topic, say 40 years back, 50 years back, and still you have a debate on this. And again, after 50 years also, you can have the young generation, those who are sitting out here, they can still organize a debate on the same topic. We can't have a debate on this topic, sir. And those who are sitting against the motion and those who are sitting for the motion, they will all have to, come to a consensus after the debate that yes, it's a mirage. Let us, forget about, our physical presence out here. Whether you are doctors, you are a chartered accountant, there are a couple of administrators present out here. Just go back to our today's stories in the newspaper. Three, main stories that I was just reading out here while coming to this auditorium. One aged gentleman died yesterday in Bombay airport. He traveled from some parts of our country, got down in Bombay airport. Flight got delayed by almost 3 hours. He was accompanied by his wife. They were requiring 2 wheelchairs. We'll talk about infrastructure, big infrastructural, developments coming to here and there, especially in Bombay airport, made by Mr. A. I would not take the full name. 2 wheelchairs were required for the couple, aged couple. They could bring down only 1 wheelchair. The gentleman who was, who was waiting for the second wheelchair, it did not come and he could not wait and he had to accompany his wife. And finally, after working for half an hour, he died at the airport. We talk about infrastructure, we talk about foreign investments. It is all about accessing the system. We are all talking about healthcare. We are all talking about investments in healthcare. Bishwidha was saying that he has visited Khatra or some parts of the rural areas. Even if you give him a Sastro Sati card, it is important whether he can avail that medical system there. We should have all those hospitals present out there. He was saying that anybody can come with the health card and he can have that admission done in corporate hospital. Is it so simple, sir? Not at all. You have to think about the reality. Second story. Supreme Court, Honorable Supreme Court had given a verdict day before yesterday. Electoral bond, which was considered to be a reform in our country, it cannot be done, right? One political party has got 5,000 crores. The second one got only 1,000 crores. Inequality lies there. All gentlemen, ladies and gentlemen present out here, I know a couple of them, those who are struggling a lot if they get love letters from income tax department. If you have, say, some amount of credit in your bank account, you would be getting love letters from income tax department. And now the love is on the air that you would be getting the love letter, but you would not be knowing who is the person who has sent you the love letter, because it is now a faceless suspect. You must be knowing. We, general public, we are just like a मंदिर का घंटा, कोई भी आता है बजा के चला जाता है. I am not good at Hindi, भाषा को मत समझिए, भावनाओं को समझिए. But for the political parties, anybody can give any amount. There would not be any question being asked by anybody. There lies inequality. We talk about, he was talking about medical insurance. Sir, would you know that only 14-15% of the Indian population, they are covered by this medical insurance? And that too, if you go back to those earlier income tax amendments led by Mrs. Sitaramanji, you can't have now 80C, the new income tax structure. Earlier, it was, proposed that, if you can pay medical insurance under Section 80D for yourself or for your family, you would have taken deductions, rebate. Now it is gone. Now government does not want you to, expend into medical expenditure, medical insurance. It is not a compulsion now. It was earlier a compulsion. Forcefully, people used to do it to get, income tax rebate. Now it is no more. And the GST being paid by a general public on medical insurance, 18%. Government wanted to, those Niti Aayog members, policy makers, they decided, whether it could have come down to 12% or 8%. Finally, it has not been done. So 18% GST. As I do not know the age of Biswit. I am the youngest one amongst the lot. But if he can go, to any medical insurance companies and tries to get, medically, the insurance done, first of all, you would not be qualified for some medical, tests being negative for him, I'm sure. Number two, the coverage vis-a-vis the premium is so high that, normal people cannot avail those, medical systems. Now, coming back to this topic again, once again, we talk about infrastructure, that, budgeted allocation on healthcare. We talk about 3 trillion, 4 trillion, 5 trillion economy, and only 90,000 crore has been, allocated for medical infrastructure. Not even the infrastructure. The medical allocation was only 90,000 crore, of which they are talking about coverage of ASHA, ICDS Karmi, the employees under Ayushman Bharat. This is India. And if you talk about the difference between urban and the rural areas, I'm sure if you would have thought of organizing this debate, not in Kolkata, but in Kagdip, not in Sandeshkali, I'm sure nowadays. But if it would have been done in Kagdip or Namkhana, you could see the difference. Even if we have Sati, even if we talk about Ayushman Bharat, but accessibility to the system is important. And we have too many, even, if we talk about healthcare, we have hospitals under healthcare, we have diagnostic centers under healthcare, we have medical shops under healthcare. We may have medical shops, we may have multiple diagnostic centers within 1 kilometer of radius, but you can't afford to have that hospitals which is required. And I'm sure that those who are, present out here, they would, as Dr. Mukherjee has rightly said, there is scope, and we would all can think of doing something great in a different style so that we can bridge the gap. Thank you very much.
Thank you. Now for the last speaker, who has been making copious notes, and I'm sure she will give us a very spirited articulation of why she thinks that equitable healthcare is not a mirage, it's a reality. So let's see what Swati Gautam has in store for us.
Mr. Moderator, let my time start now. Good morning, ladies and gentlemen. My worthy proposition has beautifully practiced the art of, if you can't convince them, confuse them. I say this for 3 reasons. But before I say that, let me quickly recap what we in the opposition have been sitting and doing. Dr. Krishnendu Mukherjee, being a doctor, gave you very, very clear examples, illustrations, and solutions about how we are already in a very equitable state of healthcare in India through the medical fraternity's eyes. Bishwajit Babu came up with his vast on-ground experience as a journalist covering healthcare and showed you what the reality is today. That the Mem Sahib or the Didi or the Bodhi of a household may be admitted on a bed next to the house help, the maid servant of the household. I am here to take our example, our case further. Bishwajit Babu also spoke very, very extensively about how insurance and health schemes have made it possible. I am here to talk about the larger impact, the larger social angle of this motion, that equitable healthcare in India is a mirage. Never mind what the last speaker consistently kept hammering on. It's but obvious for chartered accountants whose clients must be having love affairs with the income tax department, you will be getting love letters. Here is an entrepreneur of 35 years, and as God is my witness, by God's grace, great amount of money from 3 retail stores, by God's grace, please all of you cross your fingers for me. Not a single love letter from anyone. Anyone. And Valentine's Day has just gone past. Let me quickly refresh the topic for us. Equitable. The Oxford Dictionary says, equitable is fair and reasonable treatment of everybody. Presuming there are a large number of doctors here in this auditorium, is there a single doctor who can tell me that they have not treated their patient fairly and equitably in life? Do you as doctors treat your patients depending on what the size of their wallets is, what their background is? What are we talking about? My worthy proposition has completely confused equitable with equality. And there I say this, just because men are born unequal does not mean there's no right to equality, does not mean equality does not exist. Similarly, just because we have not reached the desired stage, the desired level of equitable healthcare in India does not mean that A, it does not exist, and secondly, that it is a mirage. Rupkatha, my most worthy opponent, says in 2 back-to-back sentences, it's time to provide equitable healthcare. That means she, the individual that she is a very hopeful, very strong, a teacher who treats every student equitably. Unfortunately, she's been put by Dr. Home on this side of the motion, and she has to defend it. Else she would have surely agreed that being equitable is part of the game. We are already there. She says it's time to provide equitable healthcare, and in the very next sentence she says, "Ota kintu mirage, morichika." Mirage to konodin sharthok hoy na. It is dreams that can be fructified, ladies and gentlemen, not a mirage. A mirage remains a mirage forever. To bolster my point about being equitable, I would like to say something very simple to team proposition. My belief, our belief as team opposition is far, far, far greater than your doubts. We are here to tell you that we, not just as a progressive nation, as a progressive class of humans, as progressive humans on earth, are here to ensure that we reach out continuously and consistently to more and more people. Very clearly, to correct there are lies and damn lies, and statistics is one of them. And the chartered accountant who deals with numbers is perfect at doing it. He says 14-15% of the population has been covered by insurance. I dare you, sir. I wager my entire estate on this. Prove yourself right. 2023. My source is the Forbes magazine, no less, who's held to high journalistic standards. 2023, the Forbes magazine rightly says 70% of Indian population is already under healthcare, health schemes, which we call insurance. Only about 30% under private insurance, yes. But the other 40% is covered, which is what Bishwajit Babu spoke about. I will now quickly tell you 3 stories. One, a green story, one a white story, one a blue story. All these 3 stories are of hope. Very quickly, I'll run through them. And I'll tell you, and I'll tell the proposition that do not limit your challenges. Challenge your limits. The blue story about the Champaran Revolution, the Indigo Revolution. A man not many are familiar. And I tell you, go back to the history books and check his name. Rajkumar Sukul, of a very landed family, high caste, Brahmin, zamindar of the Champaran region. For 200 years, he sees how the British have dramatically exploited the people of that region, reduced them to indentured labor, reduced them to penury, finished homes, generations, villages. What does that man do? He recognizes this Gandhi who's just come back to India from South Africa. Rajkumar Sukul does not know how to speak Hindi or English. He can only speak his native vernacular. He doesn't give up hope. He goes to the Lucknow session, the Lucknow Adhiveshan of the Indian National Congress, and ensures that he stays in a tent next to where Gandhi is staying. He ensures he gets a translator and goes to Gandhi and tells him this is what's been happening for 200 years. Gandhi, being who he is, says, I will go and see for myself to believe that this is true. And Rajkumar Sukul takes Gandhi through muddy villages, through no roads, and shows him the truth. The Champaran movement starts, and it changes the face of India. That is what one man's hope can do. This is for the proposition. This is for all of you. Never lose hope. The Green Revolution, and M.S. Swaminathan, whose family insisted that he clear the IPS, he did, but he went on to become a zoologist, who then specialized in plant breeding. He ensured that one man, through his efforts, that there was a green revolution. A white revolution, Verghese Kurian. What did he do at a point of time when the larger amount of milk in India was being wasted, not consumed? He came together and did this. It's not the time to give up hope. Equitability exists. It is not a mirage. Equitability is a dream that can be bettered and bettered with time. Ladies and gentlemen, before I go, it's quick. I must refute Rupak also. He said, whether it is a reality or a dream of equitable mortgage. Sir, in a debate, you need to make your mind up and mark your words. Thank you.
Thank you. Swati is more often than not unstoppable. You saw all my bells. Not any attention did she pay to it at all. But nonetheless, Swati, thank you. You only exceeded your time by 32 seconds, which is beautiful. So there's a very handsome offer from both the teams that they want to do a bit of summing up, which will add to the entertainment. So for the organizers, do we have a few minutes for that? So the leader of the opposition should go first, Dr. Krishnendu Mukherjee, to sum up his viewpoint and to take the final pot shots at the proposition.
Thank you very much, the organizers and Mr. Chairperson, for another unexpected opportunity for summing up. Till the chartered accountant, Mr. Anirban Dotto, came up, I was under the impression that we were debating on equitable healthcare. And then I realized, no, it might be that we were debating on equitable wheelchairs. And, he talked about 1 and 2 and 2 and 1, 1 and 2, not healthcare, wheelchairs. And he's a chartered accountant. It just reminds me of a story that if you ask somebody what is 2 plus 2, everyone would say 4. If you ask a statistician, he would say any variable between 3.9 and 4.1. And if you ask a chartered accountant what is 2 plus 2, he'll say, apni koto chan. Okay. Summing up, I can't take a lot of time. I can only reiterate that equitable healthcare means being honest and fair and say beforehand what we can offer. We cannot offer, the government or the government insurance schemes cannot offer ECMO, but we can offer at least a BiPAP. So that is reasonable healthcare as per circumstances. We have to move forward. Mr. Chairperson, Madam Rupkota Sarkar said that we are talking about now. No, we are not talking about now. A mirage, a Morishika is something you see in the distance. You keep walking and then you realize, it wasn't Oasis. It existed somewhere else. But because of the reflection of the light and, I forget the physics, you're seeing it there. We are trying to say we have made some strides. There are many problems yet to solve. Of course, we need more money. But what we are seeing there in the distance, maybe another 10 years, maybe another 15 years, if we become from an emerging market, if we become a middle income country, and by the time, if we can improve our insurance coverages and infrastructure, certainly we will be able to reach a situation where we have equitable healthcare. Thank you.
Thank you, Dr. Mukherjee, for maintaining time, and over to you. Rupak Borua, the final speaker this afternoon, defending the motion.
Thank you. First of all, I would like to point out to Swati Madam, that's a reality or the dream that I have not decided. I am not supposed to decide. I had given it to the audience actually to decide after the discussion whether it is a reality or the dream. Dr. Krishnendu, as you have mentioned about we are dropping this year population, but if you see this year April 2023 statistics, our population has increased 1.42.85 is your crores of population, which has surpassed China. So these are the reality. And Vishwajit was talking about Swasthya Sathi and all the insurance scheme. You need to understand, yes, first of all, if you could track my discussion, I've never said it's a absolutely not possible, but it's a reality that we wanted to point it out. Because until and unless we understand the reality, we'll never will be able to reach out to the goal. Swati ma'am's talk is, of course, Swati and particularly Vishwajit is a very political discussion nicely. I mean, in the election rally, if you talk about, people will absolutely clap. Yes, that is the vision. But we need to understand the reality. You are talking about the healthcare expenditure and all. You are talking about the healthcare access. You know that in the rural areas, for a dialysis, the patient will have to travel 40 to 50 kilometers in some of the districts, some of the interior. There is no facility available. You are talking about insurance. That is yes, it's growing. Insurance, it's not today. Insurance is there, Mediclaim, the subject, you all know. It's there for 30 years, 40 years. In this 1999, Indian Regulatory Development, Insurance Regulatory Development Authority, IRDA, they had a foreign investment, they have diluted, and they have agreed, they have given permission for foreign investment in terms of your healthcare insurance. And you could see 2000 onwards, that is, there is a lot of private insurance, Bupa, your ICICI Lombard, there are multiple number of insurance. Still, the access percentage it was before COVID, it was 12%, and post-COVID, it has reached to 15%. 220 million of population actually is being covered by insurance. I'm talking about private or public, that both combining GIPSA and the private insurance corporations. If you talk about the other segment, yes, Yashashri Yojana, CGHS, WBHS, Swasthya Sathi, what is the percentage? And of late, what you could see, the government is not in a position to continue with this scheme because the way this scheme is growing, that is, they are beyond their budget. So it is not possible. universal health scheme, if you are talking about universal healthcare facilities, if you are talking about, it is really in terms of the population, not criticizing, but the challenges we are trying to discuss. There is a population is increasing, there is a diverse population, there is a lot of challenges in terms of your human resources. Yes, human resources, that the percentage that we talked about, the doctor shortage, nursing shortage, all you are facing. But yes, it is going to address, but it will take time, 20 years, 30 years, we know. 2047 insurance companies, they are mentioning, IRDA mentioning that they will be able to cover more than 50% of the population. That is the 2047. We need to wait for another 20, 30 years to really make this your healthcare as an universal. But still, by that time, the population will grow. By that time, more of the challenges will come up into the project. So it's, as of today, I leave it to the audience, this healthcare, your universal equity healthcare is a mirage. Thank you.
Thank you, Rupagda. A very spirited presentation in response to equally spirited attack by Dr. Krishnendu Mukherjee. The motion, of course, will be put to a show of hands, but I'm reminded of certain points that I think we must highlight. We have on one side the proposition telling you that the unfairness in access and affordability and the overall law and regulatory system and the financial reality of a third world nation prevents you from even hoping that you will have equitable healthcare in this country. Am I right? It is their viewpoint that the unfortunate scenario that we see around us, pandemic or no pandemic, is likely to continue for quite some time, and what we think of as equitable healthcare is a mirage. On the other side, the opposition has told you that given the current level of evolution of our society and of our nation after independence, given the fact that our country has so many schemes, government, non-government, private, non-private, and supported institutional schemes, access and affordability are not the primary issues in healthcare today. There may be some issues of convenience, but most of the population is now covered under some degree of healthcare. But most importantly, the opposition also highlighted the fact that equality and equitable access to healthcare, equitable healthcare, are two different things. And I was reminded again and again by speakers on both sides of a dialogue in the film Lincoln, which many of you have seen, where the legislators in the US Houses of Congress who are opposing the abolition of slavery are told again and again that this is not something to make people equal. This is something to make them equal before law. But here we are talking of equitable healthcare, which is not equal before law, but what is fair and just, which may be within the purview of the law, but more often than not extends well beyond the purview of what the law states. There is no law, as Dr. Krishnendu Mukherjee pointed out, there is no law that tells you that you will not provide treatment to an individual who unfortunately has reached certain landmarks or paradigms in longevity, number of years, and in the complication of the disease, that he will not get access to treatment. The point is, equitable is when a doctor takes this decision that it's better that you go back and enjoy the quality of life with your family and not try to reverse a situation that is irreversible. Very difficult and challenging ideas, no doubt, but it's something that we have to live with. The problem is that we are shaped by our cultural inputs. So you have Milton's Paradise Lost on one side, where Lucifer says, what if one war is lost? What if one battle is lost? The war is not lost. You should always have hope. So hope comes from Lucifer. On the other side, we have Tagore, to paraphrase him, who said, every time a child is born, it shows that the Almighty has not lost hope in mankind. So we have both Lucifer speaking through Milton and Tagore speaking for himself, who tells us that we should have hope. But does it apply to equitable healthcare? The proposition thinks not. And there are enough negatives. We live in a society that is imperfect, a global order that is imperfect. And however much we hope that we will all live in peace, every few months, some war breaks out somewhere in the world and it keeps on going. Whether it is Israel and Hamas, or whether it is Ukraine or Russia, whether it is the conflict in some part of Yemen, whether it is piracy on the Red Sea, our reality surpasses our imagination when it comes to evil and violence and all the negatives. So both sides have much to speak on them. But for my country, I'm very proud of my country. When we became independent, Krishnendu, correct me if I'm wrong, our average lifespan was in the 30s, 34 or 35. Today, the average lifespan of the Indian is in the 60s, 70s. We have a population that is both aging, yet that is overwhelmingly young. So be proud of India, because India is a very important part of the motion. We are not discussing unfairness and poverty and lack of access to healthcare in the USA, or in the UK, or France, or Germany, or even our neighbors, China and Pakistan. We're talking of India. So my point is, as an economic journalist, what we have achieved from 1947 to today, not taking sides, apologies to all three of you. But I am like more hopeful than non-hopeful. But let that not influence you. Can I have a show of hands? How many of you think equitable healthcare is not a mirage? It can happen to us. How many of you think? Right. We have about 34 hands up. And how many of you think that equitable healthcare will remain a mirage, with society and politics being what it is? Well, I'm sorry that the pessimists are losing the vote, which may add to the quantum of pessimism you carry without you. But we'd appeal you to join the overall feeling of optimism that this country gives us, and to think that one day we'll have a society where every patient will have not only access to healthcare, but also access to the best diagnostic tools, much better environment, lower level of pollutions, and general social happiness all around. Thank you so much for a wonderful debate. I've been standing between you and your lunch, which is always a precarious occupation.
Please.
So with these words,
I'd request all of you kindly to be seated for just a couple of minutes more. Well, that was something. Brilliant speeches by real icons. So may I now request our Principal Chief Medical Director, Dr. Mihir Kumar Chaudhary, kindly to come up onto the dais and hand over a small memento as a token of love and appreciation from us to each of the speakers. Oh, a group photo. Okay, fine. Please. Sir, you can join. Yes, Shubhankar. Can we have Dr. Shubharna Bose here on stage as well? So, first, a small memento to our moderator, Mr. Pradeep Guptu. Next, Mr. Vishwajit. Mr. Rupak Borua. Mr. Anirban Dotto. Mrs. Rupkota Sarkar. Ms. Swati Gautam. And finally, one Calcutta Medical College alumni to another, Dr. Mihir Chaudhary to Dr. Krishnendu Mukherjee. But we'd like to hand over a small memento also to the man because of whom we were served such wonderful culinary delights all through the day yesterday. With his wonderful brand of people serving all of us, his students, his managers, a person who is not just an entrepreneur, but a great visionary, and the man behind the International Institute of Hotel Management, Dr. Subarno Bose, please. So with enough food for thought, like you said, the Mirage is actually something to do with total internal reflection. You can all reflect internally once you go back and have your food now. Ladies and gentlemen, the lunch is served downstairs. I request you kindly to join us for lunch downstairs. Thank you so much.
We are about to start our fifth scientific session. The first topic is hemato-oncology. The speaker is Professor Tufan Kanti Dolai. And the chairpersons are Dr. M. Ravindran, is not here. And another chairperson is Dr. C.K. Venkatesaralu. Both of them, I think, they have gone for the inspection of the hospital. Can I get the auditorium person so that they can take care of the chairs? We don't require so many chairs on the desk, on the dais. We'll have only 2 chairs. I think the speakers have loaded their. Nilanjan, you have also loaded. Ajay Gautam. Ongira. Loading. No, you have loaded your thing. No? Dr. Krishna Das. Dr. Krishna Das, you have loaded your thing. Shall we start?
We can start with the second year. Shubro.
Is it possible to shift the endocrinology first and then we will go with the hematology, both the sessions together, one after another? Is that okay? With Dr. Professor Dolai, it's okay, na? We'll start with endocrinology, then you will have 2 sessions consecutively. The time remains the same. So now I will request Dr. Nilanjan Sengupta, the speaker of our endocrinology session, first peptide in a pill to treat type 2 diabetes mellitus, and the chairperson is Dr. Shormishta Mukherjee. Can you please change the CV of you project Professor Nilanjan Sengupta's CV?
Hello, hello.
Should I start? So good afternoon, everyone. Today we have come for discussion of a very interesting diabetes topic here. We all know that GLP-1 receptor analogs are one of the very important weapon in the armamentarium of this management of type 2 diabetes, and it has revolutionized the management of type 2 diabetes in recent years, particularly for those patients who are having established atherosclerotic cardiovascular disease and also high risk cardiovascular disease. But till a couple of years back, we had only injectable GLP-1 receptor agonist. But fortunately, we have now a, a pill that is an oral GLP-1 analog in our hand. And Dr. Nilanjan Sengupta will probably over, give a brief overview about that pill, which is very patient friendly and also effective in terms of management of type 2 diabetes. So the subject is fast peptide pill in management of type 2 diabetes mellitus, and the speaker is Professor Nilanjan Sengupta, who is a well-known personality, an eminent endocrinologist of national fame. He is the head of the Department of Endocrinology in NRS Medical College, a very good orator, and he is also very close to us because he has delivered so many lectures in past also in our annual conferences, and he has even taken classes in Biasing. And he will be the best person to handle this subject. So without wasting time, I would request Professor Nilanjan Sengupta to start his lecture.
Thank you, Shormishta, for the kind introduction. It is really like a homecoming, though I did never belong to the Indian Railways medical fraternity as such officially, but I have come here over and over again thanks to the requests of Shormishta Di, Bhaskar Da, Sharbanidhi, and so on and so forth. So it's always a pleasure to be back here, and I do appreciate that we are in a postprandial state, postprandial slumber. So I'll try to keep my talk as brief as possible. The topic has already been introduced by the chairperson. That is, we are now having an incretin analog in a pill form. It's an oral form. And this is my brief agenda. Now, whenever there has been any peptide molecule, including insulin, that has been developed, the attempt has been there to deliver it by the oral route, because that is the route which is preferred by the patient. If you are a patient, you would also always prefer an oral medication over an injectable one. But when it came to GLP-1 receptor agonists, that was, those molecules are big peptides, therefore cannot be absorbed from the lipophilic gastroduodenal mucosa. And second, they are degraded by local proteases. So Novo Nordisk scientists working on that, they had found out a novel strategy to modify the structure of the native GLP-1 molecule, at the same time combine it with an absorption enhancer in sodium N hydroxybenzoyl aminocaprylate, or SNAC in short. Now, so the quest for an oral GLP-1 analog, which was challenging because of poor bioavailability, rapid degradation after oral administration, and restricted permeability, was finally overcome by the Novo Nordisk scientists. As you see, you combine these two molecules, SNAC, which is an absorption enhancer, and this semaglutide. Now, what does this SNAC do? It actually changes or neutralizes the acidic pH of the gastric fluid in the immediate vicinity of the tablet, whereby pepsin is inactivated. Therefore, it in turn cannot inactivate the peptide semaglutide, which is now absorbed through the tight junctions. So that it is an animated slide showing whatever I have said. But next question would be, with so much of modification, so much of jugglery, is the bioavailability same? No, the bioavailability is not same. It is much less compared to oral semaglutide, but in appropriate dosage, the exposure response relationship is similar, which actually is what is clinically relevant. So when you give injectable semaglutide, which is yet to be available in India, the dose ranges from 0.5 to 1 milligram subcutaneously, but the same semaglutide, when you give by the oral route, the dose range is 3 to 14 milligram. So now, where you can use this oral semaglutide as an anti-diabetic agent, you can use this as a monotherapy or in combination with other oral anti-diabetic agents as also insulin. But commonly it is not used in monotherapy because still this tends to be a very costly molecule, rather costly molecule. So we shouldn't use it that randomly, but in deserving patients, it can be used in combination with other oral anti-diabetic agents as well as insulin. So there are various studies which have shown the efficacy and safety of oral semaglutide with other agents, and these studies have been named by the pioneer studies. For the paucity of time, I won't go into the details, but the mean or median glycated hemoglobin reduction is to the tune of 1.5% maximum. Now you compare this to another commonly used incretin-based therapy, that is the DPP-4 inhibitors, where the glycated hemoglobin reduction is to the tune of 0.8 percentage points. So GLP-1 receptor agonists as a class are more efficacious as compared to DPP-4 inhibitors when it comes to glycemic control. And that if you look at the other way, how many patients can achieve glycated hemoglobin target of less than 7 at the end of treatment? I mean, end of treatment means in a trial, that is a very impressive 70%. So that is quite good. And unlike the DPP-4 inhibitors, which are weight neutral, semaglutide, being an incretin analog, also causes weight loss in a substantial number of patients. The mean weight loss is around 3 to 4 kilos, maybe up to 5 kilos in studies, but in clinical practice, at times can be much more than that. So this is actually, again, where the usefulness of oral semaglutide along with other agents. But being an incretin analog, we have to keep in mind, at least on initiation, some patients may have certain gastrointestinal side effects in the form of nausea, early satiety, even vomiting. Some patients may even complain of diarrhea. But fortunately so, compared to exenatide, at least in my clinical practice, the chances or the prevalence of gastrointestinal disturbances with oral semaglutide is much less, so that the discontinuation rate also is lesser. And if you start with a small dose, that is the 3 milligram starting dose, and up titrate when necessary to 14 or 7 or 14 milligram within 1 to 2 months' time, then generally there should not be any problem. Yes, there are two important issues which are problematic with oral semaglutide in India. One is the cost, definitely, and second is the availability issue. There are availability issues in India, and the manufacturers themselves have off record admitted that throughout 2024, there would be some availability issues that we have to bear with. So how to manage those side effects? You talk about the side effects with the patients beforehand, ask them to restrict the size of the meal and gradually up titrate the dose. Like any other incretin analogs, semaglutide doesn't cause serious hypoglycemia on their own. There's no much risk of pancreatitis. Since it's an incretin, we are a little bit wary of pancreatitis, but any past history of pancreatitis and any current history of pancreatitis both will contraindicate use of any incretin-based therapy. No issues about diabetic retinopathy, and this pioneer program has actually attested to the efficacy and safety of these agents. Cardiovascular trials are also underway. The SOUL trial study, I think, will be read out soon. We are all eagerly waiting. So now we come to the summary. Now, how to take this is a very practical point. Now, how to take oral semaglutide? The recommendation is to take this oral semaglutide the first thing in the morning after an overnight fast with 60 to 120 milliliter of ordinary water, no sparkling water, no cold drink, no fizzy drink or nothing. And the patient should also not eat or drink anything within half an hour, because the bioavailability is very crucial. If you take with food or other agents, then the bioavailability may be a problem. There is a sort of drug interaction with, theoretical at least, with levothyroxine. If you have any concerns, you can shift the levothyroxine tonight, which I do, and there's no dose adjustment is recommended in presence of hepatic or renal impairment. Renal impairment, that's most important, not reasonably safe in elderly patients also. To summarize, therefore, over the past 10 years, incretin-based therapies, so long injectable, have found a place in the management of diabesity. That is not only the hyperglycemia of diabetes, but also obesity. And every patient wants an oral formulation. At least we have one in semaglutide, and I think the future of this class of molecules is really very bright. So with this I end, and if there are any questions, I would love to take them.
Thank you, Dr. Sengupta, for your lucid and very much informative presentation. You have actually covered all the aspects, starting from the mechanism of action to evidence-based medicine, practical points for its use, and also your practical experiences regarding this peptide pill semaglutide. So any question from the audience? Anyone wants to ask any question?
I'm asking, is it available to your patients?
Yeah, it's available.
That's
here.
Excellent.
We have made it available. Of course, in selected patients we are giving.
It has to be, but availability, at least you have the option to use it in deserving patients.
Yes, yes. One thing, has your practice changed after this semaglutide, the oral GLP-1 receptor analog has come to the market? Has your practice changed? Have you shifted from liraglutide or dulaglutide to semaglutide in your practice?
Actually, I haven't shifted that much. Those patients who were happy with dulaglutide or even liraglutide and did not complain, I didn't even break up the issue with them. They are taking it. But when it came to new initiation,
yes.
if I give the option to the patients, I can remember one, but all patients said, okay, I would settle for an oral version. The cost is not much of an issue. Only one patient who was also on glargine, so that patient knew about injections. He said, I don't mind. I would take dulaglutide if that calls for a single weekly injection. But otherwise, when I give the option, the vis-a-vis daily injections, they prefer an oral medication, even if that is a shade costly. But what I said, over the last 6 months or so, the main issue has been the issue of availability in the Indian market.
Okay, thank you very much.
Thank you.
I mean, do you have any off-label use of this in obesity in non-diabetic patients?
I have
do you use personally?
I had used liraglutide, but not semaglutide as yet, because I'm made to believe that Wegovy or injectable semaglutide would be coming, so I'm waiting for the injectable itself to be used in obesity.
That will be more rational and scientific then.
Right.
Okay. Thank you very much.
Thank you.
Thanks again, Dr. Nilanjan Sengupta, for your beautiful presentation, and thanks to the audience for patient hearing.
I will now request our chairperson, Dr. Shormishta Mukhopadhyay, to hand over a token of appreciation to Professor Nilanjan Sengupta. Our next session will be hemato-oncology, 2 sessions, one after another. Thank you, Dr. Nilanjan. And the hemato-oncology sessions, the speaker is Professor Tushan Kanti Dolai. And the chairpersons will be Dr. Indira Jha and Dr. Reena Mukherjee. I'll ask them to come to the stage and take their seats.
Okay. Very good afternoon to all of you who are present here. The topic will be taken up by Professor Tufan Dului. He is a consultant hematologist in B.R. Singh Hospital for quite some time, and we have known each other for a very long time. So he will be talking today on diffuse large B-cell lymphoma, which is a type of non-Hodgkin's lymphoma. So he'll be talking on polatuzumab vedotin. He's very well known in the city as a hematologist. He works at NRS Medical College, which is just beside PR Singh Hospital. Okay, Dr. Tului, you can start your deliberation.
Thank you, ma'am, for your kind introduction, and the ladies and gentlemen. And first, thanks for the organizer giving me the opportunity to speak on this audience. So, in a brief discussion of the 8 minutes, I will be focusing on this the polatuzumab, these drugs that is called the polatuzumab. You know, the hematology and the hematology is filled up with the different maps. And this map have been changes the scenario of the treatment of the different hematological patient, and particularly the hemato-oncology patient. You know, the hemato-oncology patient, these are the group of the patient we can cure with this targeted therapy of the different monoclonal antibody. And after the discovery of the rituximab, the subsequently the lot of the monoclonal antibody have been coming on the market, and these are the another drugs that is called the polatuzumab. Because you know, in the time of this, the slide is not moving. Slide is not moving from here. Yes, thank you. So this is my disclaimer. So you know the non-Hodgkin's lymphoma is the common variety of the malignancy we encounter in day-to-day clinical practice, particularly after the Hodgkin's and the non-Hodgkin's. These two variety of the lymphoma, the non-Hodgkin's is more common. In terms of the non-Hodgkin's lymphoma, the diffuse large B-cell lymphoma is the very common, and around the 25,000 of the cases every year we came across in non-Hodgkin's lymphoma in terms of the India. In terms of the survival rate of the non-Hodgkin's lymphoma by giving the chemotherapeutic agent, you know, in the previously we are supposed to use the CHOP chemotherapy. Then subsequently we use the rituximab based chemotherapy to call the R-CHOP chemotherapeutic regimen. In that chemotherapeutic regimen, the progression-free survival is 70% and overall survival is around 80%. So around the 70% of the people we are able to cure by this the availability of the drugs. So there is a 30% of the patients we are not unable to cure this patient by this the front line of these chemotherapeutic drugs, or some group of the patient they can progress, and in that group of the patient there is a challenges is there. So around the 30-40% of the people there are our challenges for the treatment of this the currently available therapy of the R-CHOP. So the CHOP is from the 1976, then subsequently the rituximab in 97, then subsequently in the era of this the R-CHOP chemotherapy from 2002 we are using regularly. But yes, 30-40% of the patient we are unable to cure it, because some group of the patient this R-CHOP chemotherapy is not going to do anything, particularly in case of the high IPI, age is more than 60, and also the non-GCB variety, and also some the dual expression or double hit lymphoma group of the patient, this R-CHOP is not going to help in this group of the patient. That's why the people have been tried the several chemotherapeutic agent to improve the survival of this the 30% of the people of the patient by giving the lot of the combination of the chemotherapeutic agent in the backbone of the R-CHOP or the CHOP chemotherapeutic agent, but neither has been able to improve the survival of the people with the diffuse large B-cell lymphoma. So in 2022, this the Pola R-CHIP is been coming into the market by the previously untreated diffuse large B-cell lymphoma. So to introduce the drug, it is become basically the polatuzumab vedotin is the antibody drug conjugate against the CD79B, because the CD79B is the signaling component of the B-cell receptor. That's why this drug is very acting, and the tumor cells become killing by the process of the apoptosis. By this, the trial of this, the polatuzumab have been published into the NEJM, that is the global randomized double-blinded placebo-controlled trial that have been changes the scenario of our treatment of the diffuse large B-cell lymphoma. In terms of this, the rituximab is there. Only the vincristine have been replaced by the polatuzumab. So from the R-CHOP, it will become the Pola R-CHIP. So only the one drug we have been replacing here from the vincristine, we are switched to the Pola R-CHIP regimen. And this drugs is basically the randomized, the 1:1 randomization, the polatuzumab vis-a-vis the R-CHOP in this group of the patient, and the primary endpoint is the progression-free survival and also the overall survival. In terms of this efficacy, primarily the refractory group of the patients, that the some group of the patients who are not responding to these drugs, that the Pola R-CHOP has been superior comparing to your CHOP. So the advantage of giving the polatuzumab is becomes more than 20-30% of the people that have been given the drug of the polatuzumab. And in terms of the efficacy of the drugs, this is the very important, we call the event-free survival, that the 24-month event-free survival, if we compare that in terms of this R-CHOP and vis-a-vis the Pola R-CHOP, that there is a superior in terms of the overall the event-free survival of this patient. And in terms of the overall survival of this patient, if we consider the overall survival, that is the very important, because you have to treat the patient very effective chemotherapy from the front line. So cancer drugs has to be so effectively that has to be attacking in the first time rather than by giving the relapse and the refractory patients. This is the beauty that this Pola-CHOP drugs is become taking care of this the rest 30% of the cases. So around the 80-90% of the people, they are becomes effective by giving the Pola R-CHIP regimen. And that's why in terms of the overall survival, if you compare that, this event-free survival and the progression-free survival is better with the Pola R-CHIP, but as it is the malignancy, sometimes the overall survival may be matched together. Though it is statistically not a significant, but yes, this is the polar arch of improving the event-free survival of the patients with this group of the drugs. And the more important terms that by giving these drugs in upfront, then subsequent chemotherapy utilization becomes less. When the patient become relapse, we are using the different high-dose chemotherapy regimen. We are using the stem cell transplant. We are using nowadays the CAR T cell therapy, because this CAR T cell have been totally changed, will be changes the scenario of the treatment of the different malignancy. So if you treat early, if you hit early by giving these most effective drugs, then subsequent usage of your the second line of the drugs, the radiotherapy, even into the stem cell transplant requirement will become very, very less by giving this the polar arch of chemotherapeutic regimen. In terms of the adverse event of this group of the drug of this the polar arch, there is a peripheral neuropathy, the nausea, neutropenia, diarrhea, anemia there. So this is basically the comparable in both the group of the cases. So the adverse event is not superior, means adverse event is comparable in both the group of the cases. That's why into the NCCN, this is the recommendation I've been given the NCCN for the treatment of the diffuse large B-cell lymphoma, that in terms of this the stage 2 and stage 3 and the stage 4 group of the patients, this the polar arch has to be used as the upfront chemotherapeutic agents. So the ladies and the gentlemen, for the treatment of the diffuse large B-cell lymphoma, particularly in case of this advanced stage of the disease, this the polar archive regimen have been increased the overall survival and event-free survival of the people of this diffuse large B-cell lymphoma. So we are not using now the R-CHOP, we will be using the polar archive in the patients with this diffuse large B-cell lymphoma. With this, thank you very much for the patient hearing.
Thank you, Professor Dului, for that enlightening talk on the newer recent advances in treatment of DLBCL. That reminds me, this morning our PGT presented DLBCL in the breast, our pathology resident. So this session is now open to question and answers. If anybody from the audience has any questions. If there are no more questions, we can close the session, conclude the session, and move on to the next topic. So, Professor Dului, next session will be on role of innovative drugs in hemato-oncology and what is new in Hodgkin's lymphoma. You can start your talk.
Thank you very much, ma'am. So I have been finishing the diffuse large B-cell lymphoma by giving this the polatuzumab. So this is the another area that we need to improvement of our hemato-oncology, that is the Hodgkin's lymphoma. You know, the Hodgkin's lymphoma is one of the malignancy that is the success story of the oncology treatment. Because in the lymphoma, we broadly divided the Hodgkin's and the non-Hodgkin's lymphoma. In terms of the Hodgkin's lymphoma, that in general, we are able to cure around 80% of the people. And if you again dissect it further in terms of the limited group, in terms of the advanced, this is slight difference. In terms of the limited stage of the disease, your survival is more than 90%. So this Hodgkin's lymphoma, by giving the chemotherapy agent, particularly you know the ABBD chemotherapeutic regimen we are using for last 30 years, that have been able to improve the limited stage of the patient around the more than 90%. In terms of the advanced stage of the disease, this advanced group of the patients, there is a little bit hiccup with this ABBD chemotherapeutic regimen, and their survival is somewhere between 80 to 85% of the cases. In this area, these drugs will be using or will be focusing subsequently. But before that, you know this the Hodgkin's lymphoma that mainly involving the lymphatic systems. And broadly, we will be divided in the Hodgkin's lymphoma in the two categories. We call the classical Hodgkin's lymphoma and also the lymphocytic predominant Hodgkin's lymphoma. Out of all the cancers, this Hodgkin's lymphoma, the chemosensitivity is very high, and we are able to achieve the cure in majority of the patients of the Hodgkin's lymphoma. But in terms of availability of the ABBD chemotherapy for the years, these are the algorithm we are using for the couple of years, that in terms of the favorable group of the patients, we are using the ABBD chemotherapy regimen by giving the 3 to 4 cycle of the chemotherapy. Subsequently, by the era of the PET CT scan, we are applying there for the upstaging and the downstaging for giving the chemotherapeutic regimens. Because the ABBD chemotherapy, they have a lot of side effects there. And in terms of the advanced stage of the disease, along with the ABBD, if it is not responding, then we are using the Biakov chemotherapeutic regimen. But unfortunately, around 30% of the people in the advanced stage of the disease, they might relapse. So in that group of the patients, we are using the lot of the combination of the chemotherapeutic agent, that starting from your DAP chemotherapeutic, the GDP chemotherapeutic, and subsequently we are doing the autologous stem cell transplant. And in selected cases, we are using the allogenic stem cell transplant also. So the lot of the drugs have been using in the relapse and the refractory cases in terms of the treatment. So in terms of the treatment by giving the existing therapy, that is the ABVD, that around 10% of the limited state of the disease, they are become refractory and the relapse by giving the ABVD chemotherapeutic regimen. In terms of the advanced stage of the disease, I already mentioned you, around the 30% of the people, they are not responding our front line, the old disease, the ABBD chemotherapeutic regimens. And not only that, there is a lot of problem is there by giving the ABBD chemotherapeutic regimens. In terms of the side effect, they have a chance of pulmonary toxicity because we are using the bleomycin, and also there is a chance of secondary malignancy because we are curing the cancer, but in the down the line, patient may develop the secondary malignancy because we are using the alkylating agent. We are using the anthracycline, there is a chance of cardiotoxicity, and the more important in terms of the fertility issue by giving the existing ABBD therapy. And there is a quality of the life issue is also there in case of the ABBD. There is a problem of fatigue, there is a problem of depression, and lot of the unemployment. These are the important problem by giving the ABBD chemotherapeutic regimens, though we are using for the couple of years. And another two important problem of the ABBD chemotherapy regimen is the bleomycin induced the pulmonary toxicity. That's why you are worried that by giving the ABBD chemotherapeutic that containing the bleomycin, that has a problem with the pulmonary toxicity, that lead to irreversible fibrosis, and that lead to the COPD or the obstructive airway changes. Patient will be cured the cancer, but they will be landed up with the pulmonary toxicity, and that is becomes more common in terms of the elderly people. And in terms of this pulmonary toxicity, the probability of the survival is also the decreasing, the quality of the life, the morbidity is become increasing by this group of the ABBD chemotherapeutic drugs. That's why the scientists have thought that if we can able to omit the bleomycin from the ABBD chemotherapeutic regimen, we can improve the survival of the people with the Hodgkin's lymphoma. And at the same time, the CD30 that have been expressing our Sternberg cell, because for the histology, those who are from the pathology, this Sternberg cell is the sine qua non for the diagnosis of the Hodgkin's lymphoma, and they are usually expressing the CD30. So the people are targeting the CD30 by giving these drugs we call the brentuximab vedotins. The brentuximab is basically the humanized CD30 directed antibody, and these drugs also kills the tumor cell by giving these drugs by the different mechanism. In terms of the mechanism, that usually the CD30, they are into the cell surface and they becomes complex formation, lead to the internalization, and ultimately they become arresting the G2 and the M phase, and ultimately there is apoptosis of the tumor cell. So to translate the clinical, the trial, that is called the ECLON trial design for showing the improvement or the results of this brentuximab in the existing ABBD chemotherapeutic regimen. There is a 1:1 randomization is there in the trial. One arm there is the ABBD, that is the bleomycin is there. Another arm, the bleomycin has been replacing with your brentuximab vedotins. They have been giving the 6 cycle, and these are the doses, and primary endpoint is becomes the progression in survival and also the overall survival in this kind of the group. And the primary endpoint is the progression-free survival is there. In the statistical terminology, they are using here the modified the PFS, that the progression-free survival. In terms of the progression-free survival, if you consider here that the progression-free survival, that is the disease progression, by giving the brentuximab with the AVD, vis-a-vis the ABVD chemotherapeutic regimen, that the progression survival is 82 vis-a-vis the 77, and it is become statistically significant. So there is a 23% reduction of your modified progression-free survival by giving these drugs. So comparing to your the ABVD, that the brentuximab plus AVD, that becomes statistically significantly improving the progression-free survival of the people, and so there is a benefit of the progression-free survival in this the ABVD chemotherapeutic regimen covered to the brentuximab chemotherapy regimen. So the brentuximab is superior in terms of the disease progression and in terms of the death comparing to the ABVD, and they are in the subgroup analysis. They becomes effectively into the all group of the hospitals, starting from the less than 60, the more than 60. There is a IPS scoring system, any IPI, and also the external involvement side in the all group of the patients. This the brentuximab is becomes very effective. If we consider the overall survival, in terms of the overall survival also, that the curve is well separated, and in terms of the progression-free survival, here in the overall survival, that your the p-value is 0.009, means it is the significantly improving the overall survival, and there is a 41% reduction of the risk of death with this the ABVD chemotherapeutic regimen. If we go to the toxicity profile of this the brentuximab, there is the peripheral neuropathy and also the febrile neutropenia. These are the two concerns, but the other side effect is more or less the similar in both the group. You know the pulmonary toxicity is more common into the ABVD, as I already discussed you. So the pulmonary component is more in ABVD, and little bit of the peripheral neuropathy and the febrile neutropenia is more with this brentuximab because it is monoclonal antibody. The chance of the myelosuppression will becomes more. In terms of the peripheral neuropathy, this peripheral neuropathy is not permanent. It is become transient. After the stopping of the drugs, it will automatically reverse back. So this peripheral neuropathy, though it is the grade 2 and the grade 4 is more common, it is reversible. So there is no worry in terms of your the giving the peripheral neuropathy from this the brentuximab. And in terms of the myelosuppression, the febrile neutropenia, we are talking that we need to give the primary prophylaxis with the growth factors. If we give this the growth factor, so we can decrease the incidence of the febrile neutropenia with this the brentuximab containing regimen. And pulmonary toxicity is more common with the ABVD. Here there is a significant difference. Is the grade 3 it is the 7%, and here it is only the 2% has been developed the severe pulmonary toxicity by giving drugs. In terms of the secondary malignancy also, this the brentuximab, they have a less chance of the secondary malignancy comparing to your the ABVD. So the secondary malignancy, the pulmonary toxicity, it become less with the brentuximab maintaining chemotherapy comparing to your the ABVD. So these are the two major advantages. That's why the drug have been given approval for this FDA for the treatment of people with this Hodgkin's lymphoma, particularly in case of the upfront setting also. These are the conclusion that this ABVD chemotherapeutic regimen have been improving the progression-free survival. They are improving the overall survival with the less toxicity. There is a less pulmonary fibrosis. There is a less chance of your secondary malignancy. That's why they have been preferred that this brentuximab containing the regimen has become superior comparing to your the ABVD. And also the NCCN have been giving the clear-cut recommendation is that in the stage 3 and the stage 4 disease, the category 1 recommendation that this brentuximab has to be used along with the ABD. But if the patient has a severe elderly, patient has a peripheral neuropathy, so there is a caution with this the brentuximab containing of this chemotherapeutic regimen. So these are the upfront data. What about the relapse and the refractory setting? In terms of the relapse and the refractory setting, I already told you that by giving the ABVD chemotherapeutic regimen, around the 30% of the people, they are become relapsing. When they become relapse, we have been giving the high-dose chemotherapeutic regimen, particularly the GDP chemotherapeutic, DAP, ICE, MIND, lot of the high-dose chemotherapy regimen is there. Followed by you are doing the autologous stem cell transplantation, and also the selected cases we are doing the allogenic stem cell transplantations. But in this group of the patients, if we give the brentuximab vedotin, what might be the result? How we can improving the survival? Because by giving the high dose chemotherapeutic regimen before the transplant, there is a lot of the toxicity is there, and also the organ function improvement is there. That's why into the post transplant maintenance cases, this the brentuximab also have been used by this trial, and in that trial also, if we consider that the overall survival and also the complete response rate by giving these drugs, that even after doing the stem cell transplant, these drugs is quite affecting and improving the overall survival and also the CR rate in case of the relapse and refractory setting. And also in terms of the overall survival and also the progression with survival, if we consider the overall survival here, we are improving around the 40.5 months the overall survival, and your the progression free survival also the improving here. So even in case of this the consolidation phases in the relapse and refractory setting, that these drugs becomes improving the overall survival and also the progression free survival. If we consider the long term remission data, that is the more than 5 years data, if we consider that by giving this the brentuximab, this they are maintaining this complete response. So by giving these the drugs by the brentuximab containing regimen, the progression free survival and also the overall survival is become improving, and they are in complete remission. So there is a chance of relapse is very, very less in this group of the patient. What about the toxicity in the relapse and the refractory setting? It is the more or less the similar like the upfront setting. There is a slight increasing risk of your peripheral neuropathy, and there is a slight increasing risk of your the febrile neutropenia. That's why we are using the growth factor prophylaxis when you are planning for giving this the brentuximab containing regimens. Sometimes we are using this the stem cell transplant, but into the early consolidation we can give these drugs. Then we can improving the transplant outcome also. In this group of the patients also, this is a phase 3 trial of the Ethera trial, that the early consolidation after the autologous stem cell transplantation, the drugs has been giving the 1:1 randomization with the brentuximab vis-a-vis the placebo, and there the probability of the survival is becomes improving by the brentuximab. So even after the consolidation, after the autologous stem cell transplantation, we are improving the progression-free survival, and also in terms of the long-term benefit by giving the 5 years of the drug, this brentuximab vedotin becomes sustained improving of the progression-free survival around the 95% comparing to 40% in terms of the placebo. So even in case of the early post-transplant consolidation, these drugs becomes quietly effective, and that, as I already told you, that the peripheral neuropathy is little bit a concerns, and it is becomes reversible by giving these drugs, and also the neutropenia is becomes reversible. If we give the prophylaxis of the growth factor, this not might be the problem of the people with the brentuximab containing regimen. And in terms of the peripheral neuropathy, I already told you that if you discontinue it, there is a 90% discontinue lead to the improvement of your peripheral neuropathy, and there is a 73% of the cases there is a complete resolution of the peripheral neuropathy by giving this brentuximab vedotin. So in terms of your improvement by the peripheral neuropathy by giving these drugs, it becomes no worry. Majority of the people, they becomes improved by stoppage of the drugs or after the completion of this treatment. So in terms of the recommendation of this relapse and the refractory setting by the NCCN, the current recommendation is that depending upon your the grouping, that is the whether by giving the relapse and the refractory, means usually when we suspect the relapse, we do the PET-CT. In the PET-CT, we usually do the uptake, and this uptake has been translated our Duvalli scoring systems. In the Duvalli scoring systems means that if the patient has a Duvalli 5, we call the progression of the disease. And in terms of the 4, also the progression of the disease, and 1 to 2, we call there is a response is there. So depending upon your the Duvalli scoring systems, we usually identify whether the my patient is going to relapse or not. If your the Duvalli scoring is very high, then we do usually the lymph node biopsy to diagnose that the patient has a relapse or not. Sometimes in terms of the PET-CT directed biopsies become essential to proper diagnose the patient with the relapse and the refractory setting. So this PET directed is very, very important. And if the patient have been relapsed by the histology, then the important thing is that along with your the drugs of this high dose chemotherapy, along with the autologous stem cell transplantation, the post transplant setting, we have to use the brentuximab as a maintenance chemotherapeutic regimens. And this maintenance chemotherapy has to be used particularly in case of the high risk group of the patients, because in that group of the patients, we need to give them benefit by improving the progression-free survival and also the overall survival. So the brentuximab vedotin in the relapse and the refractory setting and also in the post-transplant consolidations is becomes very useful to improve and the relapse and refractory group of the patients. So not only into the first line of the drugs, like it will become replacing the ABVD to the brentuximab VD means the replacing the bleomycin to the brentuximab, 30% of the people we can able to improving the survival. We can improving the pulmonary toxicity. We can cut down the pulmonary toxicity and the secondary malignancy by giving these drugs. So, ladies and gentlemen, for the treatment of the Hodgkin's lymphoma, by giving this availability of the drugs of this brentuximab, the scenario have been totally changes, and it will change into the future, not only into the long-term toxicity, but also the survival and also the secondary malignancy, and this becomes improving in the early setting, means there is a primary setting, newly diagnosed setting, relapse and the refractory setting, and also in terms of the post-transplant setting. With this, thank you very much for the patient hearing.
Thank you, Dr. Dole. Both your lectures were very lucid, and we learned a lot. The whole lymphoma chapter was covered. Non-Hodgkin's lymphoma is the better one, a better outcome. No, it's more common.
Hodgkin's, it is more
And
common.
Hodgkin's is better one.
Better one.
And in both, we learned about the two new MABs. MABs are very expensive, but to save the life of these patients who are not responding to the normal therapies. So that was very good, both boltuzumab and brentuximab. Thank you very much for this. Now, if any in the audience, if anyone would like to ask a question, please come ahead. Okay, if we don't have any questions, we'd like to end this session. Thank you.
Thank you very much.
I'll request our chairpersons to give a memento to our speaker, Professor Dole. And I will also request Dr. D.R. Das to give tokens of appreciation to our two chairpersons. Dr. D.R. Das, please. So we move on to our next session. It's on respiratory medicine. Topic is severe asthma, a case-based approach. Speaker is Dr. Ongida Dasgupta, and the chairpersons are Dr. Devopriyo Sengupta and Dr. Somnath Saha. I'll request them to come to the stage and take their places.
We are here to hear one of the most academic member of B.R. Singh Hospital, Dr. Ongida Dasgupta. She has done MD in pulmonary medicine, DNB in pulmonary medicine, and MRCP from UK, and also a couple of fellowships from other countries. Now, she is very actively involved in pulmonary medicine. She has more interest in pulmonary medicine, although she is also an internist. So let us hear about a very common problem, which is asthma, from her. Thank you.
Thank you, Debopriyoda, and good afternoon, everybody. So the timer has started. I thought it wouldn't because initially it showed just 15 minutes on the first slide. What I'll do in the next 15 minutes or so is to talk about severe asthma and how we can approach it in a case-based approach. So the objectives of my talk today is why is severe asthma important? I'll take you through the journey of phenotyping to endotyping, try and discuss the different endotypes of airway inflammation, and I'd like to put everything in perspective of the clinical scenario by discussing a few cases. So why bother about severe asthma at all? It's because 5 to 10% of airway diseases remain symptomatic despite the best available and guideline-based therapies. And some of these patients can be on long-term oral corticosteroids with its side effects. So the management of severe asthma is usually in a stepwise fashion. We've all seen these pictorial depictions by treating patients of asthma in step 1, 2, 3, 4, and 5. And once you've reached step 5, where you've gone max to these long-term ICS and LABA therapy, this is the point where asthma becomes severe and there is a need to phenotype asthma. So this is the first case, and let's see if we can work out our way through the management protocol. Symptoms started at 45 years of age. He's a 60-year-old female, ex-smoker, atopic, on salmeterol plus fluticasone, which is the ICS-LABA combination, very high dose, tiotropium, very high dose. We did the post-bronchodilator spirometry, where it shows that the patient had an FEV1 of 50% and an FVC of 86%, which means it has a very severe disease. Radiology, normal, echo, mild pulmonary arterial hypertension, and the patient continues to remain symptomatic despite all these high-dose therapies. The compliance of the patient was good, ruling out lower doses of inhaled corticosteroids, no ongoing allergen exposure, and the comorbidities were well controlled. Now, when we say there are no ongoing allergen exposure, we need to keep in our minds whether the patient has a pet at home, birds at home, or some allergen that the patient can identify causes symptoms in him, in her. So this is how we look at the endotypes of asthma. There is the allergen, which is sitting right up. It goes into the epithelial cells, into the subcutaneous mucous membrane, the submucutaneous tissues, where the naive B cell is stimulated and it can form the naive T cells, which will differentiate into Th2 and Th1 types. The Th1 type is the neutrophilic one, where you get neutrophils in the direct submucosa, and the Th2 one is the eosinophilic phenotype. Whereas if the plasma cell is stimulated to form B cells, which are going to produce IgE, it becomes a high IgE asthma, which is an allergic type. So if we don't look at the cells high up, if we just look at the panel at the bottom, so the patient can have either a type 2 inflammation or a non-type 2 inflammation. In type 2, you have allergic plus eosinophilic, whereas in non-type 2, you could have neutrophilic and postgranulocytic inflammation. So I'll explain the terms a little bit slowly. So how are we going to understand what the phenotype of the patient is? Obviously, we need to measure something that's going to tell us that this patient belongs to the Th2 type, that's the eosinophilic type, Th1 type, neutrophilic type, or is the patient an atopic with a raised IgE level? Now, the best thing that can be done very simply is a blood cell count of eosinophils. Serum mediators, periostin, we do not have the facilities till now. But the most well understood thing that we could do in these patients is to do a sputum cells and the supernatant assay. So sputum cells are going to give us a quantitative measure of the total cell count and the differential cell count, much like we would get when we do a TCDC from the blood. So people have always preferred blood biomarkers because it's easy to do. And the count of blood eosinophil which can predict a response to steroids or monoclonals is a count of more than 300. Now, monoclonals are biologics that we give the patient in severe asthma if the phenotyping shows that the patient has a blood eosinophil. So what is the biologic that we are using here? Anti-IL-5, that targets the eosinophils. And so the monoclonals that we can use are mepolizumab, benralizumab, dupilumab. I don't expect people to remember these things or even to pronounce these things. So it's best it's on pen and paper. The raised serum IgE asthma, we would give an omalizumab, whereas in allergen-specific IgE, if we can measure that, predicts response to specific immunotherapy. We do not practice that in BRCing anymore. So if we look from a mechanistic point of view, whenever I get a patient of severe asthma, what I ask myself is to try and understand what the underlying mechanism is. So like I said, it could be either a Th2 or eosinophil-driven mechanism, Th1 neutrophil-driven mechanism, or a B cell. So 3 mechanistic types of asthma which we have to identify from the available tests and then treat the patient accordingly. So let us not forget our patient who was a 60-year-old female with severe asthma. Now, in order to identify the endotype, there are 3 things that we can do practically in clinical practice and not just in books. We could do a blood eosinophil count, which in this patient was 210 cells per cubic millimeter. Unfortunately, blood eosinophil count is very non-specific. There can be hundreds of reasons why the blood eosinophil count can go up. The total IgE is 220 international units per liter. Here also, it's rather non-specific, and there are lots of reasons where the serum IgE can be raised, including allergy, and most of the time, we cannot identify what the allergy is. We could also do a pheno, that's an exhaled nitric oxide test, which if more than 40 millimeters, 40 parts per million, could mean that the patient has an ongoing inflammation. But this is what we aim at, and this is what we should do in these patients where the identification of the endotype is not possible. So what do? We do a sputum biomarker assay. Now this gentleman, Freddie Hargreave, is the person who pioneered the entire process of doing a sputum quantitative assay. This is the process, which Joyita knows somewhat, and Reenati will knows at some point of time. So here, what do we get? We get a total cell count and a differential cell count after going through all those steps. So I'm not describing all that. And what you get is something like this, a slide, where you can identify eosinophils, macrophages, lymphocytes, neutrophils, and do the differential counts. So now if we see a eosinophil, it doesn't mean that the patient has an eosinophilic asthma. And why is that? Because sometimes the patient's eosinophil or inflammatory cells stay back in the airway lumen without doing anything. It's just sitting there inactive. So if we can demonstrate the presence of degranulating eosinophils, then it's not a problem. We know that eosinophil is active. These are the various types of airway inflammation: eosinophilic, neutrophilic, combined, and postgranulocytic means it has normal counts. So if you have an eosinophilic count of more than 3% with a normal total cell count, what do we do here? Yes? I can see some heads nodding, so Orko. What do we do when we have an eosinophil count of more than 3%? We give steroids, either oral or injectables. Neutrophilic, we give antibiotics, and we do not mess with the inhaled corticosteroids. We could have a combined one where we can treat the total cell count first and then go for a repeat assay where we will know the basic type of airway inflammation, that's the eosinophilic bronchitis. So this is the strategy. I have a better slide later on. So endotyping with the available tools these are some of the tools which are available, and I spoke about them a little bit earlier. We could do a serum IgE, which is indicates a B cell mechanism. We could do a blood eosinophil count, which indicates a high Th2 pheno, ongoing airway inflammation, and sputum quantitative assay, which shows either a low Th2 type or a high Th2 type. So this is another patient, 53-year-old female, exertional shortness of breath on activities of daily living. The patient has recurrent exacerbations for the past 1 year, where he needed around 4 admissions in the hospital. FEV1, 60% predicted, FVC 70%, not that bad, but still it's obstructive. Has been on very high dose of inhaled corticosteroids and OCS, non-antiallergics and bronchodilators. That's what we do all the time. So if the patient does not respond to some sort of a medication, we either add something else or we go up on that. Not realizing what we are doing is actually giving the patient a medication to which the patient is not responding. But what are we doing? We are adding more of that. So more not causing any symptom relief, add more of what you are doing. So that should not be the approach. We did a blood work in this patient where the total cell count was 5,600, absolute eosinophil count 120, not that significant, IgE 920. So from that, I think the take home from that case would be that it's in serum IgE that's raised, so the patient has allergen-induced atopic asthma. Treatment options, like I described, anti-IgE omalizumab, that's a biologic, and allergen-specific IgE, that's specific immunotherapy by trained and allergy expert. That's difficult. So another patient, a 50-year-old gentleman, never smoker, asthmatic since late 20s, recurrent exacerbations, allergic to dust, also has rhinosinusitis, nasal polyposis, family history of asthma, treatment again as per the step-up approach. We've reached step 5. You can see very high dose of ICS, LABA, LAMA, and also a LTRA, that's montelukast. He had documented sputum eosinophilia once. His specialist decided to maintain him on a low dose prednisone, that's 7.5 milligrams daily. Spirometry, pre-bead bronchodilator, 62% predicted, and FVC 78% predicted. HRCT normal, IgE low, blood eosinophil count, again, it's normal. So what do? We do a sputum study, which showed a total cell count of 9.9 million cells, which is normal, 60% neutrophils normal, 10% eosinophil, that's high eosinophilia, and an exhaled FeNO of 45, which is also high. So this patient is going to benefit from corticosteroids. And when we have reached the ceiling dose of corticosteroids, what do? We have to consider a biologic. What is that? Anti-IL-5, because this is the biologic which targets eosinophils. So there are 2 of them available, mepolizumab, benralizumab. Both are available in our country, and there is nothing to choose between these 2. You can give whichever one you think is going to work better. A 38-year-old non-smoker, asthma since teens, lots of unscheduled specialist visits, lots of admission in hospital, prednisolone courses monthly, Symbicort, that's again the combination inhaler, no ongoing exposure to any known trigger, HRCT normal, cardiac consultation non-contributory. What is the endotype of this patient? Upon doing these tests, we again end up with the sputum quantitative assay, where the total cell count is raised very much. Sputum has 88% neutrophils and 2% eosinophils. So this patient has a neutrophilic asthma, and when you have a neutrophilic asthma, the options available to you are give antibiotics. We have to give antibiotics to these patients, and then repeat the assay where we might end up showing up eosinophil counts in the airways. So this is data from our lab. What does it show? That we have a 64% patients who have eosinophilic type of asthma, and non-eosinophilic was the rest, remaining 36. Now this is in blood. When we did the sputum, see the ratios have all reversed. Eosinophil has gone down, neutrophil has gone up. There is a mixed pattern there, and 3% patients had postgranulocytic lesions. Now, why do we need to do that when we see that patients have already a raised blood eosinophil count? Because sputum versus blood is absolutely, we have no relationship between two others. You could have a low count with a high sputum, a high sputum with a low blood count. I'm done. So this is my last slide. So completing the talk today is, asthma is heterogeneous. We all realize that because there are several subtypes or endotypes or phenotypes of asthma. Knowledge of biomarkers and endotyping is required to prognosticate or predict the specific treatment strategies. And this is what personalized medicine is all about. Commonly used biomarkers are total and allergen specific IgE, eosinophil counts, sputum neutrophil counts, and a mechanistic approach aids in accurate endotyping and adopting the correct strategy. Thank you very much. I know I had to go through very fast, and the people might have not understood what I said completely, but then this is some new technology which needs to get into our brains and might take a little bit longer.
Thank you so much for your excellent talk on this topic, which, yes, as you said, it will need a little more time, quite exhaustive in that matter. If the House has any questions, please go ahead.
So what I want from everybody here is to understand that sputum quantitative assay is an important test. It should be done. It's quite easy to perform, provided you have the method correct. And once you have the correct endotype going on in your patients, then you know what to give which patient. And then empiric therapy for asthma is never going to happen.
Yes, thank you so much.
I'll request our chairpersons to give a memento to our speaker, Dr. Ongida Das Gupta. And I also request Dr. D.R. Das to give mementos to our chairpersons. So we move on to our next session, that is a cardiology session. Our speaker will be Dr. Ajay Gautam, and our chairpersons will be Dr. Basudev Bhattacharya and Dr. Man Singh. I'll request all of you to please come to the stage and take your seats. The topic will be ICD implantation, a rare case of a young boy.
Good afternoon. Dr. Ajay Gautam doesn't need any more introduction. He was one of the most prominent interventionists right now in the Eastern Railway. I think he's also in the Indian Railway as well. Now he's going to present one case who just admitted a couple of months before in our ICCU. And it's really interesting. I think you will get some interest over here. Please, Ajay, continue.
Thank you so much, Chairperson. Respected seniors, friends, we all know Advanced Cardiac Center, B.R. Singh Hospital, is providing excellent tertiary care level services to our railway beneficiary, not only the Eastern Railway, as well as nearby zones. So it has improved a lot, and now I am happy to share that we have most advanced equipment, and we are providing the most advanced treatment management, which only few of the hospital in Kolkata or even Eastern Zone can provide. So I have chosen this topic of implantable cardioverter defibrillator because now this is not an uncommon device therapy, and most of the other clinician of other specialty will come across with a person, with a patient with ICD in situ. So we must be aware of some basic about the ICD implantation. So I will be discussing about indications, implantation, and one very interesting case of young boy of just 21 year old. So whenever we try to treat a particular patient, we need some guidance. And for guidance and the decision making, which is important because we need to know which patient will get most benefit from which type of therapy. So this is one of the $1 million question, because from the very beginning, your first decision about a particular, I'm talking about this particular treatment device, if we decide from the very beginning which type of device is most important for a particular patient, it will have a great impact in his future and quality of life. Now, we always follow some guideline for the therapies. For us, because this nowadays everything is evidence based, and for us we follow usually American Heart Association ESC guidelines. So if we talk about the landmark ICD trials, the high risk heart failure or post MI or low ejection fraction patients, there was a study between antiarrhythmic drugs versus ICD, which was MADIT, MUST, MADIT 2, and SCD HEF trial. Now, if we talk about landmark trials of highest risk VTVF patient, antiarrhythmic drugs versus ICD, they were AVID, CIDS, and CASH trials. Now, we all know for students, PGTs, I would like to highlight, whenever we talk about a particular therapy, we need to get class of recommendation. So we all know class 1, class 2, class 2A indications, and also we must know the level of evidence, which is level A, B, and C. So whenever we start some therapy, we must take into consideration what is the class of recommendation. Now I will talk about indications. So broadly, I will divide this group in two parts. 1, LV dysfunction patient. 2, patients with a structural heart disease. So whenever a patient of LV dysfunction comes to us, we decide whether they have reduced ejection fraction or preserved ejection fraction. So in patients with reduced ejection fraction, it can be ischemia related, it can be non-ischemic related. So whenever there is a patient with 35% and below ejection fraction, we must consider this device therapy, which is very helpful. First and foremost, it saves life, 1. And 2, in long term, with antiarrhythmic drugs, quality of life also improves of particular patients. Now, these are class 2 indication. There are unexplained syncope with significant LV dysfunction, non-ischemic cardiomyopathy, patients with HCM, hypertrophic cardiomyopathy, which is very common, 1 in 500 cases, and ARVC, arrhythmogenic right ventricular cardiomyopathy, with risk factors of sudden cardiac death, patients of channelopathies, which is CPVT, Brugada syndrome, with syncope or VT while on beta blockers, patients with sustained ventricular tachycardia, patients with cardiac sarcoid, giant cell myocarditis, and Chagas disease. These all are indications in which we must consider ICD therapy for a particular patient. I would like to show about the implantation, how it is implanted. It's a short video.
If problems occur with your heart's electrical system, you may develop an abnormal, potentially life-threatening heartbeat called arrhythmia. Your doctor may want you to have an implantable cardioverter defibrillator, or ICD, to restore the heart's normal rhythm and prevent sudden cardiac death. During the procedure, your doctor will thread a small wire through a vein until it reaches your right ventricle. The wires continuously monitor the heart's rhythm. After verifying the wire is in the correct location and works properly, your doctor will attach the wire to the ICD generator. Then your doctor will insert the ICD device under the skin of your chest below the collarbone. The battery-powered ICD constantly monitors your heartbeat using a computer. If a life-threatening arrhythmia occurs, the ICD delivers an electrical shock to your heart, resetting your heartbeat back to normal. The ICD can also be programmed to pace the heart and restore its natural rhythm.
So this was just in short how the implantation is done, but it appears simple, but is much more complicated and very delicate, and it needs a long learning curve. So with this background, I would like to share one very important and unique, interesting case of young boy with ARVC and recurrent sustained VT. This 20-year boy had recurrent loss of consciousness with documented incessant VT, and it was very, very difficult to control with medications. This is a rare genetic disorder which is structural changes in heart muscle leading to foci of abnormal electrical rhythm which causes VT, leading to loss of consciousness and even death. He was admitted for long, and finally we implanted one ICD and it saved his life. Now see this young boy who was almost bedridden, out of school, and leading very compromised life, how this device has transformed his life. Recently, last Wednesday, he came to OPD. He touched my feet and said, "Sir, I am all right. I am doing my studies, and even I am playing cricket." So this is the huge impact on particular patient who was almost bedridden, and this device has transformed his life. Now he is active and quality of life is very good. So this was the MRI, and this is the boy who was device was implanted. He is doing well. With this background, I would like to say that you must, all the broad specialty and other specialty people must be aware of ICD, because it is very important whenever one particular patient comes with ICD implantation, the management from your end also has to be modified. I still remember a case of young girl, 17 years, Monica Khannal, I also remember the name. She had a very rare genetic cause, sawtooth cardiomyopathy. She underwent ICD implantation in 2017, and she is doing well till now. After some time, she had to get operated for GB stone. I still remember Dr. Dipanjan Pradhan operated her. So at particular that moment, I had to be present inside the OT because she was a case of recurrent VT with ICD implantation. So this device is very important for LV dysfunction patient and a structural heart disease patient, which saves lives and improves quality of life of the particular patient. Now, at the end, I would like to highlight the facilities at Advanced Cardiac Center, BR Singh Hospital, Eastern Railway. We do all the cardiac interventions, including right from angiography to angioplasty, peripheral angioplasty, complex angioplasty, pacemaker, ICD, CRT implantation, EP study, IVUS study, device closures, coil embolization, pericardiosynthesis. And from cardiac surgery point of view, we are doing CABG, valve replacement, ASD, VSD repairs, cardiac tumor surgery, minimal invasive surgeries. In the future prospect, we are planned for a TAVR, which is transcatheter aortic valve replacement, leadless pacemaker, thoracic and vascular surgery, pediatric cardiac surgery, and I am very hopeful that we will get a DNB super specialty course also at Advanced Cardiac Center. Thank you so much. Thank you for patient hearing. Thank you.
So thank you, Ajay. So these are the facilities right now, and I think one thing needs to be mentioned that we have got a root ablation as well. And we are using this thing for last this came around 2019. Out of 4 years, we have been using it. So any question from the audience? It is a classical case of right ventricular RSVT. And this MRI shows this is a patchy, hypo intrinsic zone within the apex of the right ventricle and the free wall of left ventricle as well. So actually, this cardiomyopathy involved both the ventricle, not only the right ventricle. So any question from anyone? Sir?
What is the life of this device and cost?
Sir, usually this device longevity depends upon the use, but approximately 10 to 12 is the usual lifespan of the PG, the pulse generator.
Any rejection cases?
No, sir. These devices are all there is no antigenicity of this device. Nothing. It's as good as pacemaker. It's a simple like pacemaker.
First 5 years you get full, and thereafter you get only half.
Thank you, Ajay. I'll request our chairpersons to give a memento to our speaker, Dr. Ajay Gautam. Now I will request Dr. Amrita Naha to give a memento to our chairperson, Dr. Man Singh. We will be moving on to our next session, that is on nephrology, diabetic kidney disease, New Horizon. The speaker is Dr. Krishna Das. She is the nephrologist of Garden Reach Hospital. And our chairpersons will be Dr. Jagadish Chandra and Dr. J.P. Rawat. I'll request all of you to please come to the stage and take your places.
Good evening. Dr. Krishna Das is the HOD of Medicine and looking after the nephrology unit at Central Hospital, Garden Reach. She will be presenting a topic. Next. Holistic cardiorenal metabolic care in type 2 diabetic mellitus, CKT management. Kindly go ahead.
Thank you, chairpersons. Good evening to my seniors and all the doctors present here. Today, as you see, the topic for discussion is holistic cardiorenal metabolic care in type 2 diabetes, and the focus is on optimum CKD management. As we all know that the national health policy goal is to ensure 25% decrease in the premature death in India by 2025. Here in the picture, you can see that in 1990, the CV cause of death of overall mortality was 15% in 1990, which has risen up to 28% in 2016. So all of us know that the CV death is the leading cause of death in India. 11.4% of the adult Indian population has type 2 diabetes, and the type 2 by 3 to 4 times. So to achieve the national health goal, we have to decrease the CV death, particularly in type 2 diabetes, and we need to control glycemic control in type 2 diabetes strictly. And also the CKD, you can say that the CKD is the end point of type 2 diabetes pandemic in our country. So as we see in diabetic patients who develop CKD, most of them die due to CV deaths, and very few of them reach to the ESKD or end stage renal disease or kidney failure. And the CKD patients, they have 6-fold more likely to die from CV causes and 13-fold from any other causes like sepsis before they reaching to ESRD. As we see in our OPD maximum of the times, the prototype of patients who are coming, like 50 years of female presenting with early CKD, diagnosed only 1 year back on routine checkup, and the patient remains asymptomatic. Having type 2 diabetes for 1 year, as we know that type 2 diabetic patients usually present with complications with hypertension and dyslipidemia. Here the patient is suffering from hypertension and dyslipidemia for 10 plus years. Her BP is 140/90, ankle brachial pressure index is 0.8, hemoglobin is 9, she is anemic, hemoglobin A1C is 7.9%, that is she is not achieving the target. In lipid profile also her LDL-C is raised. Urine albumin creatinine ratio showing 90 milligram of gram creatinine, which shows moderate grade of albuminuria. eGFR is 55 ml per minute per 1.73 meter square, and the decline is 4 ml in last year. ECG is also suggestive of myocardial ischemia. She is on current therapy with metformin, telmisartan, amlodipine, atorvastatin, etc. And what next? What next medication to be started in this patient to prevent the severe death? DHKD. DHKD is the syndrome, diabetes, hypertension, kidney disease. 50% of the patients with diabetes attending the medicine OPD in referral hospitals in India are shown to have CKD that remained previously undiagnosed. 8 out of every 9 such patients with diabetes also have hypertension. So syndromic diagnosis of DHKD is important for early detection, effective care, and prevention of premature death. As we all know, CKD is defined as abnormalities of kidney structure or function present for more than 3 months with implication for health. And CKD is classified based on causes, GFR category and albuminuria category. As you see in the picture, the green part showing that the stage 1 and stage 2, when the GFR is above 60 and the patient is not having microalbuminuria or macroalbuminuria or gross albuminuria. As the albuminuria increases and the GFR declines, the risk also increases, going up to high risk category in stage 5. So to prevent that, we need one medication which can prevent the premature death. So EMPA-REG outcome trial has shown that empagliflozin use significantly improves kidney outcome for patients across categories. It has also shown that it decreases 38% of the lower risk of progression to macroalbuminuria. This study has also shown that there is a 68% lower risk reduction of rapid decline in the kidney function in patients who are given empagliflozin compared to the placebo. Empagliflozin use leads to 30% lesser odds of worsening and 56% greater odds of improving categories category. Here you can see those patients who were given empagliflozin had decrease of worsening of the categories category by 23.3% compared to the placebo, which has 36.3%, and improvement of categories category by 27.1% in patients who were given empagliflozin. Empagliflozin use also showed improvement in the systolic blood pressure. Here, analysis of 1,819 patients with type 2 DM with established CVD and GFR less than 60 ml has shown that by 12 weeks, there is systolic blood pressure reduction by 4.5 to 4.8 millimeter of mercury, and there is significant increase in the hemoglobin level by 0.6 to 0.7% at 12 weeks. The cardiorenal outcome in patients with type 2 DM with atherosclerotic CVD, the ASCVD subgroup of CV outcome trials that has been used different SGLT2 inhibitors, EMPAREC outcome trial, Canvas program, declared TIMI58 and VertiCV, where empagliflozin, canagliflozin, and dapagliflozin, ertugliflozin was used respectively. So in this trial, we can see that EMPAREC outcome trial has shown significant risk reduction in the MACE events, that is the major adverse CV events, CV death, all-cause mortality, hospitalization for heart failure. It has also shown there is CKD outcome of 46% risk reduction. Other trials in Canvas trial also showed decrease in the MACE event and hospitalization for heart failure. And all these studies using this dapagliflozin and ertugliflozin also, there is a significant risk reduction in CKD outcome from 46% to 34%. So consistent with the kidney benefit, this trial, Veteran Affairs trial, where a cohort study of 379,033 patients with type 2 diabetes with GFR more than 30 ml was studied compared to empagliflozin against non-SGLT2 inhibitors, where they has observed for 3 years. It showed that there is a 32% decrease in the risk for MACE events, that is the major adverse kidney events, when empagliflozin was used. This study again showed that there is 32% decrease in the MACE events across the eGFR categories, even those who are having less than 30 ml eGFR. So latest ADA guideline, 2024 guideline, also recommends focusing on CRM, that is the cardiorenal metabolic care, recommends use of SGLT2 inhibitor in patients who are confirmed case of CKD, eGFR less than 60 ml and albuminuria by 3 milligram per millimole. It should go for repeat test to confirm the CKD and use ACE inhibitors and ARBs. After the use of ACE inhibitors and ARBs, if there is no improvement in the glycemic control, the ADA guidelines recommend use of SGLT2 inhibitors with primary evidence of decreasing the CKD progression. Even the patient's GFR to 20 ml per minute per meter square. And if there is still, and the SGLT2 inhibitors to be continued till the starting of dialysis or kidney transplantation. If there is any contraindication of use of SGLT2 inhibitor is there, then we can add on GLP-1 receptor analog, which also showed there is a proven benefit of CVD risk benefit along with the CKD progression decrease. So if HbA1c level target is not achieved with either of the SGLT2 inhibitor or GLP-1 receptor analog, then either of the two can be added or vice versa to achieve the tight glycemic control and thereby decreasing the CRM or CV risk and CKD risk. So ADA standard care 2024 summarizes the glucose lowering medication. Here we can see that all the metformin, SGLT2 inhibitor, GLP-1 receptor analogs, dual GIP and GLP-1 receptor analog all have high efficacy to very high efficacy. None of them causes hypoglycemia. Weight reduction is there, and CV benefit is maximum with potentially benefit with metformin, and maximum benefit is found with the SGLT2 inhibitor and also GLP-1 receptor analog. Heart failure, metformin is neutral, but benefit is seen with canagliflozin, dapagliflozin, and empagliflozin. GLP-1 receptor analog is neutral here, but progression of DKD, metformin is neutral, SGLT2 inhibitor has benefit, cana, dapa, and empa, not ertugliflozin, and GLP-1 receptor analog, there is benefit with dulaglutide, liraglutide, and semaglutide. Dual GIP and GLP-1 receptor analog, the study is ongoing with the use in CV and DKD. So to summarize, addition of an SGLT2 inhibitor to the prototype of type 2 diabetic patient with high CV risk and early CKD, it improves glycemic control, aids in the comprehensive risk factor control, along with standard care of hypertension, dyslipidemia, anemia, etc. Overall, it helps in the reducing the risk of cardiovascular mortality and mortality, including kidney disease progression. Thank you.
It has been a very nice presentation. Thank you, Doctor. Thank you very much. If there is any question, we can take.
Nursing hospital has just arrived after the inspection, and I think he has something to add. Please, Ranada, if you want to add something. You can multiply also.
You are welcome, please.
You can multiply also. We have a little bit of time.
I wanted to thank Krishna, who is a very, very dear friend of mine, though quite junior to me. And she is very ably managing a big nephrology load in Garden Ridge Hospital. And she maintains regular liaison with me. And I also maintain liaison with her. And it's a very compatible relationship. And she is also managing the medicine ward over there, Garden Ridge. So hats off to you, Krishna. Great. And the topic that you chose. But first of all, I would like to highlight one important point. Now, you have seen in this conference, the focus was on how would you prevent the progression of CKD. Because the first lecture was also based on that, and this is also almost based on that. So our target is to lessen the load of CKD. It doesn't get to reach the stage 5 or the when you require dialysis or transplantation. Towards that end, all the recent advances, all the work that are going on are based on that only. And Krishna's topic, I presume, was SGLT2 inhibitors, and that is all. And I have got a lot of friends in this audience and also outside also who have lost a lot of weight out of using SGLT2 inhibitor. So I am having very low diabetes. So I thought I would be using, but I was prevented by Sharmishta. So I thought that I would lose weight also. So thank you, Krishna.
Thank you, sir.
It was wonderful having you with us.
Thank you, Ranada. So I'll request our chairpersons to hand over a token of memento from our side to our speaker, Dr. Krishna Das. And I'll request Dr. Dr. Das to hand over the mementos to our respected chairpersons. Thank you, sir. So we move on to the last chapter of our scientific session. That is a very interesting chapter 2. That's a quiz on respiratory medicine. I'll request the participants, you know your groups, the teams, the 4 sofas in the front row. I'll ask you to occupy those 4 sofas. Team A, B, C, D. Like, sir, I will request, please, sir, if you can move to this end sofas, because the teams will be sitting in the first 4. You can sit in the side sofas. You know the teams are also written over here. From the Department of Medicine, we have Sneha Kumari and Abhishek Singh. From the Department of Pediatrics, we have Aisha Asadi and Sandeep Siv Puja. Department of Anesthesia, we have Kurtibas Sethi Naveen Kumar Valmiki. Department of GNO, we have Rupa Brahmo and Akanksha Agrawal. From surgery, we have Ijilal Ahmed and Jilam Basu. Ophthalmology, we have Bidushi Raichaudhuri, and pathology, we have Pranit Chiruda. So according to the team, as you can see over there, you sit team A, B, C, D, the four of us in the front line. The team names is written over there. Don't waste time, just sit. And the quiz master is Dr. Dr. Ongida Dasgupta. And Mondira will be the scorekeeper, assisted by Siddhartha. And we have prizes for all of you. I think you should sit like this, because otherwise you may not be able to see from that sofa. One of the persons missing. Team B. Akanksha, you have come. Akanksha to ache. Rupa has not come. So any other PGT? Well, Alka, you sit there. No, actually, if they sit there, they may not be able to see it. That is why I have kept it like that. No, you sit over here. No problem. You sit there.
Make sure you can see the projection.
You can see the projections properly?
So we have 4 teams, and the beauty of this quiz is going to be that although we are naming it a respiratory thing, you are from all different departments. So instead of taking it to be a difficult thing, I think you should take it to be a fun thing. So you will definitely get scores, first, second, third, and as many number of audiences are there, we are going to distribute so many number of prizes. Okay. The first round is based on images, pictures, and all that, questions. Each direct question has 10 points, and each pass question has 5. There are no negatives. Okay. এই টিমটা দেখতে পাচ্ছে? Can you see the projection?
All of you can see the projections, no?
Hello.
So question number 1. Identify this logo and name the organization. Team 1, no, it's the 8th question. Huh? No? So we pass on to team B.
Pass.
Team B is also pass? D knows, yeah, so what's the answer?
That's a logo of NMC.
Very good, indeed, yeah.
Dhanvantri.
Pass questions, 5 marks per bit. And for the audience, who is standing in the center?
Dhanvantri.
কে answer দিয়েছে? ঠিক আছে, all of you will get a prize, don't worry. Kandilalda has also answered. And you get a gift every time you answer it correctly. So you might take home 10 chocolates. Okay, so we've done with this question. Now, who are these 2 people? Eta hocche B, team B question. So think of countries which are very cold. Think of prizes that might be won by them. If you can't name the persons, you can tell us why you think they are famous. This is not an audience question. You will not get chocolates for that. So team B, no? Yes? Nobel Prize. Nobel Prize for? Medicine. You should have said respiratory medicine then. Huh? Absolutely right. So sir gets some prize. He's not part of the team, so he's part of the audience. সুজাতা দি নাকি ঠিক বলেছে? এই তাহলে you get another chocolate. না টিমও তো পারেনি করতে. So they developed the mRNA vaccine against COVID-19 and they are Nobel laureates. Question 3 goes to C. Name the organism. Be very careful because some viruses can look like this. The clue is look at the projections. GP120, GP41.
Influenza?
Influenza is not the right answer.
It's
Abhishek knows.
It's ma'am. So ma'am, HIV.
Very good. I think Abhishek deserves a clap. Very good. So that was 5 points for you. Okay. So what is this machine called? Now this is your direct question, Team D. Come on, you know it. There is a mask-like thing and there is a cylinder-like thing. The mask is fitting onto the cylinder and there is a reservoir-like thing on top, the blue thing. Any guesses? No? Okay, so Team A. Almost there. What?
Nebulization apparatus.
This is a nebulizer, right? But what sort of a nebulizer is this? Huh? Nah. She knows the answer. It's just not coming out. What are the types of nebulizers? Jet? Is this a jet nebulizer?
No, this is not a jet.
This is not a jet. So is it the other one?
Yes, the other one, but
It is the other one, but you don't know the name. Any of the teams? Pass Team B? Team C? So we open the question for the audience.
Spacer, madam, spacer.
Spacer, na? Bolo, bolo, bolo. Okay, I couldn't hear you. কি বলছে? তুমি একটু সামনে এসে বলো, আমি বুঝতে পারছি না কথাটা। No, unfortunately not. The audience, so let me give some more hint. I think you will be able to answer this. So there are 3 types of nebulizers. One is jet. This is not jet. Second is ultrasonic. This is not ultrasonic. Then what is the third one? It's called a wire mesh nebulizer. Okay. So you can read up wire mesh when you go home. Okay. So now who is this? It's a 5th question. We've done 4. Abar oder question. A.
Gregory.
Right. Gregory, whoever.
House. Dr. House from House.
House. Absolutely.
How is he related to the erosion divide?
ওরা full marks পাবে. But why is he known? What is he known for? There is a video. I'll play the video for you so that everybody can enjoy. ইরে এটা মাউসটা কোথায় গেল? এই এসছে। Be quiet and listen to this. You will enjoy it.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes, Anna, and you have to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Okay. So next question হচ্ছে B. So who is this person, the heroine, and what is the relevance? You ask the movie questions is right there on the tip of the tongue. Okay, so what is the relevance? Because you said it's Manushi Chiller, right? Yeah, so you should have said Dr. Manushi Chiller. 10 marks for them. Okay, team C, what's this? A blue colored suitcase. New, এটা কি? What is this? এটা কি team C? So you, does team C, do you want some hints?
Cold chain.
Cold chain. No?
Some oxygen concentrator.
Excellent, that's very good. And that's a pass question. Huh? না ডাইরেক্টর ছিল সি দের, এটা ডি পাস হলো, সি কোয়েশ্চেনটা পাস হলো ডি তে, কাজে ডি পাবে 5. ওকে। A, what is the preferred driving gas for nebulization in patients of COPD? So this is something, these are some things we have to know when we are treating patients with respiratory diseases in the ward. বলো team D না এটা? Team D direct, Abhishek. Go for it now.
Ma'am, air.
Air. Wow, good. I think everybody needs to know this, not only medicine, all the different departments. Please make a point to find out when you go to the ward what has been the driving pressure, driving gas when you are advising nebulization. I think you know the reason also. Okay. So back to team A. Artificial pneumothorax, phrenic nerve crush, thoracoplasty, plombage. These are some of the things that you would do in which disease? Now, of all the diseases that are common between across the specialties. It could be gynae, it could be medicine, anesthesia, opthal, patho, surgery. This disease is pan-specialty. It's a direct question to team A.
Negative marking? Sorry. TB?
Absolutely. Excellent. এত ভয়ে ভয়ে উত্তর দিচ্ছে। আচ্ছা, next team B direct question, what are these? Monoclonal antibody. So would you stick to that answer or do you want to change your mind?
The anti-tubercular.
Decide amongst yourself. Same team can't give two answers, right? So which one do you want to stick to?
Anti-tubercular.
Anti-tubercular.
Newer anti-tubercular drugs.
Good. 10 marks for team B. Okay, so this is another question. What sort of a device is this? This is an inhaler. So we are not expecting the answer to be an inhaler. It's the team C, na?
Metered dose inhaler. MDI.
No, we are not looking for that. It's a special type of MDI, metered dose inhalers.
Rota inhaler.
Mm-hmm.
There is no. Rota inhaler.
No. Anything else you want to say? No? Next, pass to team D.
Can you repeat the question? What sort
हाँ,
of question एक बार repeat करना?
कुछ नहीं. What sort of a device is this?
मैम pressurized metric dose inhaler.
उतना difficult नहीं है this. This is a dash actuated MDI.
Dose extension.
Mm-hmm. Simple. What do you do with your respiratory system? What is the primary thing you do? You breathe in, you breathe out, right? So when you are using this inhaler, you will breathe in, the medicine goes in. When you breathe out, it remains in the canister. So what is this then? A breath actuated MDI. So you wanted 5 marks? Team C. I think we'll give them 5 and everybody else has already given 5 to team C. ওদের ডাইরেক্ট কোয়েশ্চেন ছিল না? আচ্ছা. This is a very interesting question. Where in the world can you see things like this?
Havra Bridge.
Huh?
Havra Bridge.
Howrah?
Bridge.
Bridge. Very good. So I think they deserve a clap.
No, road.
Okay, so as when the scores have to be added up. In the meantime, where do you find a similar person here? A person we know. This is for the audience. This is not for the part. On the dais. কি বলছে? Oh, okay. So you mean it's me? No, not at all. Which one?
Ma'am, Shorvani ma'am.
Which one? There are 4
Shorvani
girls.
ma'am.
Right side এ আপে. Right side মানে কোনটা?
Right
আমার
hand
right, তোমার left. এইদিকে? এইদিকে আপ। শর্মিষ্ঠা দি বলছে না। ওইটা ঠিক। ওইটাই, very good. আচ্ছা, and who's this? Okay, so what is the total score up till now? জোরে বল। Hello. Now we move on to the second round. অশোকদা পুরো এক্সাইটেড হয়ে দাঁড়িয়ে পড়েছে। Okay, this is a very interesting X-ray. What is the diagnosis? ওটা total করে দিয়ে দে না।
Total করে দিয়ে এবার ওটার উপর add করতে হবে।
What is this diagnosis? এটা কার? টিম A নাকি we'll start reverse? টিম D থেকে start করব। What do you want? এদের থেকে করব? সেম অর্ডারে যাব না ওই দিক থেকে করব? উল্টো দিকে। So this is question for team D, direct one. You think of this X-ray and try and find out where the pathology is. Which lung is affected more? Right or lung left bolo? Right na left? Right lung is diseased.
Diseased.
So what has happened to the left lung?
Left mid, the mediastinum is shifted to the right side.
Mediastinum is shifted to the right.
Left side is
Hyperinflated.
No, it is not hyperinflated. You can see some metallic strings sort of. There has been a operation in this patient, Some form of an OT. Acha, I think we'll pass now. Enough number of clues. D এর পরে A. ওদিক থেকে আসবো? আচ্ছা, তাহলে টিম সি বলো। নো নেগেটিভ আর নেগেটিভ আর দরকার নেই। টিম ডি হলো না, সি হলো না, বি। বি হ্যাঁ, টিম এ। But this moves on to the audience. The question is, what is the diagnosis, and not whose lung this is. So,
Ma'am, right lung atelectasis.
কে ডায়াগনোসিস করতো? কি না, পসিবলি তো নয়। কি আছে ডান দিকে, বাঁ দিকের লাংটা লুকস নর্মাল, তাই তো? এবারে একদিকের লাংটা ছোট, ওরকম একটা শ্রিঙ্ক করে গেছে, ফাইব্রোসিস। একদিকের লাংটা ইজ নর্মাল। সো হোয়াট ইজ ইট? খুব সোজা, সব বলে দিয়েছি। না,
Right lung TB.
no, right lung what?
TB, tuberculosis.
No.
Collapse.
This is fibrosis, all right? So most of the time, if you have fibrosis of this extent, you're also expected to have some fibrosis on the other lung. So how come that lung does not have any fibrosis? হ্যাঁ, এই যে কে বলছে এটা? I've heard the correct thing. কি আমি শুনতে পেয়েছি, কেউ বলছিল লাং ট্রান্সপ্লান্ট করে। এটা কে বলেছে? কোথায়? হাত দেখতে পাচ্ছি। রিনাদি, ভেরি গুড, বাহ। রিনাদি, ক্ল্যাপ টু ইউ। Lung transplant indeed. এইটা তো মেডিসিনের পেটেন্ট কোয়েশ্চেন, যেটা সবাই বলতে পারবে। But I would like the other disciplines also to know about this. This is the direct question to B. B na C? C, acha, ঠিক আছে, বলো। What is your diagnosis? You can see a face with some rashes, pinched up nose, oral cavity is getting smaller. You look at the chest X-ray, there is bilateral fibrosis on the basal and peripheral areas. C, না এটা কি B এর কোয়েশ্চেন না? না, C এর কোয়েশ্চেন। C তে অ্যানাস্থেশিয়া কি আছে নাকি? হ্যাঁ বলো।
SLE?
Almost scleroderma. Yes, এটা কে বলেছে মন্দিরে? না আগে বললে হবে কেন? এটা তো ওরা না পারলে তারপরে পাস হওয়ার কথা।
Systemic sclerosis.
Systemic sclerosis. না, ও তো শুনে বলেছে আর কি এই কোয়েশ্চেনটা। ঠিক আছে, we'll give you 5 marks, okay? আচ্ছা, a bit difficult, maybe medicine people will be able to answer. What is the investigation? ব্রেনে কি একটা হয়েছে জানি, এবং সেটা কি হয়েছে বোঝার জন্য we have done this test. এটা বি না? 3 তো বি। বলো। MR spectroscopy. Very good. Now this is very easy. What is the investigation?
This is a whole body PET scan.
Very good. Achha, this is the CT brain of a 56-year-old male who presented with headache and vomiting. This is a very easy one, given the history. It's a question 5 মানে আবার দিতে ফিরে গেলাম। বলো।
Is it subarachnoid hemorrhage?
Excellent. Very good. Oh my God, who is this? পিছনে মাইসেলফ তো কাঞ্জিলালদা হাত তুলেছে। কাঞ্জিলালদা বলুন, হেডলেসটা ঠিক আছে, তাহলে সুব্রতা ইউ ক্যান টেক অল দ্য চকলেটস। হেডলেস, হোয়াট ইজ দ্য সাইন? সার্জারি পিপল। এটা কার? ডায়েট কোয়েশ্চেন টু এ।
Mercedes Benz sign.
হ্যাঁ, আগে ঠিক কোয়েশ্চেন টু এ। মার্সিডিজ বেঞ্জ সাইন। Very good. So a little bit more about the Mercedes Benz sign. Where is it found? How is it made?
Due to air trapping within the
Within the what?
within the gallbladder stone.
Ball?
Within
ঠিক
the
আছে।
stone.
Within the stone. Okay. কি পয়েন্টস পাবে তো? পাবে তো? ঠিক আছে। ওদের 10। কে? ওরই তো কোয়েশ্চেন ছিল। আচ্ছা। Question 7. What do you see here? Question 7 মানে হচ্ছে 4 4 কাদের হবে? সি হবে। এই দেখো, এটা ডি। ডি, আচ্ছা, অভিষেক অ্যান্ড টিম। আরে আমি তো গুলিয়ে যাবেই এতগুলো। এবার ট্রুথফুলি বলতো, না এটা বোধহয় ভুল হয়েছে ওদের, ও বলতে পারিনি, ও একটা টার্নের আগেই বলে ফেলেছে। It doesn't matter, you will all get prizes. So what do you see here? So you don't see movies? You don't take things while you are seeing movies?
Popcorn means in vertebra.
Vertebra?
Popcorn calcification.
Popcorn, but not vertebra, beside that.
Lungs.
Good. So how many movies have you seen in the last week? Nay? So I think we'll leave you one day to go and see a movie and take some popcorn. 8. ওর হয়ে গেল, ওদের ডাইরেক্টলি ওরা পেয়েছে, এবারে ওদের এ ডাইরেক্ট কোয়েশ্চেন। হ্যাঁ, 8 নম্বর মানে লাস্ট টিমটা, তো ওদিক থেকে স্টার্ট করেছিলাম। এ হবে। Okay, we can give you an extra question if you want. What is this medicine you should say? 8 মানে হচ্ছে এ হবে, ডি সি বি হলো, তাহলে এ। ও জানে কিন্তু বলতে পারছে। এটা কি হয়েছে? What has happened? The vessel has become bigger.
Aneurysm.
Aneurysm শুধু বললে হবে না। On the MR scan, what is happening? The arteries are, the blood.
Aortic dissection.
ঠিক আছে, রাইট। আরেকটা কি দুটো টিম বললো আনসার? আরেকটা কে বললো ডিসেকশন? একে 5, ওকে 5। 5 তো ওখানে হাফ হাফ হলো, 10 পাওয়ার কথা ছিল, ও অর্ধেক উত্তর। আচ্ছা, now this is purely audience questions. Who is this? Audience question. এটাতে কোনো হিন্ট দেওয়া যাবে না, যারা চেনে বহুদিন ধরে। না, শুভ্রদা একা বললে হবে না। শর্মিষ্ঠা দি, এটা অনেকেই জানে। হয়নি, শুভ্রদা হয়নি। রানা স্যার, দ্য রেজিং বুল। রানাদা ঠিক হ্যায়। শুভ্রদার সঞ্চিতা দিয়ে দিকে দাঁড়িয়ে আছে, বাট শুভ্রদা ইজ মানে গেটিং ম্যারিড টু সামবডি এলস। আর দুজনের মাঝে যেই ভদ্রলোক আছেন, গুড। এবারে গোল করা কার মুখ? না, লাস্টলি থ্যাংক ইউ ভেরি মাচ। সো নাম্বারটা বলো।
দাঁড়াও, ওদের প্রাইজ দেওয়া হবে, চলে আসবে। এই তো এদের দিয়ে দিতে হবে, বাচ্চাগুলোকে সবাইকে প্রাইজ দিতে হবে, কাঞ্জিদাকে দিতে হবে, কাঞ্জিদা প্রাইজ দিতে হবে না, এতগুলো ছেলে গিয়েছে। বিপ্লব হয় না, করোনা চলে। এই সবাই হাতে হাতে দিয়ে